Hi everyone, and very good morning to all of you. I hope that you all are fine and doing the best of your health. Guys, first of all, warm wishes from the entire DBMCI team. It's a penultimate day for your exams. I'm very sure you'll do well. And just for the last minute revision, what we have planned is to ensure that we will try to revise as much as possible on the last day. The two things you can do, you can revise yourself or you can revise with us. Without wasting any time for you, I would ensure that we have to do the most important points here in the FMG. So in this 1 hour of session that I would be taking, I would be covering most of the important PYQs. I have taken them over the last 5 years, picked up most of them, and then I'll discuss this. And it's not only the question that I'll discuss, okay? A lot of things apart from the discussion of the questions, I discuss some important points also. So because I've seen last 5 years of question, the 5 into 2 is 10 sessions of FMG, what I have done is I will try to tell you the most important topics or points. I'll not say topics actually, it's very late to say the topics. So all the important points that you must be taking care of while you are going for the exam tomorrow. So I wish you all the best. Yes, hi Sheikh, hi Gautam, hi Shiva. Hi Praveen. Praveen asking Praveen that how many hour of session? My session will be around for 1 hour, and then subsequently there will be an OBG session, post ops gynae. There will be a session of medicine and surgery. Okay. Hi Yashwant, Siaj. Hi Pinky. Hi Yashwant and hi Dr. Sheikh. So are you all ready? And we can start the session. So it is all interactive session. It's all a PYQ. Tomorrow's exams will not discuss a lot of topics in detail. I'll just need your answers, and in case you have any doubts, ekdam feel free to ask me. Whatever doubt you have, just feel free to ask me ki, sir, please explain this part or that part. I will be more than happy to explain you, because the time is very crucial right now for you. You cannot take out the books or textbooks right now. The only thing you want is just tell the most highlighting points from our point. So okay, some other members have also joined us. Hi, Rahul, Vishnu, Devdutt, and Pratyusha. Hi. So start karte hain, and let's start with the question 1 here. And I want all of you to tell the answer. Diabetic patient, pigmentation of skin over the arms, was suffering from micronodulocirrhosis. On biopsy, iron deposit is seen. What is the diagnosis? So yes, the answer is very good. The answer is hemochromatosis. Acha. So in this, what all the question can be asked? Number one, in hemochromatosis, it is usually due to increase in iron deposition, which can lead to diabetes mellitus. It can lead to cirrhosis and can lead to pigmentation. Okay, that's the three things you expect that. In alpha 1 antitrypsin deficiency, what you expect is number one, emphysema history. Along with that, there will be history of either cirrhosis, or there can be history of any hepatocellular carcinoma, or can be just a hepatitis history. And along with that, we see what pass positive globules where in the liver. Okay. In Wilson disease क्या मिलेगा? You will have a ATP7B deficiency, ATP7 gene mutation, and there is a increase in the copper deposition, right? It happens due to celluloplasmin deficiency. Okay. In the autoimmune hepatitis, now can any of you tell me, फटाफट बताना, ठीक है ना, in what is the antibody you see in autoimmune hepatitis? Okay, don't google, आंसर है तो बताओ, नहीं पता बताओ, सर नहीं पता बता दो, ठीक है? So in this one, what you get is, देखो, there is type 1 and there's type 2 autoimmune hepatitis. And how to remember, I'll tell you. In type 2, there is 2 organ antibody. It is anti-LKM antibody, liver, kidney, microsomal antibody. It's LKM antibody. And in type 1, all the other antibodies that you can see, that is basically the ANA. It can be smooth muscle antibody. ठीक है ना? It can be smooth muscle antibody. We can call this smooth muscle. It can be SLA antibody and can be AMA antibody. What is AMA? It is mitochondrial antibody. So smooth muscle antibody, SLA क्या है? Soluble liver antigen antibody, and ANA is the anti-nuclear antibody. But कैसे याद रखना है वो देखो. For type 2, the 2, the liver kidney, LK. Okay, liver kidney antibodies. ठीक है? चलो आगे बढ़े. Let's move forward. चलो, most abundant plasma protein. फटाफट बताना है. We don't have time for this. Look at the question, put the answer. Answer is Very good. The answer is albumin. Acha, what all question can be asked on this topic? This they can be asking you about the serum electrophoresis. देखो, in serum electrophoresis, I hope you all know there's something called as A is to G ratio. पता है ना ये? It is 1.5 is to 1 as a normal one. So if it is 1.5 is to 1, so what is the maximum protein? It is albumin, right? What they can ask you is what is the constituent of a देखो, and about the globulin, this G is called globulins, and what is the globulin here? It is, do you know the normal electrophoresis pattern, right? कैसे होता है देख लो एक बार. So suppose I make here albumin, there is the albumin peak here, albumin peak, it is what? Alpha 1, alpha 2, beta and a gamma globulin. ऐसे होता है ना? Okay, it is alpha 1, alpha 2, beta and a gamma, and all of these are what? Globulins. What they can ask you is what is the constituent of alpha 1 globulin, and what is it? It is alpha 1 antitrypsin, it is HDL, it is the TGF, and it is also the alpha 1 lipoprotein. About the alpha 2, it is haptoglobin, it can be ceruloplasmin, or can be alpha 2 macroglobulins. Okay, the beta 1, it can be transferrin and can be beta lipoproteins, and gamma is basically the antibodies. And which is the most maximum concentration of antibody? Tell me which is the maximum concentration antibody. फटाफट बताओ. Let's come back to this. So this globulin, which is what? It is alpha 1, alpha 2, beta and gamma globulin. Gamma is the what? It's the antibody. Now fibrinogen, it is what? It's an acute phase reactant, and this is responsible for increase in ESR. Okay, the fibrinogen is actually the particle which is increasing the ESR, and Burns-Jones proteins, you all know, is in multiple myeloma. They can ask you what is the constituent of the Burns-Jones proteins. What is the constituent of a Burns-Jones protein? Batao. Yes, it is basically the light chain. Okay, it can be light chain, which can be kappa or lambda. Kappa हो सकता है and lambda हो सकता है. Yes, I got the answer from Capgras syndrome. भाई क्या नाम रखे हो? It is IgG. Very good. So the most maximum antibody here is IgG. That is the most maximum prominent antibody in concentration in the blood. Achha, one more thing they can ask you is what is the basic function of IgG and what is the basic function of IgM. देखो IgG, they can ask you IgG का basic function क्या होता है? Phagocytosis. Okay, and IgM का main function in the immune system is what? It is complement fixation. Okay, complement fixation. So phagocytosis for IgG and complement fixation for IgM. Let's move ahead, all of you. Chalo, fatafat. And no one will leave this session right now. You all have this exam like this. Give an exam with me. I'll not waste a single minute from here onwards. Test not done during blood transfusion. Batao. Not done. Yes, Hep A is not done. So they can ask you what are the tests they can do in blood transfusion. Yes, it is apart from these three. Plus they do what? They do syphilis. Okay, syphilis. And along with that they do what? Malaria. Two more tests they do, and Hep A is not done. Apart from this, what they can ask you in blood transfusion. Fatafat sun lo meri baat, and please share this video to maximum friends. Ask them to just attend this session. This 1 hour session and from pathology, and the multiple session coming up later on also. Just share this to multiple of your friends and ask them to come and attend this class. Dekho, what they can ask you in the blood transfusion. Whatever they can ask you, they'll be telling you. Dekho, two things can confuse you, and that is first of all, dekho, PRBC hota hai, FFP hota hai, it is the cryoprecipitate, and there is platelets. ठीक है? Acha. Now, acha, how many questions we can expect from this? I'll discuss so many things now. It will cover medicine also as well as pathology, a lot of things extra. बस सुन लो मेरी बात ध्यान से. देखो. Now for a PRBC, the basic storage temperature, that is what they can ask you. Okay, and the shelf life. The two things they can ask. Okay, shelf life. So for a packed RBC, the storage temperature is 2 to 6 degrees Celsius. For FFP it is -20. You can also use -40. For cryoprecipitate, -80 is the usual temperature, and for plated, 20 to 24 degrees Celsius room temperature is the main one. Shelf life for PRBC is 21 days or 35 days or 42 days. So why is the difference there? 21 days if you are collecting in acid citrate dextrose, 35 days for CPDA, and if it is SAGM with CPDA, it is 42 days. FFP and cryo can be stored for 1 year, and 5 days is the usual uh, thing that is for platelets. ठीक है? अच्छा, apart from these things, what they can also ask you in blood transfusion is about the cryoprecipitate. देखो, FFP का जो main use होता है ना, main use, that is DIC. Okay, the main use in DIC. Cryoprecipitates, the main use in cryoprecipitate क्या होता है बताओ? The cryoprecipitate main use is what? Yes, because it has factor 8 plus VWF plus fibrinogen. So it is useful in what? Hemophilia A. It is useful in von Willebrand disease and if a patient has hypofibrinogenemia. Okay, this is how and where it is actually useful. So this table is very important. अच्छा, इसके अलावा they can ask you the complication of massive blood transfusion. फटाफट सुन लो. देखो, मैसिव ब्लड ट्रांसफ्यूजन में व्हाट यू मस्ट नो इज दैट इट इज गिविंग द इक्वल अमाउंट ऑफ पेशेंट ब्लड वॉल्यूम. ओके, इक्वल वॉल्यूम ऑफ ब्लड इन 24 hours or 50% volume in 3 hours. That's a basic definition of massive blood transfusion. So if you give such a high amount of blood, it can lead to some complications like I just listed down. It is hypothermia. Okay, it can be hyperkalemia, it can be hypocalcemia, it can be metabolic acidosis as well as alkalosis. Okay, and it can lead to dilutional coagulopathies. Okay, these are the basic thing you can expect in the massive blood transfusion. Okay, let's move to next question. Chalo, myasthenia gravis is what type of hypersensitivity reaction? Batao. Myasthenia gravis is type 2. Very good. Ab dekho, what they can ask you is what are the other examples of these type of hypersensitivity. देखो, तो when a question like this is asked, type 1 में the few A से क्या क्या है? Allergy. Okay, there is allergy, there is asthma, there is atopy, and there is anaphylaxis. Okay, apart from this, it is Cassoni's test, and it is the Cassoni's test. Along with that, it can be urticaria. Even hay fever is there. Okay, hay fever. Now, apart the type 2, type 2 ko we should remember in a different format. Type 2, it is of 3 types, right? Those which cause inflammation, there are 4 examples. And what are those? इसको नीचे लिखता हूँ मैं. Goodpasture. Okay, Goodpasture syndrome. It can be Vasculitis, right? It can be pemphigus and can be rheumatic carditis. ठीक है? Along with that, those which are bloodborne, anything which is bloodborne, how to remember? देखो, type 2 है ना, 2, तो 2 में B आता है ना, B, and in the bloodborne it can be what? AIHA, autoimmune hemolytic anemia. What else it can be bolo? It can be ITP. So any bloodborne is type 2. Okay, and yes, blood transfusion reaction, very good, that is also is type 2. Acha, apart from this, all those which can activate or inhibit receptors, example में myasthenia gravis, or it can be Graves disease, or it can be pernicious anemia. So all these are also type 2. Type 3 has a simple mnemonic of SHARP, where S is SLE and serum sickness. Okay, S is SLE and serum sickness. H is Henoch, short in purpura. A is Arthur's reaction. R is rheumatoid arthritis, and P is polyarthritis nodosa. Along with that, all type of glomerulonephritis also is type 3. Type 4 में all the disease which can lead to granuloma is actually type 4. And apart from granuloma, it can, any disease can lead to granuloma is type 4. And apart from any granuloma, what are the other examples? It can be multiple sclerosis. Okay, it can be type 1 diabetes. Okay, type 1 diabetes, and it can be lepra reaction. Which type? Type 1, because lepra reaction type 2 is type 3 hypersensitivity reaction. And how to remember this last point? So if you add the lepra reaction with the hypersensitivity, your total should come as 5. मतलब देखो, type 1 is type 4, and how to remember? देखो, 4 plus 1 is also 5, and 3 plus 2 is also 5. So in case of any confusion, you can also remember this. ठीक है? अच्छा, these are all the basic things that you must remember in type 1, 2, 3 and 4. याद हो गया ये? अच्छा, let's move to next question now. बताओ, cell responsible for graft rejection. Look at the question carefully. बताओ, all of you. ठीक है, आंसर इज बोथ बी एंड टी सेल्स, आंसर इज बोथ बी एंड टी सेल्स, ठीक है। अच्छा, why it is that? Because the question they can ask you is the three types of graft rejection. It can be hyper acute, ठीक है, it can be acute, it can be chronic, ठीक है। अच्छा, first of all, the time in which they can occur. The hyper acute occurs within minutes to hours, acute occurs within days to some weeks, and months to years is the chronic, ठीक है। अच्छा, then they can ask you what is the mechanism behind it. So if any rejection occurs due to a preformed antibodies, preformed antibody, ये है hyper acute, ठीक है। If it is due to post transplant antibody or T cells, it is acute. And if it is post TX transplant T cell mediated, it is chronic, it is chronic, ठीक है ना, क्लियर हो गया। अच्छा, नाउ दे कैन आस्क यू इन दिस क्वेश्चन व्हाट इज द हाइपर सेंसिटिविटी रिएक्शन। सो प्री फॉर्म्ड है, इट इज एंटीबॉडी है तो टाइप 2, ओके, दिस एंटीबॉडीज अगेन टाइप 2 है, टी सेल है तो टाइप 4 होगा, ओके, एंड दिस श्योरली इज टाइप 4 हाइपर सेंसिटिविटी, दिस एक्चुअली टाइप 4 हाइपर सेंसिटिविटी, ठीक है ना, ये क्लियर हुआ। अच्छा, अपार्ट फ्रॉम दिस what also remains a very important point here is when we talk about these all rejection, they can ask you that among these three, so when you see a graft being transplanted, what is the most important HLA should be matched. So matching of HLA, at least you must match HLA 1A, 1B and 2DR. The three HLA you must match at least, okay. Which organ will require no matching? Cornea, cornea, ठीक है ना। Which organ will require maximum matching? Our answer is bone marrow, याद रखना, 0% for cornea and 100% is required for the transplantation for, yes, for bone marrow. Clear cut हो गया। चलो, next question. A 10-year-old child came to the clinic and mother gave a history of repeated blood transfusion over the past. She now worried about her son as earlier he was maintaining good grades in class, but now for few months grades are going down and remains lethargic. Blood investigation shows crescent shaped RBCs. ऐसा crescent मतलब moon की तरह ऐसे. What is this RBC called? Yes, dear, it's called as sickle RBCs. And why lethargic? Because now the patient has now anemia also. So with a sickle cell patient, what is the next step of management? What is the next step of management? Bolo, answer this question. They have been given repeated blood transfusion. Don't worry about the repeated blood transfusion. They are being giving this. So what is the answer, guys? I'm still waiting. The best answer for such questions is IV hydration with oxygenation. Remember, okay, the first step in management of any such finding is hydration, okay, and along with oxygenation. That's the best step. So the answer is C, not B. Answer is no. Right now you can't observe it. Just this patient already is lethargic. You must give hydration and oxygenation because it will decrease what? It will decrease risk of sickling crisis. Okay, so once there is any issue in sickle cell anemia, do not just take it idly. You must give IV hydration just to decrease the risk of sickling crisis. Acha, if this is not in the option, then what you would have taken? Along with that, you must give some agents which can increase the amount of HbF, and that is hydroxyurea. Hydroxyurea. You can also give crizanlizumab, which is a PCAM antibody. Okay, it's a PCAM antibody. Along with that, you may give voxelotor, which is basically increasing the oxygen affinity, and you can give L-glutamine. Okay, now these all will decrease the crisis. All of them will reduce what? The sickling crisis. Okay, sickling crisis. The high risk of infection is surely there, but you know what is the next step? Next step is to always decrease a immediate crisis episodes. that is which is an emergency which can happen, and therefore next step should not be antibiotic, next step should be a IV hydration fluids. Okay. Acha. If the answer is what is the best treatment for sickle anemia, it is hematopoietic stem cell transplantation. That's the best step. Okay. Acha. That's the best thing. Chalo. Next question batao. A 10-year-old has lower abdominal pain, rashes over the lower extremities, and pain in the joints. What do you think it is? Abdominal pain hai, rashes hai, and there is joint pain. The whole thing combined to form, yes, Henoch-Schönlein purpura, HSP. देवरुण तुमको समझ में आया ना कि why not antibiotic? बताओ, इसका आंसर is HSP. अच्छा, what they can ask you is HSP is obviously these finding, and HSP में रहना history is always 1 to 2 days after an episode of pharyngitis or sore throat. ठीक है? That's basically the finding of HSP. Along with that, HSP also has thrombocytosis, not thrombocytopenia. They have thrombocytosis, not thrombocytopenia. Okay? अच्छा. Alport syndrome में क्या क्या मिलेगा? Alport syndrome is a triad of 3 things. Yes, it is gross hematuria. It's gross hematuria, pehla. Second, it is what? Yes, it is sensory neural hearing loss. And third, it's a triad of the anterior dislocation of lens, anterior lenticonus. ठीक है? अच्छा, थर्ड इज टाकायासु आर्थराइटिस. अब इसमें क्या मिलेगा? देखो, टाकायासु आर्थराइटिस and temporal arteries are the name for giant cell arteritis, GCA. Now, how to differentiate in simple words? How to differentiate Takayasu with GCA? उल्टा करता हूँ. How to differentiate? Sorry. GCA with Takayasu arteritis. One of the most important thing you must look is the age. So, if the age is above 50, it is GCA. Less than 50 is Takayasu. That's the one important finding. Clinically, usually a GCA will have a history of the head area. Usually, matlab it is agar patient is seeing a history of headache, okay, headache and history of headache, decreased vision, okay, plus there is jaw claudication along with the backache, you must think about GCA. Okay. In Takayasu, the history can be of headache, decreased vision, but the most important finding usually is a hand claudication. Okay. And along with that, you will get a decreased or feeble radial pulse. Decreased or feeble radial pulse. And this hence is called as pulseless disease. Pulseless disease. This finding will help you differentiate a GCA versus Takayasu. Clear hai? Acha, let's move to next part. Macrocytic anemia will be seen in about these 4. Dekho, when the question is on microcytic anemia, your options are Sita. Sita matlab sideroblastic anemia, iron deficiency anemia, thalassemia, and it can be anemia of chronic disease. Okay, that's a microcytic anemia. So in this case, all these will show you microcytic. Chronic liver disease will show you a macrocytic anemia. Okay, so what they can ask you in this question is what and how will differentiate these 3 causes. How differentiate these 3, and this question is surely going to come. Okay, someone asked me, sir, इसमें कितना expected question है? Iron deficiency anemia से question surely expected है, no doubt about it. ठीक है, अब सुनो, देखो. So you have to do serum iron studies, and for this what you must do is first of all write serum iron test name. It can be ferritin, okay, it can be percentage transferrin saturation, and can be total iron binding capacity. ठीक है, अब देखो, I'm writing IDA, इसके बगल में sideroblastic anemia, and then writing ACD. To remember the table, remember first a rule says that ferritin is inversely proportional to TIBC. ये rule है. Rule कहता है ferritin and TIBC are inversely proportional. ठीक है, अच्छा. Now see, if a patient has iron deficiency anemia, obviously यार iron deficiency है तो serum iron should be low, correct? Ferritin should also be low. Saturation should also be low. As a rule, ferritin and TIBC is opposite, so this must be high. Now, sideroblastic anemia is actually what? It's an opposite of IDA. It's an iron overloading. So this one is high, it's also high, it's also high, this becomes low. ये clear हो गया दोनों? अच्छा, ACD. Now, in ACD, why do we learn this table along with iron deficiency anemia? Because the problem occurs, it also has low iron and low saturation. That's the problem of ACD. But if you look at the ferritin is exactly opposite in the ACD. What happens in ACD is the patient has high ferritin, and as a rule I mentioned there, देखो, it should be low TIBC. ठीक है? That is how you must remember the entire table. It will never confuse you. This one and this one should go opposite as a rule. It'll really make the table very, very significantly easy. Okay, and what else they can ask you? They can ask you the ferritin is the most sensitive test. That's one question they also have asked you multiple times. Okay, along with that, in iron deficiency anemia, you also get what? Pencil cells. Pencil cells. Okay, acha. And what is the treatment for sideroblastic anemia? B6 is a treatment. Okay, B6 is the main treatment. चलो आगे बढ़ते हैं. A patient suffering from iron deficiency anemia, what stain is used to confirm the iron stores? Yes, the answer is Prussian blue. Okay. Other options. Alice and red is done for calcium. It can also use von Cossa. ये वाला calcium. Mithrin blue along with the eosin. This is basically seen as called as Romanowski stain. Example, Leishman and Jimsa. These both are the Romanowski stains. Clear what? Acha. Apart from this, they can also ask you the other stains, especially for, they can ask you the stain for lipids, okay? Glycogen. They can ask you for melanin, okay? They can ask you for lipofuscin, and they can ask you stains for proteins, okay? Dekho. For lipid, it is oil red O and Sudan black B. Remember, oil red O is used in a fresh tissue. Fresh tissue matlab a tissue which is not fixed in formalin. For this you use the oil red O. The glycogen is pass positive and they are diastase sensitive. Okay? Acha, if the same question is pass positive, however it is diastase not sensitive, but it is mentioning this diastase is resistant. Okay, then the answer is proteins. अच्छा, melanin के लिए होता है Mason Fontana. Okay, now if the question is Mason's trichrome, ये तो Fontana है ना? Mason trichrome कहाँ पड़ा है? All of you tell me. Mason trichrome. Lipofuscin के लिए Sudan black. Sudan black. Okay, and you need to tell me what is the where do we use Mason's trichrome? Trichrome कहाँ use करते हैं? Yes, trichrome is used in collagen staining. Very good. So if the question is Mason's trichrome, then it is for collagen. Along with that, a previous question they have asked you is what we use for basophil or mast cells? It is toluidine blue. Okay, toluidine blue is used for mast cells. नहीं, लाइपोफुस्किन लिपिड रेड ओ से नहीं होगा, सिर्फ सुडान ब्लैक से होगा. ठीक है, प्रत्युषा प्लीज करेक्ट दिस. चलो नेक्स्ट वन. अ फीमेल वेंट फॉर कैंपिंग विद हर फ्रेंड्स. शी हैज अ बी स्टिंग. जैसे दिखा बी स्टिंग, दिमाग में क्या आना चाहिए? टाइप 1 हाइपरसेंसिटिव रिएक्शन, राइट? एंड शी हैज दिस एनाफिलैक्सिस रिएक्शन इन विच शी हैज एडिमा, रेडनेस ऑन द फेस, and there is breathing difficulty. So what is the mechanism responsible? It is IgE mediated because it is type 1 hypersensitivity. Cytotoxic is type 4. Cell mediated is also is type 4. Okay? Immune complex is type 3. And all the examples we already have mentioned above. चलो आगे बढ़ते हैं. A couple is trying to conceive for the past 2 years. Okay? After unsuccessful trials, the patient has revealed 2 things. What all? Gynecomastia is there, scanned pubic hair, and atrophied testis. Tell me, what is the diagnosis? फटाफट बताओ. Comment on diagnosis. Three things are there. Yes, the answer is Klinefelter syndrome. Okay, it is 47XXY. तो सर याद कैसे करें? ऐसा एक ट्रिक बता दो कि आई कैन रिमेंबर ऑल दीज थिंग्स स्पेशली फॉर टुमारो. तो लिसन टू मी वेरी केयरफुली. देखो, now for the Klinefelter syndrome, there's a very simple trick. What happens in Klinefelter syndrome? Listen to me very carefully. All of you watching this, let's listen to me carefully for just 1 minute and we'll make it very simple for you all. देखो, in Klinefelter syndrome, the problem is 47XXY. So this patient is a male but has an extra X. Because of the extra X, the male has abnormal testis development. The first thing you should remember is the patient has small testis. Now see, if patient has small testis, don't you think the testosterone value will be low? Because of low testosterone, the estrogen and testosterone ratio will be high, which can lead to gynecomastia. Because of small testis and testosterone not coming out, LH is high, FSH is high. So both of them are elevated. And because of less testis, the secondary sexual characters are delayed or absent. Clear ho gaya? Acha. Along with this, just one more thing you must remember is long stature with long legs. We call this eunuch-like body proportions. This is how you must remember Klinefelter. Now let's come to the Turners. In Turner, a simple mnemonic is CLOWNS. ये है for Turners. ठीक है? So for Turners, what you must remember is C, cardiac abnormalities. They have asked you what is the most common cardiac abnormalities? Bicuspid aortic valve. L is lymphedema. O is ovaries underdeveloped short stature. W is webbed neck. N is normal intelligence, and S is short stature with short fourth metacarpal. The features of clowns. याद करो, cardiac anomalies. याद करो, close your eyes and tell with me, everyone. Clowns. C, cardiac. L, lymphedema. O, ovaries underdeveloped. W, webbed neck. N, normal intelligence. And S, short stature with short fourth metacarpal. What is a Turner syndrome which occurs due to not a chromosomal mutation but is a autosomal dominant single gene mutation? Finding like Turners but without finding like Turners but without any chromosomal abnormality. Like Turners is what? It is 45XO, right? However, if a finding is like Turners but is not having chromosomal anomaly but is a single gene mutation, what is it called? Yes, the right answer is Noonan syndrome. Very good. Noonan syndrome. Acha. Now we move to Down syndrome. So in Down syndrome, this question was asked in the last year of that's July session of the FMG, and they asked you about this image. What you see here is a single line. Like when you see a single line here, sorry, this one, a single line fusing both of them is called semen crease. Semen crease with a saddle gap in first and second toe. Gap of first and second toe with a single crease is a diagnostic feature of Down syndrome. Okay, when you see the fifth finger which is not straight but is curved, as a curving ho gayi na, we call this clinodactyly. And on the facial you see three things. What all? We see mongoloid slant, matlab the eyes are downward like this, epicanthic folds, these are skin folds on this side, and you see depressed nasal bridge, and all of them are Down's syndrome. A simple mnemonic of problematic situation will help us to solve lot of questions where P is protruding tongue. R, problematic situation. Mnemonic क्या है सर? Problematic situation. ठीक है? Occiput is flat and open wide frontally. Brushfield spots very frequently asked. Low nasal bridge, I just showed you in the above image with language problem. Epicanthic fold, I showed you in the above image. Ears are also low set. And there's hearing problem. This was also asked in this year's NEET PG. Okay. Mongoloid slant, acute leukemia, Alzheimer, trisomy 21, clinodactyly, congenital heart disease and cataracts, and saddle gap with semen palmar crease are the basic finding of Down syndrome. Acha. For Edwards, the mnemonic is Rocky Mountain. Rocky Mountain. Acha. In Rocky Mountain, it is R is rocker bottom foot. What is rocker bottom foot? If this type of image is given, in which the foot is not having a typical arch, it is opposite. मतलब देखो foot कैसा होना चाहिए? ऐसा होना चाहिए ना? But now it is like this, opposite, like a rocking. Okay, it's a rocker bottom foot. Along with this, overlapping finger, C is cardiac defects, K is kidney malformation, Y is the microcephaly, M is mental retardation, and the finding of Edward syndrome. Let's come back to our question here. Chalo. Glioblastoma falls in which grade of WHO? देखो, the moment you see a question with blastoma is always grade 4. So can you name one more blastoma? Yes, glioblastoma multiforme and also medulloblastoma is a grade 4 tumor. तो grade 1 क्या है? Grade 1 is called as pilocytic astrocytoma, and the other tumors like oligodendroglioma and ependymoma, they usually are grade 2 more than grade 3. Okay, they're usually grade 2 actually, not grade 3. I'll just correct this, it's grade 2 here. ठीक है, अच्छा. Meningioma is grade 1, 2 and 3 also, but meningioma is not grade 4. Meningioma is not grade 4. What they can ask you in this one is, what is the finding of medulloblastoma? Remember, it's a primitive neuroectodermal tumor, PNET, and therefore it shows a typical microscopy in which cells are arranged like this with a pinkish center. Can you tell me what is this called? What is this called? Batao, naam batao. What is this called? Yes, very good. It's called as Homer right rosette. It is called as Homer right rosette. Okay. Apart from this, remember meningioma, it is having grade 1, 2 and 3, but meningioma is no grade 4. Grade 4 is not there. This is only grade 1, 2 and 3. Meningioma shows samoma bodies which is seen in papillary carcinoma, serous carcinoma and meningioma. Okay, PSM. ये बेसमेंट स्टिपलिंग नहीं है बच्चे, इट्स अ होमर राइट रोसेट. ओके, चलो. Patient presents with history of liver disease. Hepato shows ground glass appearance. Ground glass appearance is a typical finding of which disease? Bolo. Yes, it is a finding of chronic hep B. Answer is A. Rotor syndrome में क्या होता है? In Rotor syndrome you see a black pigmented liver and is due to inherited. It's a inherited hyperbilirubinemia. Black pigmented अगर liver है, it is seen in Dubin-Johnson, and if not in the option, only then take Rotor syndrome. Hemochromatosis we already discussed, and also we discussed Hep A. These two topics are already done. चलो आगे बढ़ते हैं. Next question. ये बताओ. A mid-age patient having hypercalcemia and features are consistent with renal insufficiency. ठीक है? On CBC, the RBC count is severely decreased. And on X-ray, multiple lytic lesions seen. There is renal insufficiency with multiple lytic lesions. Combination क्या बना? Yes, the answer is multiple myeloma. So multiple myeloma is one question all of you want to read it very carefully. I have seen every year in FMG they ask you questions on multiple myeloma. इसको छोड़ना मत multiple myeloma को. So what are the things you must remember in multiple myeloma? Often you must remember in multiple myeloma a CRAB finding, CRAB, where C is hypercalcemia, R is renal failure, A is anemia, and B is the bony lesions, bone lytic lesions. ठीक है, ये CRAB findings है. Now, along with this CRAB, a patient has M protein. But what is M protein? M is monoclonal protein. M is monoclonal protein. ये है CRAB findings. Okay. And along with this, what you get is a typical morphology of the multiple myeloma. So what do we expect in the morphology of multiple myeloma is first of all a cell assay in which there is a eccentric nucleus. Okay, eccentric nucleus. Along with this, sometimes they can show you a pink color substance coming out of the plasma cell assay करके. We call this flame cell. And sometimes we can see globules of antibodies filling the plasma cells. We call this grape cell. ठीक है, ये क्या है? It's a flame cell. It's a MOTT mott cell. Flame cell and a mott cell. ठीक है? So all these things can be seen in multiple myeloma. Apart from this, what they can also ask is what is the most common M protein? It is mnemonic is GAMDE. GAMDE. The most common is IgG. Because IgM is not the most common, Therefore, IgM is not in the most common. Remember, they often have asked you that is hyperviscosity common or rare? Remember, hyperviscosity is rarely seen in multiple myeloma, not a common finding. It's rarely seen in multiple myeloma. It's not a common finding what you expect in multiple myeloma. क्लियर हो गया? चलो आगे बढ़ते हैं. Pattern of inheritance seen in a disease inherited from grandmother to father and then father to son. बताओ क्या होगा? Grandmother to father, father to his son. क्या होना चाहिए? इसका आंसर बताओ फटाफट. देखो, if you are answering X linked, think once. देखो, let's say X C Y है और X X है. So ये क्या लिखा हुआ है? फादर टू सन है ना? गॉट द पॉइंट. अब देखो क्या होगा. देखो क्या होगा. X C X X C X X Y X Y. तो फादर से कहां गया? टू डॉटर. मतलब X लिंक में इट इज फादर टू डॉटर, नेवर टू सन. तो योर X लिंक इज गॉन. ठीक है. अच्छा, मतलब when you don't see any such predilection, then it is autosomal. But since it is having no generation skipping, so the answer becomes autosomal dominant. Okay, no skipping and no difference of gender. Very good. The answer is autosomal dominant. Well answered. Very good answer. अच्छा, ये बताओ. A 45-year-old male patient has splenomegaly with a following CBC findings. TLC is 1,20,000 and there are all these blasts of 45%, basophil of 2%. What do you think it is? It is myeloblasts, promyelocyte, metamyelocytes, all of them combined to make 45%. So the answer is, with a 45-year-old person and splenomegaly, it goes to in favor of chronic myeloid leukemia. So now the question, sir, why have you not answered AML? Because in this one and this one, the blast itself should be more than 20% in both the condition. In CLL, you will see a convent girl appearance, and along with this, you will see what? Smudge cells. Convent girl appearance and a smudge cell. Okay? चलो next पढ़ते हैं. A middle-aged man on urine examination shows Benz-Jones proteins. I think this we already solved. The protein found high in the condition, likely seen. And what is the most common? It is globulins. Which globulin? Antibody, right? What is antibody? Gamma globulins. Antibodies are all the gamma globulins because antibodies are raised in multiple myeloma. Antibodies are raised in multiple myeloma and antibodies gamma globulins. ठीक है, चलो. Dystrophic calcification is seen in. बताओ इसका आंसर क्या होगा? Metastatic and dystrophic. How to differentiate? The main differentiating point is look at the serum calcium level. Raised here, normal here. Example. Raised में क्या क्या आएगा? Hyperparathyroidism. Vitamin D. Toxicity. All hypercalcemia causes. Okay. Sarcoidosis. Okay. What else? बताओ. Milk alkali syndrome. What else? Chronic renal failure. All of them will lead to hypercalcemia. ठीक है. And multiple myeloma also. Multiple myeloma. ठीक है. So hyper PTH, increased calcium. Atherosclerosis, vitamin D, increased calcium. Hypercalcemia, increased calcium. So the obvious answer is atherosclerosis. Remember, a simple mnemonic for dystrophic calcification is RATNT. Okay, मतलब rheumatoid nodules, which is seen in the rheumatic fever. It can be atheroma. ये A है. It is TB and tumors. And in tumors, we call this Samoma body. In tumor, we call this as Samoma bodies. That's a RATT. ठीक है, clear है सबको? Okay. चलो. NF1, pattern of inheritance. NF1 is also called as, yes, von Reckling Recklinson disease, von Recklinson disease, NF1 क्या होगा? Autosomal dominant. अच्छा, they can always ask you, first of all, what are the finding of NF1 and finding of NF2? For those who are watching the videos, are all there? सब देख रहे हो ना? If you're really watching it, put a like to this video. I'll then move ahead. चलो, NF1, NF2. Are you all finding it useful or not? NF1, NF2. हाँ जी. NF1 17Q, NF2 22Q. Okay. NF1, what is a protein? It is न्यूरोफाइब्रोमिन और NF2 में मर्लिन. ओके, यहां क्या होगा? MERLIN, मर्लिन. ओके, एंड इन NF1 इट इज नो स्पेस, SPACE, नो स्पेस, मतलब न्यूरोफाइब्रोमा. ओके, ऑप्टिक नर्व ग्लायोमा. ठीक है, स्फेनॉइड बोन डिस्प्लेशिया, प्लेक्सीफॉर्म, sorry, plexiform neurofibroma. Very sorry. Plexiform neurofibroma. A, axillary freckling, cafe allo spots, and I में we can find lish nodules. ठीक है, ये हो गया NF1 का. NF2 में very important, and you all will miss me in your exam tomorrow because lot of questions going to come from this session. It is multiple inherited and 3 tumors: schwannoma, meningioma, and ependymoma. Okay, there's a features of NF1 and NF2. Remember, both of them are autosomal dominant. Both of them are autosomal dominant. ठीक है, चलो नेक्स्ट वन. मोस्ट कॉमन लंग कैंसर. अब यहां पर ना समथिंग हैज चेंज्ड एंड यू शुड ऑल नो अबाउट इट. देखो, व्हाट हैज हैपेंड इज previously the most common lung cancer in our country was squamous cell cancer. Okay, ये पढ़ा था ना, most common in India is squamous cell cancer, and most common in the worldwide in non-smoker, okay, and most common also in young, it is adenocarcinoma. However, what they have changed here is the most common in India is not squamous cell cancer now. Even most common in India also is adenocarcinoma, more common than squamous cell carcinoma. ठीक है, so things have changed now. So most common lung cancer in India and worldwide has changed from squamous to adenocarcinoma. इसको ध्यान रखना. It's a recent change in the Robbins also. It has been mentioned in a text. Do not think anything else. Answer is adenocarcinoma. I know I was also teaching B, squamous cell cancer, a few months back, but it's a recent update and you must all know about this recent update. Clear हुआ? Clear होना सबको? ये recent update है. Okay? तो everyone who has taught to including me, मैंने ही पढ़ाया तुमको squamous cell cancer, but update हो गया है. तो update पता होना चाहिए ना? चलो नेक्स्ट क्वेश्चन चलते हैं. Come on. चलो नेक्स्ट क्वेश्चन. A patient present with hematuria and hemoptysis, investigation revealed anti-GBM antibody. What is the most probable diagnosis? फटाफट बताओ. Yes, it is Goodpasture syndrome. Okay. IgA neuropathy is also called as is also, we see the mesangial deposition here. Mesangial deposits in vaginous granulomatosis. What you see a finding of ANCA with RPGN with a history of granuloma, and along with that a history of upper and lower respiratory infections. ठीक है. Alport syndrome we already have discussed. इसका आंसर is the Goodpasture syndrome. This is already done. हाँ, स्मोकर में तो स्क्वामस सेल कैंसर हो गई. गरिमा, If the question is on smoker, it should be squamous cell cancer. However, the most common lung cancer in India is now adenocarcinoma. Smoker में surely it is squamous cell cancer, no doubt about it. ठीक है, चलो next question. TAM Horsel protein is seen in, बताओ फटाफट. Yes, the answer is hyaline casts. Okay, now hyaline cast is also physiological. ठीक है, apart from physiological, it can be seen in nephrotic syndrome as a pathological cause. RBC cast is a hallmark of glomerulonephritis. WBC cast is seen in pyelonephritis, also called as tubulointerstitial nephritis, and muddy cast is also referred to as a granular casts. Okay, it is seen in ATN, acute tubular necrosis, along with this pyelonephritis. Okay, ये clear हुआ? चलो next. A patient has backache, renal stones, raised urea and creat, and this is the image that is given to you. The finding is giving you backache, kidney stone, raised urea and creat. This is combination of multiple myeloma. Sir, what is MGUS? It is monoclonal gammopathy of undetermined significance, MGUS. MGUS क्या होता है? If the M protein less than 3.5 gram per DL, and along with that, suppose a patient has a M protein less than 3.5 gram per DL, and along with that, there is plasma cells of less than 10% in the bone marrow, and there's no CRAB finding. No CRAB finding. It's a feature of MGUS. HCL is hairy cell leukemia. In hairy cell leukemia, you see hairy cells and also get fried egg appearance. The special stain is TRAP trap, and the CD marker is 11C 25103 and FMC7. It shows fried egg appearance. Waldenström macroglobulinemia, remember W, and from W remember M. You remember two things. MYD88 mutation hoga, first thing, and secondly, it will show you increased amount of IgM causing hyperviscosity in Waldenström macroglobulinemia. ठीक है, and all the images you see here, these all are plasma cells. They are plasma cells. Eccentric nucleus है ना, they all are plasma cell in the image given above. Clear हुआ ये? Yes, cladribine, very good. Is a drug of choice, is cladribine, very good. But देखो, whenever there is a tumor and if you have an option of bone marrow hematopoietic stem cell transplantation, always choose that option. अगर tumor है and you have a hematopoietic stem cell transplantation, please choose that option as the best option. Cladribine अपने सब कुछ बाद में. Is it okay? चलो. The following is involved in extrinsic pathway. Intrinsic extrinsic को कैसे solve करना है मैं बताता हूँ. देखो, it is really confusing. Intrinsic pathway, extrinsic pathway, common pathway. याद रखना, common starts from 10. Common starts from 10. 10 का half कितना है? 5. 5 का half कितना है? 2. और 2 का half 1. ये है common pathway. Simple हो गया. Extrinsic में there is only one pathway. It is called as factor 7. ठीक है, ये क्या है? 7. ओके, 7 से जाएगा 7A में, will activate 10. Intrinsic में it is what? It is 12. 12 will activate 11. 11 will activate 9. And 9 with the help of 8 will activate to 10. ठीक है, ठीक है, ये वो 10, 10 से 2 and 2 से 1. क्लियर हुआ? अच्छा, once we move to 1, 1 is fibrin, इस पे क्या लगेगा? 13 and makes it what? A stable clot. ठीक है, that's how you must remember the entire pathway. अच्छा, now once you know this point, अब क्वेश्चन above क्या है? देखो, what they're asking you above is number 1, which are in an extrinsic pathway. Simple answer 7 है, वो तो सबको पता ही है. But what they can also ask you in this question is, what is the test for measuring the coagulation defect? देखना, small name small pathway, मतलब this one and this one, PT. तो PT में extrinsic plus common, and long name long pathway, APTT. APTT will measure the intrinsic pathway plus common pathway. ठीक है, ठीक है ना? चलो, a female took aspirin for headache. She developed some allergic reactions and she would be related to which of the following? Aspirin से allergy हो गया. The moment you see aspirin allergy, what is it? Yes, it is increase in IgE. Aspirin से allergy हो गया, it is increase in IgE. देखो, nasal polyp जो होता है ना, it is a syndrome finding. Nasal polyp कहाँ दिखता है? In young syndrome. Okay, it can be seen in young syndrome. So that's a different thing. Positive skin allergy test can be seen, but a better example is IgE here. Yes, Samtus Strat bhi ho sakta hai. This is completely agreed. Samtus Strat can also be there. So that's also can be there. Yes. So it can be, sorry, it can be nasal polyp as actually a Samtus Strat. Very, very good. It's actually B only, not C, it's B. It's Samtus Strat and it's actually B, not C. ठीक है? चलो, characteristic feature of hemolysis क्या होगा बताओ? Reticulocytes increased. This cannot be the answer. Low haptoglobin, true. Neutropenia is not the basic option. The answer is decreased amount of haptoglobin. ठीक है, decreased amount of haptoglobin. ठीक है, चलो next question. Splenectomy is useful in the following condition except, बताओ answer. All of you, tell me the answer here. Answer of this question. Splenectomy is useful in which of the following condition except है? Yes, in D. It is very useful in ITP, surely in HS, as tumor is also the treatment of choice. The answer is G6PD. May there's no role of splenectomy. The answer is D here. Okay. Next, in sickle anemia, the simplest question: glutamic acid to valine. Okay, glutamic acid to valine on the sixth position of the beta chain. I think this is the most easiest one, and you might have all marked this correctly. Chalo. A 50-year-old female came to OPD with headache. She was afebrile. Finding revealed a tumor measuring 2 into 2 centimeter attached with dura mater. बताओ क्या है ये? Yes, it's a case of meningioma. Very well answered. अच्छा, concentric finding of body is seen in, again, meningioma. That's the answer. Meningioma. Okay. Antony A and Verroque body is a feature of schwannoma. And obviously, egg yolk appearance is seen in the oligodendroglioma. The answer is B here. The answer is B here. ठीक है? अच्छा. A 44-year-old female comes with wheezing, coughing every year at the same time period. Degranulation of which cell is responsible for this type of finding? The answer is mast cell. Okay, mast cell degranulation release what? Basophils. Okay, along with this will also release PAF. And both this PAF and histamine, this will release PAF and histamine, they both have more or less the same finding. And what do they have? They have vasodilation, increased vascular permeability, and they also lead to bronchoconstriction. Typical finding of PAF and PAF पता है ना? Platelet activating factor is PAF. ठीक है? अच्छा, eosinophil release what is? Eosinophil release eosinophil, cationic protein, ECP, and major basic protein. ठीक है? These two comes from the eosinophils. Then they ask you IgE का FC receptor is on which cell? Remember, the FC receptor of IgE is on mast cell. याद रखना. Okay, on the mast cell. चलो, next question. A child went ocular surgery for an eye tumor and enucleation was done. More likely, they're talking about which one? Retinoblastoma. And so the answer is retinoblastoma gene. Achha, they can ask you, among these, which is the most common gene getting mutated? The answer is P53. It causes what is called as Li-Fraumeni syndrome. If the question is Li-Fraumeni, you must remember this in a simple way, and that is the blast. B-L-A-S-T. तो बी से ब्रेस्ट आएगा, ब्रेन आएगा, एल से लंग, ए से एड्रिनल, एस से स्किन एंड स्टमक, एंड टी इज ऑफ द ट्यूमर. ठीक है, टी इज द ट्यूमर. Okay, MYC gene is mainly responsible for Burkitt lymphoma. Now, MYC is on chromosome number 8. So, typically they ask you the typical translocation is 8 with 14. 8 with 14. ठीक है, 8 with 14. Clear हो गया? अच्छा. Apart from this, let me tell you what are the most important mutations they can ask you in lymphoma topic. देखो, they can ask you translocation 11 14, 14 with 18, and they can ask you 8 with 14. अगर 11 14 है, इट इज मैंटल जोन लिम्फोमा. 14 18 है, फॉलिकुलर लिम्फोमा. 8 विथ 14 है और 2 विथ 8 है और 8 विथ 22 है. दिस बिलोंग्स टू बर्किट्स लिम्फोमा. ठीक है, द 3 ट्रांसलोकेशन यू मस्ट रिमेंबर फॉर लिम्फोमा. इतना याद करो, इज रियली सफिशिएंट. इज रियली सफिशिएंट. चलो, नाउ ऑल ऑफ यू टेल मी व्हाट इज द आंसर टू दिस क्वेश्चन. ये बताओ, व्हाट इज द आंसर टू दिस क्वेश्चन? आइडेंटिफाई द पेडिग्री. देखो, when you do the pedigree, the 3 rules you must set. Rules. Okay, rule 1, 2 and 3. First is see it is mitochondrial or not, then see it is X-linked or not, and then see it is autosomal or not. ठीक है, देखो. Now, first of all, look at for mitochondria. In this disease, the male is transmitting. Because male is transmitting, the disease mentioned here, it cannot be mitochondrial. Correct? Now, whether it is X-linked or not. Now, in a X-linked disease, a male will never transmit, the male will never transmit to son. Now, since in the condition, the male is transmitting to son, the male is transmitting to son, it does not look to be X-linked. So, it looks to be autosomal. ठीक है, autosomal. ठीक है, अच्छा. Now, it is the third condition, whether it is dominant or recessive. Okay, so this is autosomal. Now it comes to dominant है or recessive है. Dominant or recessive. So if it is dominant or recessive, to understand that, what you must do is look at here. Agar you see a diseased child and you see a diseased parent, one of the parent getting diseased, it is dominant. If not so, recessive. मतलब देखो यहाँ पर diseased child है, is one parent diseased? Yes, it is dominant. ठीक है. Now, what is happening here is, if you look at this condition, diseased child hai, but is one of the parent diseased? No. So it cannot be dominant. And hence the best answer is autosomal recessive for this condition. And very well answered. Yes, generation skipping is seen there, and hence it should not be dominant, it should be recessive. 3 rules. First look for mitochondrial, then look for X-linked versus autosomal, and then look for dominant or recessive. Am I clear here? समझ आपको? Mitochondrial के लिए क्या होना चाहिए? The female must transmit to all children. For X-linked autosomal क्या होना चाहिए? For if the male is transmitting to son, it cannot be X-linked. And third rule क्या है? If you see a diseased child and one of the parent disease in every generation, it is dominant. Else it is recessive. This for the 3 rules will make the easy all your pedigrees. What is this? It is, yes, it is hemangioma. Okay, and whenever you see hemangioma on the skin or you see on the mucous membrane, always mark it capillary hemangioma, because cavernous hemangioma occurs in organ, especially like liver. Especially like liver. Especially like liver. Okay. Chalo. Now this is a Mott cell. Now many of you also told me कि sir Mott cell तो हर बार आता है. Yes, Mott cell हर बार आता है. It is multiple myeloma. Very correct. चलो next question. Achha, this is very important question. This has been asked in NICT also, NEET PG also. So all of you watching this video, do stay with me. Do not go anywhere. Okay? This is what? It's a islet cells. It's a islet cells. ठीक है? So It is diabetes mellitus. ठीक है ना, because islet cells of pancreas. अच्छा, now if the, do you know, if the arrow is marked here, मान लो यहाँ पर arrow marked है, ओके मतलब ये islet cell क्या होता है, endocrine portion होता है ना, it's an endocrine portion, ठीक है. But suppose it is marked in the exocrine glands and then asking you if the problem occurs here, if the defect occurs here, which is the disease it will cause. Can anyone tell me what is the answer to this question? बताओ, this question का आंसर बताओ, all of you फटाफट बताओ. If exocrine gland is marked as a defect, what is a disease you will accept? बोलो बोलो फटाफट बोलो. Yes, it is cystic fibrosis due to CFTR gene mutation. Cystic fibrosis due to CFTR mutation. तो what do we expect in cystic fibrosis? थोड़ा बहुत जान लेना चाहिए. In cystic fibrosis, what you expect is number one, you expect a patient to have increased sweat chloride condition. ठीक है? Increased sweat chloride, and this is seen as a salty kiss in a baby. Typical history आएगा salty kiss. Typical history आएगा, ठीक है? Along with that, they can be giving you a history of the dry secretions, okay? Dry and viscid secretion of GI, of pancreas and also of respiratory system. तो उससे क्या होगा, GIT में obstruction का history होगा, ठीक है? Pancreas में there is a history of acute and chronic pancreatitis का history होगा, and respiratory system में is respiratory infections. ठीक है? Yes, it is autosomal recessive condition. ठीक है? Along with that, they can give you either a CFTR mutation, and the most common mutation in the CFTR is delta F508. मतलब in 508 position of the CFTR gene, the phenylalanine changes to something else. Okay? A treatment is something new, at least from the name of Caftors. ये drug का name है. Caftor में क्या क्या आया है? Eva Caftor. Okay? Eva Caftor. There is Elixa Caftor and Luma Caftor, and therefore this all they are together called as Trikafta. क्या कहते हैं? Trikafta. It's a new drug for cystic fibrosis. But however, again I repeat, अगर आपको ऑप्शन में hematopoietic stem cell transplantation है, always choose that answer in a single gene mutation. अगर chromosome mutation है, then you can't choose it. Okay? ठीक है? अच्छा. A factory worker of gastric upset because he was eaten outside for last few days. Some other friends also have same symptom. So what are they suffering from? Yes, Hep A, because it is fecal-oral and waterborne disease. It's a fecal-oral and waterborne disease. ठीक है? चलो next. An adult male suffering from road traffic accident, grafting was done using his own tissue. तो क्या होगा ये? Yes, it is autograft. Autograft है ये. अच्छा, autograft में देखो कैसे डिफरेंस होता है. आइसो याद है ना, आई से आई. It is identical twin. No confusion. Same species is not isograft. Okay, ध्यान रखना. Same species allograft. Same species. And xeno is between different species. Okay, different species. Yes, in the previous question, Hep A and Hep E. Okay, Hep A and Hep E are both waterborne. Very correct. Very good. ठीक है? चलो next question चलते हैं. ये बताओ फटाफट 30. So now this is the 70th question we are reading. सोचो. A 7-year-old child with hypoalbuminemia, edema, and hyperlipidemia and proteinuria is there. Along with that, there is edema. You are given steroid therapy and disease goes away. ठीक है? In kidney biopsy, the light microscopy was unremarkable, but on EM you see effacement of food process. क्या है ये? Yes, it is minimal change disease. Minimal change disease. Now comes the question, sir, what is the finding which helps us to identify the other disease? देखो, in short I'll tell you how to identify every nephritic syndrome in short. देखो, बहुत simple होगा. एक है nephritic एक है नेफ्रोटिक, ठीक है। इन नेफ्राइटिक इट इज PSGN, it is RPGN, it is IgA nephropathy and MPGN, ठीक है। Now remember, nephrotic में it is minimal change disease, FSGS, MGN, and this IgA and MPGN belongs to both nephrotic and nephrotic. Now what you must remember in all these conditions to solve all the questions, देखो ध्यान से, अगर it is asked most common cause of nephritic in children, your answer is nephritic. In this case, you'll get what is called a starry sky appearance, and they can mention humps in the EM. In RPGN, what you might get a history is crescents, with what you can get is a flea bitten kidney, crescent मिलेगा, flea bitten kidney, and there can be GBM rupture. Don't forget, RPGN is 1, 2, and 3. All these three you must read. In the type 3, in the RPGN type 3, you test for ANKA. ठीक है. In IgA, there is a mesangial deposition of IgA. In MPGN 1 है और 2 है. MPGN में this proliferation of mesangium and capillary also, and hence also called as mesangio capillary glomerulonephritis. In MPGN 1, you get what? You get tram track appearance. सबका याद रखना चाहिए, okay? In MPGN 2, you get dense deposit disease. ठीक है, ये हो गया. In this one, ये है most common cause in children, MCD. Okay? यहाँ पर you get what is called as podocytopathy. Podocyte का effacement मिलता है, effacement. However, podocyte effacement can be seen in FSGS and MGN also. तो इसीलिए if you get a history of fibrosis in the glomerulus and along with this get you podocyte effacement, only then you mark FSGS. If you get a history of spike and dome, and along with that you get podocyte effacement, that is MGN. And I already have told you about the IgA and MPGN. I think this has now become simplified. इसको याद रख लेना. Don't forget this. In short, इससे बहुत सारे क्वेश्चन सॉल्व हो जाएंगे. स्पाइक एंड डोम, fibrosis, and no change with podocyte effacement. But podocyte effacement is seen also in MCD, FSGS, as well as what you see is in IgA nephropathy. ठीक है. Last question. A 24-year presented with hematuria and edema and has history of sore throat 10 days back. So what is it? There's hypocomplementemia, and this is a history of PSGN, as I mentioned above, that if you get a history of any sore throat, ध्यान रखना, it is 7 to 21 days. It is PSGN, and 1 to 2 days is often seen in IgA nephropathy. The same history is also seen in Henoch-Schönlein purpura. ठीक है. So that is how we can just quickly revise it. Guys, the next class, medicine, is just starting after me. But in case, I'll just share this PDF in my Telegram group and you can clearly take it from there. My Telegram group has a very simple name, Dr. Praveen Ames. That's very simple. And if you type in the Telegram, just type the name Dr. Praveen Ames. You get my Telegram group, you add up there and you can see this, all the PDF I just showed you. You can just download it from there for a quick revision. If you want to do that, it's very nice for all of you, for a very quick revision coming up next time. So guys, I hope you like the class. Ensure that you do message me in case you have any difficulty. I will always there to support you and give the answers to your queries that you may have. So with that, wishing you all the best for the exam coming up, and stay blessed, stay happy, and more importantly, stay calm during the exam. You know a lot of things, and if you just stay calm, most of the things that actually can confuse you, you will again come back to that question after you attempt all the questions. You again come back and think with a calm mind. I think you should get the answer there. Wishing you all the best. Take care. Goodbye. Medicine class coming up just after this, just now. Bye bye.
सुनो सुनील हेलो एवरीवन FMG mega revisions session of the medicine. Well, I'm sure you must have done a good preparation for your exam tomorrow, but I'll be giving you lots of points which you should remember as a last minute revision points. So first point is about hypertension. What are the endocrine causes where we can see hypertension? Cushing syndrome, Conn syndrome, pheochromocytoma, acromegaly, hyperparathyroid, hypothyroid, and hyperthyroid. But one thing you like to see, in this list, diabetes is not there. This is an important catch point. As such, diabetes and hypertension are often seen together. But diabetes as such is not a cause of hypertension, you can see. It's a very important negative point to remember. Similarly, in the endocrine condition, Addison disease. This is again not a cause of hypertension. And one more point, hyperthyroid is the usual cause of systolic hypertension. And in this, both systole and diastole occur. S for systole, D for diastole. So they are all important last minute revision point. Now there are certain drugs which can also lead to hypertension, corticosteroids, oral contraceptive pills, or you can say any drug which contain estrogen. Non-steroidal anti-inflammatory drug and chronic alcoholism. That means there is one patient who takes a lot of alcohol for a long time. That can also induce hypertension. So they are so-called drug-induced. And after this is the single most important. Because this causes hyperglycemia. It causes increased BP. So steroids are notorious to cause hypertension and diabetes. Now, mean arterial pressure, very, very important question. This is a universal question. Diastolic hypertension and 1/3 of pulse pressure. Suppose the BP is 120/90. So diastolic pressure is 90. Pulse pressure is 120 minus 90. Pulse pressure is systole minus diastole. This is 30. If 1/3 of this will be how much? 10. So 90 plus 10. The mean arterial pressure in this is, is 100. Isolated systolic hypertension, this is seen in elderly person. This is due to loss of elasticity is lost. Aortic elasticity is lost, the artery becomes stiff. So this becomes only systolic BP high. In this case, BP may be 190/80. So you can see only systolic BP is high, diastolic is normal. White coat hypertension. This is one entity. Patient has normal BP at home. But when the patient goes to the hospital or doctor, when the patient goes to hospital, when he sees doctor wearing the white coat, BP high, goes high. So this is so-called white coat hypertension. So BP normal at home, high at the hospital is white coat hypertension. Well, golden line to remember, age-related decrease in compliance, increased stiffness. I told you elderly person. of the aorta and proximal major arteries often cause isolated systolic hypertension. The point I just mentioned to you, the elderly man or maybe a man of 60 year having BP of 190 by 80, this is IS. This is all stiffness of the artery. It's a very frequently asked question. How to treat a case of hypertension? Remember, the best treatment is always lifestyle management. DASH diet. DASH diet is low sodium, low fat, high fiber diet. Is DASH diet. Well, little bit physiology also before we really treat a case. BP is, this you should remember very well. Make a box. BP is heart rate multiplied by stroke volume multiplied by peripheral resistance. That means in the physiology there are only 3 parameters that you have to take care of. Okay, so now drug which reduce heart rate, beta blocker and evaporating. This is a very, very important question. The 2 drugs which are going to take care of this component, so-called heart rate. They reduce the heart rate, BP will come down. Now let's talk about drug which reduce stroke volume. Again, beta blocker. Point to be noted, the beta blocker, they reduce heart rate, but they also reduce stroke volume. Diuretics. Again, they reduce stroke volume, and nitrates. Nitrates are basically venodilators. They dilate the vein, the blood goes to peripheral tissue, the stroke volume is reduced. And now the drugs which reduce peripheral resistance are alpha blockers like prazosin, calcium channel blocker like nifedipine, and ACI like lisinopril. They're all drugs which reduce peripheral resistance. Newer drugs include aliskiren, is a renin antagonist. Naftopidil and urapidil, they are alpha blockers. And the pheneldoprem, they're all newer drugs that we use in hypertensive emergencies. Now we have one term called hypertensive urgency and emergency. Well, urgency means BP is very high, maybe 200 by 110. But there is no evidence of end organ damage. This is urgency. This we can treat on OPD basis. But we have one term called hypertensive emergencies. BP is very high and there is evidence of end organ damage is there. This need to be hospitalized in ICU. This is OPD treatment and this is ICU treatment. In both the cases, here also BP is 200 by 110. But end organ damage is there and there is no damage. So no organ damage, treat OPD basis, or end organ damage, treat in ICU or in the hospital. Golden line to remember, a presence of a continuous abdominal blew and a high specificity of renovascular hypertension, so-called renal artery stenosis. So you are suspecting a young lady having very high BP, you auscultate over the abdomen. If you can hear a brew, this indicates renal artery stenosis. RAS stands for renal artery stenosis, and this indicates renovascular hypertension. Congestive heart failure, the next topic. Usually patient come with dyspnea on exertion to begin with. But when the patient has got severe dyspnea or pulmonary edema, then in that case patient can have pink frothy sputum that indicate pulmonary edema. Okay, classical question, if you are getting pinkish sputum, is pulmonary edema. Signs, cyanosis in extreme cases, resting tachycardia, pulse rate is more than 100. Pulses alternance. Third sound is there, and crackles, that is basal capitation. You auscultate at the base. If you are getting crepitation, that again indicate left ventricle failure. So they are the sign of left heart failure. Right heart failure, raised JVP and tender hepatomegaly, liver is enlarged. And it is tender, that is painful on palpation. Biomarker of congestive heart failure, raised BNP. BNP level is raised. This is a very, very important question. Okay, right. It's a very, very important question. Just remember this thing. And if they ask you for the biomarker for congestive heart failure, go for BNP. Now, suppose we want to treat a case of congestive heart failure. How to treat a case of congestive heart failure? Well, let's learn the basic concept. This is the heart. Whatever blood is coming to the right side is preload. So if you can reduce the preload. This is by nitrate and diuretic we use. Definitely the amount of blood coming to right side is reduced. So heart failure get reduced. Done. Or we can increase cardiac contractility, increase pumping action of the myocardium. This is done by digoxin. So this is site number A, this is site number B, and finally the aorta is going out and it is having peripheral resistance in the arteriole. We all know very well the primary site of peripheral resistance is arteriole. In fact, peripheral resistance is 1 by R4. Peripheral resistance, I can write again, peripheral resistance is 1 by R4. That means narrower the arteriole, more will the peripheral resistance. If we dilate the arteriole, more and more blood will go to the peripheral tissue, the lung will get decongested. The classical drug that we use in this case is ACAI, like lisinopril. So that's a basic principle to reduce preload, to reduce your afterload, or increase the pumping action of the myocardium, like digoxin, which we call a positive ionotropic drug. Okay. Beta blocker, they reduce the pumping. Now, beta blocker are used, bisoprolol, carvedilol, and metoprolol. Newer drugs that we use for congestive heart failure are eplerenone. It is just like spironolactone, aldosterone. It's a aldosterone receptor blocking drug. Samprilat, sacubitril is the most important. This question will surely come to you. Okay, it's a neprilysin inhibitor. Very, very important drug. And of course, ivabradine we discussed. This also is a new drug that we use to control heart rate. And of course, this will reduce the BP also. Now let's talk about aortic stenosis. The classical thing is angina, syncope, and dyspnea. Mnemonic is ASD. Mnemonic is ASD, A for angina, syncope and dyspnea. That is aortic stenosis. Angina, syncope and dyspnea. Slow rising pulse we see on examination. Heaving apex beat. This is due to left ventricle hypertrophy. Left ventricle hypertrophy. Ejection systolic murmur. And there is reverse splitting of second sound. AR. These are peripheral signs of AR. They are they are VVIP questions. This you should know. Collapsing pulse, so-called water hammer pulse. So-called water hammer pulse. Wide pulse pressure. Corrigan sign. Corrigan sign is pulsation in the neck pulsation. De-Musser sign, head nodding. Durosus sign, you auscultate over the femoral artery, slightly press, you get a to and fro murmur. Top sign, you auscultate over the femoral artery, you get pistol shot. Quincke sign, you get capillary pulsation over the nail bed. Hill sign, BP difference in upper limb and lower limb. They are very, very important. It should be in your fingertips. So widened pulse pressure together with unusually large LV stroke volume and early diastolic murmur is aortic regurgitation. You are getting early diastolic murmur also when you auscultate over the precordium is aortic regurgitation. Now let's talk about atrial fibrillation. Important causes are coronary artery disease, hypertension, rheumatic heart disease and hyperthyroid. They are the 4 major causes of coronary artery disease. It may occur in a normal person after tea, coffee and alcohol, especially after alcohol. What we call as holiday heart syndrome is a very frequently asked question. Even these causes are frequently asked questions. Symptom palpitation. As the heart rate is very high, the patient has a palpitation. Classically irregular pulse. If you are getting this line, then it is 100% you are dealing with atrial fibrillation. There is no other condition where we have irregular pulse. ECG shows absent P wave, irregular QRS complex. This is again a very important point. So irregular pulse is an important question. Frequently asked question is this. And absent P wave is again a very important question. Now let's talk about a little bit of cardiac pharmacology. Digoxin is a VVIP topic. You always get one question on digoxin. How it acts? It inhibits sodium potassium ATPase. Now what happened? So there will be increased calcium will enter the cell, cardiac cell, and that lead to positive inotropic increased cardiac contractility is by calcium entering into the cell. It also stimulates vagus nerve. That's why the heart rate is reduced by digoxin. Adverse side effects of digoxin are nausea, vomiting. They are the earliest side effect. Diarrhea, Blurry yellow vision. Yellow vision is a very commonly asked question. Now, what are the factors which can precipitate toxicity of digoxin? Hypokalemia, renal failure, and hypothyroid. So, especially they talk about these two things. So, in renal failure, we have to reduce the dose of digoxin. Now, let's talk about cardiomyopathy. Dilated cardiomyopathy, the main thing is systolic dysfunction will be there. There will be feature of left heart failure and right heart failure, the point which I mentioned earlier. The predisposing conditions are chronic alcoholism. Oh, we just studied that chronic alcoholism can precipitate hypertension. Chronic alcoholism can also precipitate cardiomyopathy. Doxorubicin is an anti-cancer drug, is a very frequently asked question. Pregnancy can lead to cardiomyopathies. HOCM is a VVIP topic. You will be definitely getting one question from hypertrophic obstructive cardiomyopathy. It's an autosomal dominant condition. That means this family history will be positive. Sudden death may occur, and there is hard ejection systolic murmur is there. And the important point is intensity of murmur increase on standing and Valsalva. Intensity of murmur increase on standing and Valsalva. There are only two conditions where intensity of murmur increase on standing and Valsalva. Second condition is mitral valve prolapse. This is a very frequently asked question. Coronary artery disease again is a VIP topic. You'll be getting at least one or two questions from coronary artery disease. Angina pectoris we best diagnosed by history. What is the history? Pain chest on exertion. Patient says, when I walk, I have pain chest. When I stop, the pain disappear. So exertional pain chest is the classical feature. Levine sign. Patient will keep like this, fist on the chest. Some heaviness on the chest is Levine sign. We have one condition called unstable angina. Criteria, patient start having pain chest at rest. Or recently started, only 2-3 months back it started. And crescendo pattern. Crescendo means pehle patient says, when I was walking for 1 kilometer, I used to have pain. But now when I walk for even 500 meters, I have pains. So crescendo, the condition is worsening day by day. They are all criteria of unstable angina. Well, in any angina case, in any coronary artery disease, ECG is the best initial test. In angina, ECG may be normal. If ECG is normal in angina, then you go for TMT. TMT is an exercise test, treadmill test. How to manage a case of angina? Lifestyle modification, control body weight, decrease alcohol, stop smoking, antiplatelet therapy like aspirin, calcium channel blocker like diltiazem, beta blocker like metoprolol, statin like atorvastatin. Renal we give for resistant angina. When the pain is not getting controlled by the usual treatment, then we start add ranolazine. Acute coronary syndrome, ACS stands for acute coronary syndrome. We give all the other above drugs that I mentioned, but in addition we give low molecular weight heparin. Thrombolysis can be done by streptokinase. PTC, we can do angioplasty. Or we can go for coronary artery bypass surgery. Endocarditis, the commonest cause of native valve is Staph aureus. And common cause of IV drug abuser is again Staph aureus. So by and large, Staph aureus is one of the most important cause of endocarditis. How to manage a case of endocarditis? We give empirical treatment benzyl penicillin and gentamicin. And for prevention, prophylactic drug. For prophylaxis, we give amoxicillin, but if the patient is allergic to penicillin, then we can give through cephalexin or clindamycin. This we give if the patient is allergic to ampicillin or amoxicillin. So now we talk about some topic about respiratory medicine. ARDS is a VVIP topic. You will be getting one question. In fact, about ARDS, in all the exams throughout the world, you get one question. You will be getting one question on ARDS. ARDS is also known as acute lung injury, also known as non-cardiogenic pulmonary edema, and the very, very important point here, LA pressure is normal. This is in contrast in cardiac pulmonary edema. In cardiac pulmonary edema, LA pressure is increased. ARDS is also known as diffuse alveolar damage, DAD, what they call as high altitude pulmonary edema, high altitude HAPE. All these are same. Acute respiratory distress syndrome. Important cause are septicemia, especially gram-negative septicemia. Plasmodium falciparum, especially cerebral malaria. Heroin toxicity and high altitude. The clinical feature is sudden onset of dyspnea. Patient become breathless, shortness of breath. In the pathology, there is an accumulation of protein-rich fluid in the interstitium. Like this is the alveolus. This is the alveolar capillary, capillary, alveolus, and this is the interstitium. So what happened? Protein-rich fluid accumulate in the interstitium. So definitely when the lungs are flooded with the fluid, the lung becomes stiff. Okay, lung becomes stiff. Oxygen cannot go like this because whole lung is full of liquid water. So oxygen cannot go in. Why? Oxygen is a water insoluble gas. But CO2 can very well come out. Why? CO2 is a water soluble gas. So that's why you get type 1 respiratory failure. Lung compliance reduced. Why? The whole lung is full of fluid. The treatment is positive pressure ventilator. You have to put the patient on ventilator. That's the main treatment of ARDS. Asthma. Reversible airway obstruction. This is a key word. Don't forget this. The airway obstruction is there. It's a type of obstructive airway disease. But even COPD is a obstructive airway disease. But here it is irreversible. There is irreversible damage of the lungs. Okay. And they need to COPD, and this smoking is the main predisposing factor. But this, in contrast to asthma, it is usually by allergen. allergy is the one which predisposed to asthma. It can sometimes come with the exclusive dry cough also. Only dry cough is the one presentation of asthma. Now what happened? There is a bronchial muscle contraction. There is mucosal swelling also and mucosal inflammation. So the problem is the muscle contraction as well as mucosal swelling and inflammation is there. This play a very, very important role. That's why to take care of this, we add corticosteroid. CS stands for corticosteroid that will take care of the inflammation of the airway. Now, when we give this very important point, when we give some drug, maybe by bronchodilation or by nebulization, the particle size, the drug's particle size should be less than 2.5 micron. Then only it will enter the lung. Otherwise, majority of the drug, they remain in the throat. And they are swallowed. And that can lead to a systemic problem when it is swallowed. The particle size should be less than 2.5 microns. Typical Charcot-Leyden crystals are there. Very, very important point when we do the sputum examination. But in any obstructive airway disease, pulmonary function test is the most important. FEV1 is reduced. There is reduced FEV1. And FEV1 FVC ratio is reduced drastically. This is PFT. So you get type 1 respiratory failure, low oxygen, low PaO2, low PaCO2. This is type 1 failure. You can give short-acting beta-2 agonists like salbutamol. Or, so they lack the bronchial smooth muscle. Side effect of beta-2 agonists are hypokalemia and tremors. That is salbutamol. We also give aminophylline, they increase cyclic AMP levels. And they cause smooth muscle relaxation. Ipratropium, they are anticholinergic drug. So they also cause relaxation of the bronchial muscles. Newer drug in asthma, omalizumab, anti-IgE drug, mepolizumab, interleukin-5 antagonist, dupilumab, leukin 4 and 13. This is a very, very important slide. You are likely to get one question from this particular slide. Bronchiectasis, permanent dilatation of the bronchi and bronchiole. Permanent. Left lower lobe is most likely involved. Congenital causes are congenital so-called Carter-Jenner syndrome. Post-infection, especially after tuberculosis. Cystic fibrosis is a very important cause. And ABPA and classical exam question. In this, you get proximal bronchiectasis. And that's the reason why ABPA can have hemoptysis. COPD, again a type of obstructive airway disease. We have two things, chronic bronchitis or emphysema. How we diagnose the case of chronic bronchitis? Persistent cough for 3 consecutive months, for 2 consecutive years is chronic bronchitis. What are the complications of a case of COPD? Acute exacerbation is a big problem. Polycythemia might especially occur in chronic bronchitis. Respiratory failure, especially again type 2 failure occur. In type 2 failure, there is decreased oxygen but increased PaCO2. Is type 2 failure in chronic bronchitis. More. Cor pulmonale pneumothorax, especially in emphysema. Pulmonary arterial hypertension, especially in chronic bronchitis. How to investigate a case of COPD? Chest X-ray is always the best initial test. PFT is the most accurate test. And DLCO is decreased in emphysema but normal in chronic bronchitis is a very frequently asked question. And you get type 2 respiratory failure. What is this? This I told you in the previous slide. Point to be noted that diffusion capacity DLCO is decreased in emphysema but is normal in chronic bronchitis. Now, golden line to remember about emphysema. Dyspnea is the characteristic presenting symptom of emphysema, dyspnea. Obstructive pattern is seen in PFT. The way I told you, FEV1 will be reduced. But DLCO decrease, this is one very, very important point. There's one test which differentiates it from chronic bronchitis. A long-term bronchodilator therapy may not be improve the function in this case. Now we talk about hypersensitivity pneumonitis. Begasosis occur in sugarcane worker. G. This is how I remember. Bicinosis cotton. And in the CT, you get honeycomb appearance in hypersensitivity pneumonitis. Pneumoconiosis, silicosis, upper lobe involved. Classically, hilar adenopathy will be there, and they are prone to tuberculosis. Coal worker pneumonicosis, lung fibrosis is a big problem. Okay. Asbestosis is the VVIP topic. In fact, if examiner has to ask question on pneumoconiosis, he would like to ask from asbestosis. It leads to lung fibrosis, it leads to lung cancer, pleural plaque, and mesothelioma. Well, if you are getting one case of mesothelioma, that means he is working in asbestos factory. So don't forget. Mesothelioma occurs exclusively in asbestos exposure. Berylliosis due to beryllium exposure. Now, what is hypoxia and what is respiratory failure? Ischemia is loss of blood flow. This is the artery, this is a tissue, artery gets blocked, no blood going, this is ischemia. Hypoxemia decrease PaO2. Normal PaO2 is 94 to 104. When this PaO2 goes below 60, we call it as hypoxemia. And hypoxia is decreased delivery. Now there's no blood is coming to this tissue, is hypoxia. So hypoxia will lead to ischemia. This tissue, there's no blood supply, so tissue is ischemic because of hypoxia. But hypoxemia is decreased PaO2. Respiratory failure, type 1, PaO2 less than 60 and CO2 less than 40. But in type 2, PaO2 less than 60 and more than 45. Difference lies in CO2. Normal PaCO2 is 40 to 45. Below 40, type 1, more than 45 is type 2 respiratory failure. Lung cancer. Most common cancer of lung is secondaries. He's talking about, remember, lung cancer. Most common primary lung cancer in the world is adeno, primary. In women, again adeno. Non-smoker, adeno. Lung cancer with neuroendocrine feature, small cell lung cancer. Central tumor are small cell lung cancer and squamous cell lung cancer. Squamous cell cancer, small cell lung cancer. Peripheral tumor are adenocarcinoma. Or anaplastic, they are peripheral. Radiosensitive is small cell lung cancer. Best prognosis, squamous cell lung cancer. Pancreas tumor is a peripheral type of squamous cell lung cancer. Now, which tumor has got maximum metastasis? Small cell lung cancer. Tumors having cavity, squamous and large cell, like this a tumor. In the tumor there is a cavity also. This cavity formation occurs in squamous cell and the large cell cancer. In adenocarcinoma, you can see KRAS mutation. This question from genetics. P43RB, they are all mutations that we see in spaghetti adenocarcinoma. I just talked to you that small cell lung cancer is a neuroendocrine cancer. It secretes certain hormones, ACTH. This leads to cushingoid feature. ADH, calcitonin, ANF, and gastrin-releasing peptide. So they are all secreted by small cell lung cancer. Out of this, ACTH is the single most important. Now, squamous cell lung cancer. It secretes PTH-like polypeptide. The PTH-like polypeptide, it leads to hypercalcemia. So that means in squamous cell there is only one thing is PTH-like polypeptide come from squamous, the rest all come from small cell. Point to be noted, small cell is secreting calcitonin, so hypocalcemia occurs. This point is not known to most of students. So remember, they talk about hypocalcemia, think about small cell, but hypercalcemia, squamous cell. Mesothelioma, they occur in asbestos exposure. It is not associated with smoking, only asbestos. Classically, pleural effusion, which is recurrent pleural effusion. Recurrent effusion means you treat, again fluid comes. You can diagnose by chest X-ray and CT scan. You can do biopsy of the pleural tissue, but there is no effective therapy. Mortality is almost 100%. But this is the single most important line in this particular slide. Superior vena cava obstruction is usually due to lung cancer. Shortness of breath is a feature. Swelling on the face, but the most important line, non-pulsatile raised JVP. This line, if you are getting, is 100% you are dealing with superior vena cava syndrome. There is no other condition where there is non-pulsatile JVP. And positive Pemberton sign is there. What is this? Patient sitting in front of you, normal color. The moment you raise the hand, patient raises the hand, his face becomes red. This is positive Pemberton sign. So there are two classical questions. Out of this is the single most important question. Non-pulsatile raised JVP is superior vena obstruction. You can get prominent vein in the upper chest. Pneumonia. Commonest cause of community-acquired pneumonia is Streptococcus pneumonia. Nosocomial pneumonia, which occurs after 48 hours of hospitalization, this is known to 90% people know. But 95% people do not know that it's up to 90 days discharge from the hospital. So from 48 hours of admission to 90 days after discharge, if pneumonia occurs, we call it as nosocomial pneumonia. Atypical pneumonia occurs due to Legionella, especially defective water tanks. Mycoplasma pneumonia, autoimmune hemolytic anemia. Chlamydia is parrot. In these cases, normally the clinical features are dry cough and they involve interstitial spaces. We use curve 65 score to see the severity of a pneumonia. We use OPD treatment. Hospital-acquired pneumonia, we use anti-pseudomonas. But ventilator-associated pneumonia, we give 3 antibiotics. This is the most important question. Macrolide like erythromycin or clarithromycin. Clarithromycin. Pulmonary embolism is a VVIP topic. Fat embolism. Respiratory distress or confusion, skin rash occurring 12 to 72 hours after a long bone fracture. So respiratory problem occurring in a patient of roadside accident where the patient has a fracture in the long bone, you think about fat embolism. Kazan disease occur in deep sea diver. This is due to air embolism. And then finally, pulmonary embolism is a VVIP topic. You'll be definitely getting one question from pulmonary embolism. A venous clot from the pelvis or leg, it can enter the lungs. Well, Virchow triad, hemostasis, endothelial damage, and hypercoagulability. This is a very important question from pathology. Virchow triad, which predisposed to any clot formation in the legs. Symptom of pulmonary embolism usually asymptomatic in 70% cases, no symptom at all. Nobody will come to know also. But otherwise, sudden onset of dyspnea, patient sitting, suddenly start doing like this thing, is the classical presentation. Tachycardia, pain chest, this is due to involvement of pleura. Hemoptysis and sudden death can occur. But this is the single most important line. Sudden onset of dyspnea is pulmonary embolism. Chest X-ray, you get Westermarck sign, Pala sign, Hampton hums, and I'll show you a picture. D-dimer, the D-dimer is nothing but fibrin degradation product. Fibrin degradation product is the best sensitive test. If FDP is not there, then it's not a case of pulmonary embolism. This is watermark sign that we see in pulmonary embolism. You get focal oligemia you are getting. Palla sign, enlarged right descending artery. Palla sign, you just have to remember the name. And Hampton hum, you get wedge-shaped opacity in the peripheral tissue is Hampton's hum. CT angiography is the best screening test, but conventional angiography is the most confirmatory test for pulmonary embolism. Sarcoidosis is a non-caseating granulomatous disease. Non-caseating. Caseating is tuberculosis. It's a granuloma is an organized collection of macrophages. When we talk about granuloma, any granuloma they talk about is a collection of macrophages, granuloma. Again, in sarcoidosis, no symptom, or dyspnea is the most common symptom. In the skin, you get erythema nodosum, lupus pernio. There can be Bell's palsy, seventh nerve palsy can be there. Uveitis, very, very important question, is often associated. Hypercalcemia, don't forget. Raise ACE level, don't forget. Chest X-ray is the best initial test. You get bilateral head endopathy. This slide, what you are seeing at the moment, is a very important slide. You are bound to get one question from this slide. So if chest X-ray, bilateral hilar endopathy will be there, and treatment is corticosteroids. Tuberculosis. Primary TB is the first infection with tubercle bacilli. When the tubercle bacilli enter the body, the first thing what he does is primary tuberculosis. Seen in children, middle and lower lung zone are mainly involved. So you get primary focus, so-called gone focus. Typical caseating granuloma are seen, caseating. Point to be noted, in sarcoidosis we got non-caseating. Here we are getting caseating. Gone complex, primary focus for involvement of the ipsilateral lymph node. That is gone complex. This is gone complex. This is gone focus. Okay, so be very careful when they talk about gone focus and gone complex. Or the newer drug for treatment of tuberculosis, linezolid, amoxiclavulinic acid combination, bedaquiline and delamanid. This, don't forget these two lines. And they are usually used for multi-drug resistance. When do you call multi-drug resistance? When the patient is resistant to both rifampicin and INH. Let's talk about neurology. Neurocutaneous syndromes. They're all autosomal dominant except Sturge-Weber. NF1, chromosome 17 is involved. And the classical finding that we get in this case is Capulets macule. Whenever they talk about Capulets macule, they are talking about NF1. NF2, 22. 222, easy to remember now. Acoustic neuroma, whenever they will talk about acoustic neuroma, 99% they will talk about neurofibromatosis too. Okay. Von Hippel-Lindau syndrome, hemangioblastoma, most common cerebellum, and it can lead to polycythemia. Again, very, very important question. So this is important, and this is important. And of course, this is important. You'll be definitely getting one question on NF, neurofibromatosis. Dementia. Alzheimer's disease. In Alzheimer's disease, the most common cause of dementia, irreversible dementia. Microscopically, you get neurotic plaque and neurofibrillary tangles. This question from pathology, but very frequently asked question. the decreased level of acetylcholine in the cerebral cortex. Donepezil is the drug of choice for Alzheimer's disease. Wernicke encephalopathy is due to vitamin B1 deficiency. The classical triad of symptom of this is global confusion, ophthalmoplegia, ataxia, Goa. Easy to remember, good mnemonic. Then we have one more condition called normal pressure hydrocephalus. Ataxia occurs. Urinary incontinence and dementia is a classical triad. Ataxia, incontinence, and dementia. And ataxia, this leads to magnetic gait. Magnetic gait. Headache. Migraine is a very important topic. Typically young ladies, 4 to 72 hours of the severe pain. Use the unilateral. Now the lady has come to you with severe pain. The abortive use are triptan, sumatriptan, NSAID or acetaminophen. This is to treat the acute pain. But for prevention, we use beta blocker, so-called propranolol is a very widely used drug. Newer drugs include telcagipran or erinumab. The new drugs is also CGPR antagonist. Both are CGPR antagonists. So you should know the latest drugs. Cluster headache. Classically, for acute severe pain, you use 100% oxygen. Verapamil is the best initial prophylactic drug. So treatment of acute pain is 100% oxygen, but for prophylaxis, verapamil. Trigeminal neuralgia you treat by carbamazepine or carbazepine, because they are used for neuralgic pains. Tricuspid neuralgia is a type of neuralgic pain, so we are using drug like carbamazepine. Cerebral hemisphere, frontal lobe lesion, it can lead to Foster-Cady syndrome. And there can be disinhibition syndrome. The person becomes antisocial. Is classically either antisocial or it may be having Foster-Cady syndrome. Gertzmann syndrome, which occurs due to dominant parietal lobe lesion. Acalculia, he is not able to do simple calculation. Agraphia, he cannot write. He cannot do calculation, he cannot write. Finger anemia, he forgot whether it's index finger or thumb, and he's not able to differentiate right or left. He's not able to differentiate. Gertzmann syndrome. Speech. In the speech, this is the brain. Here is in the temporal lobe, we have a auditory center. In the superior temporal gyrus, superior temporal gyrus, we have a Wernicke area, so-called sensory speech area. If the Wernicke area is damaged, this one, superior, this is Wernicke area. If this is damaged, speech understanding is lost. In Broca's aphasia, motor speech, that means he's not able to speak out. Speech outflow or fluency is lost. Broca's area lies in inferior. This is the Broca's area. It lies in inferior frontal gyrus. And these two are united via arcuate fasciculus. Arcuate fascicle. If this is damaged, repetition will be lost. To summarize, Wernicke area damage he is not able to understand. Broca's area he is not able to speak out. And if arcuate fascicle gone, he is not able to repeat. Meningitis, pyogenic, highly raised in CS examination. This is a VVIP topic. You are bound to get one question from this slide. So in case of pyogenic meningitis, CSF will show highly raised polymorph and sugar is highly reduced. CSF sugar is highly reduced, it may be near zero. In tubercular meningitis, lymphocytes are raised and protein level are very, very high in CS. So that means the type of cell are different and the amount of protein and sugar is different in pyogenic and TB meningitis. Myasthenia gravis is a neuromuscular junction disease. Autoantibodies are there which arise from thymus and is often associated with thymoma. Young women or older men, something very unique. Ladies, they are involved in the younger age group and the elderly people are involved in the men in the elderly people. Drugs that can exacerbate macrolide, quinolones and aminoglycoside. Don't forget this question from pharmacology. Okay, macrolide like erythromycin, quinolone like ciprofloxacin, gentamicin. So these are drugs that can exacerbate, so don't use this. Dermatomyositis, certain skin signs are there. Shawl sign, heliotropic rash over the upper eyelid, Gorton sign, mechanic hand and V sign. This should be in your fingertips. Out of this also, this is the single most important thing but they ask you. Skin sign in dermatomyositis. So this is a shawl sign. This was a shawl sign. This is heliotropic rash, so-called raccoon eyes. This is the Gorton sign. Mechanic hand are rough hands. V sign over the chest. So with the picture also, now you'll not forget. Skin sign. Bell's palsy. Both upper and lower part of the face are involved. Ipsilateral face, same side of the face is involved. Patient is not able to close the lip. And look at my face. Now the face has been pulled to this side. Face is pulled to normal side. Hyperacusis. Whatever he's listening, looks very loud. Loss of taste sensation in anterior two-thirds of tongue. This question came last year also. Bell's phenomena is seen. You ask the patient to close the eye, eyeball roll upward. Bell palsy is again a VIP topic. Parkinson is caused by due to nigrostriatal pathway. Commonly asked question. The classical feature are resting tremor. This like this. Usually thumb is involved. Fascinating gait, small handwriting. Guillain-Barré syndrome, post-infectious polyneuropathy due to demyelination. It's a type of motor neuropathy. Usually by respiratory tract or jet infection, and the user bacteria, don't forget Campylobacter jejuni. This is the most important question, microbiology. If they have to ask question, they will ask you microdiscipline. Ascending type of weakness, that means the problem starts in the feet. It starts from the sole area, then come to the below knee, then above knee. It progressive upward, ascending type of weakness. And tendon reflexes are depressed. It's a type of lower motor neuron type of presentation is there. Albumin, cytoalbumin dissociation, cell count in CSF. Cell count is normal, but protein are raised. Cell count is normal, but protein are raised. And treatment is either immunoglobulin, or we can give plasmapheresis, or they are never done together. And this is much more widely used drug is immunoglobulin. Subarachnoid hemorrhage is a VVIIPPV topic. You'll be getting one question from SH. Most common cause is trauma. Second common cause is rupture of berry aneurysm. The clinical features include sudden severe headache never experienced before. This is the most important question and most frequently asked question. Sudden severe headache never experienced before is SAH. Non-contrastivity is the first investigation of choice. But most accurate test is CSF examination by lumbar puncture. You can see RBCs in CSF. CT scan can tell you 95% cases, but it's not 100% specific. Subdural hematoma, rupture of superior cerebral vein, so-called bridging veins. Trivial trauma can cause this. Again, a beautiful question from pharmacology. You'll be getting one question from this table. Phenytoin can lead to pseudolymphoma and it can lead to gum hyperplasia. Carbamazepine lead to aplastic anemia. Valproic weight gain and transient alopecia. Lamotrigine skin rash, ethosuximide bone marrow suppression, that is aplastic anemia. Topiramate renal stones. Phenobarbital skin rash. Levetiracetam, safe in pregnancy, no weight gain. This is all pure pharmacology. But this should be in your fingertips. If you are not able to write anything, you can click the photograph because time is short, content is too much, but again, we like to give you as much as possible. If you miss something, you can see it again also. Spinal cord diseases, thalamic syndrome lead to contralateral hemianesthesia. Syringomyelia, bilateral loss of pain, touch and temperature, this is known as dissociate anesthesia. Bilateral loss of pain, touch and temperature is dissociate anesthesia. Brown sequence syndrome, ipsilateral loss of position vibration and upper motor neuron feature, contralateral loss of pain, touch and temperature. This is Brown sequence syndrome. Okay. Stroke. Stroke, sudden onset of any neurological deficit. And that lasts for more than 24 hours. But if it resolves completely within 24 hours, we call it as TIA. The difference between stroke and TIA is duration of the problem. It lasts for more than 24 hours in stroke. It gets resolved within 24 hours, we call it as transient ischemic attack. Now, what happens if there is anterior cerebral arteries involved, paralysis of opposite foot and leg. Contralateral foot and leg is ACA. Same sensory loss, foot and leg, contralateral. MCA, middle cerebral artery, paralysis of contralateral face and arm. Face and arm. Leg was here. Leg involved is maybe but less than, arm involvement is more than leg. Leg area is involved is not much. Sensory loss over face and arm. That means there is contralateral motor and sensory lesion in arm and face is MCA. Contralateral loss in the leg is ACA. Now let's talk about endocrine. Diabetes. Diabetes is a VVIP topic. How we diagnose the case of diabetes? Fasting blood sugar more than 126. Random blood sugar more than 200 is diabetes. HbA1c more than 6.5% is diabetes. Certain drug can induce diabetes, thiazide and steroids. This is a very important question. Now, some drugs, GIP, GLP-1 agonists are exenatide, liraglutide. You got a newer drug, semaglutide, is given orally and subcutaneously. This is the most important question for you. Nowadays, the maximum discussion is about semaglutide, oral and subcutaneous. So don't forget this. DPP-4 inhibitor, sitagliptin and vildagliptin. They are given orally. They are tablets. Renal glucose transport inhibitor, canagliflozin and dapagliflozin. Long-acting insulin are determin and glargine. But now you got a newer insulin, degludec. The action lasts for 40 to 42 hours. That means you have to give alternate days. AD stands for alternate days. And we got one more drug, delaglutide, is again a GIP, GLP-1 agonist, which we can give once a week only. DKA is a VVVIIIPPP topic. You will be definitely getting one question from DKA. So I'm leaking the paper to you, but in a very honest way. DKA can come with abdominal pain, dehydration, severe dehydration. The tongue will be dry tongue. Small breathing, so-called acidotic breathing. Glycosuria plus ketonuria is DKA. There's only one condition where ketone and sugar will be there in the urine, that is DKA. There is no other condition. How to treat a case of DKA? You give IV fluid saline and you give short-acting regular insulin intravenous. Now let's talk about some complications of diabetes. Cardiovascular complications of diabetes are peripheral arterial disease. PAD is peripheral arterial disease, CAD coronary artery disease, and sudden death. Silent MI can occur. That means no pain, painless infarct. Wet gangrene can occur, and if you use ACEI and telmisartan, okay, they are the best drug because they control BP and they reduce nephropathy. Silglitazar is an anti-lipid drug. But it also reduces blood sugar also. Anti-lipid drug and reduces sugar also. Nephropathy. In diabetic nephropathy, first thing is raised GFR, the earliest feature. Normal GFR is 126, here GFR can go up to 140. Then comes the stage of microalbuminuria. That means the urine will have protein 30 to 300 milligram per day. Macroalbuminuria, more than 300 milligram per day of protein. Finally, end-stage renal disease, so-called chronic renal failure. Neuropathy, polyneuropathy, usually distal symmetrical and sensory loss. This is the most common. Patient complain of numbness. Autonomic neuropathy, because of this, patient can have postural hypotension. Painful neuropathy. Patient can have severe pain in the legs. Let's talk about thyroid gland. Drug which inhibit peripheral conversion of T4 to T3 are propranolol, dexamethasone, and propylthyrosol. This is a very VIP question, often asked in the exam. Treatment of hypothyroid, we give beta blocker. They reduce heart rate. Anti-thyroid medication, we can give carbimazole, but it causes placenta. So, don't give in first trimester. Don't give in first trimester. In first trimester, we use propylthyrosol because it does not cause placenta. But it can cause severe liver damage in the later half of pregnancy. So in the first half, we give propylthyrosol. Okay, but we do not give second and third trimester. We don't use this. Second, third, we use carbimazole. We can use radioiodine or we can give thyroid. We can do surgery also in case of hyperthyroid. Hypothyroid, the clinical features are toad-like face, myxedema. In myxedema, there is non-pitting edema. Non-pitting edema. Ankle jack relaxation is delayed. Carpal tunnel syndrome which compresses median nerve. Alopecia on the lateral one-third of the eyebrow is a classical finding in hypothyroid. Lab finding, TSH reduce, increase, T3, T4 reduce is a primary hypothyroid. But if all are reduced, that indicates secondary hypothyroid. Thyroiditis, Hemochromatosis, is the most common autoimmune cause of goitus hypothyroid. It's an autoimmune disease. Non-tender, rubber-like. This is very, very important. You palpate the gland, look like a rubber, but non-tender. Hurthal cell are seen, classical question from pathology. Anti-thyroglobulin antibody and thyroperoxidase antibodies, so-called TPO antibodies, will be there. Hemochromatosis is again a VIP topic. Decurvence, again a topic, painful. The previous one was rubber-like but non-painful. This is painful. Fever will be there. This is due to viral infection of the gland. Patient is transient thyrotoxicosis to begin with and later hypothyroid. Why? This the gland is in. Gland viral infection occur. All the preformed hormone is released. Suddenly there is increased hormone, thyroid hormone that lead to thyrotoxicosis to begin with. Later on, all preformed hormone gone. So now the hormone level will be reduced, patient will go into hypothyroid. And finally it will come back to normal level. This is decurvence. ESR raised, radioactive iodine uptake reduced, and it regresses spontaneously because it's a viral infection. Drug which can lead to hypothyroid, very, very important question, lithium and amiodarone. Don't forget these two lines. This is a VIP question from pharmacology. If patient has got hypothyroid with CAD, you start the dose, lowest possible dose. You start with 25 microgram per day, and later you can increase to 100 microgram or more than that per day is there. Okay, so point to be noted, we never start suddenly with a high dose. You start with the lowest possible dose. In myxedema, coma, this the first thing is given in hydrocortisone. This is a very frequently asked question. Then we give parental T3 and orally T4. The question they asked you, in a myxedema, coma, first drug to be given is always hydrocortisone, not T3, not T4. Let's talk about disease of the adrenal glands. We know Cushing syndrome. CS stands for Cushing syndrome. It can be ACTI dependent if the Cushing disease, which it comes from pituitary gland. But ACTI can come from ectopic secretion of the gland hormone. This is small cell lung cancer. But it can be non-ACTI dependent, independent, iatrogenic. Like you prescribe corticosteroid to any patient, right and left we prescribe, they can induce Cushing syndrome. Or adrenal adenoma or carcinoma, they can also lead to Cushing syndrome. Symptom can be due to excess of glucocorticoid effect, hyperglycemia. Patient become hyperglycemia. Excess of mineralocorticoid, it become high BP. Excess androgen lead to hirsutism, hair on the face of a lady, hirsutism. Adrenal failure, if it is primary, it causes increased ACTH. But if it is due to pituitary gland damage, so ACTH level will be reduced. So this is so-called primary adrenal failure, and this is known as secondary adrenal failure. So primary adrenal insufficiency occurs due to anatomical destruction of the gland. Secondly, due to hypopituitarism, I just mentioned you. And in primary, when the disease is in the gland, ACTH level increase, the point I mentioned to you. There will be mineralocorticoid deficiency, so BP will be low. When the mineralocorticoid was excess, it lead to hypertension. If it low, BP will low. And similarly, glucocorticoid deficiency, sugar value will be reduced. So now this patient has got low BP, low sugar. Hence, the commonest symptom of Addison disease is asthenia. Asthenia means fatigue, malaise, energy less. Patients of Addison disease feature are weight loss, asthenia, diarrhea or constipation, both can occur. Something very funny. Hyperpigmentation can be seen, but vitiligo can be associated with autoimmune cause. The clinical feature of Addison crisis, intractable vomiting, pain abdomen, low BP, coma, and death. We see in Addison crisis. Parathyroid gland. The treatment of chronic hypercalcemia, biphosphonate, glucocorticoid, especially in malignancy, induce hypercalcemia. Calcitonin, this will be there in your exam. Denosumab is a new drug we use to treat hypercalcemia. Hypoparathyroid, low calcium, low PTH, high phosphate. And due to low calcium, patient can have carpopedal spasm, so-called Taussig sinus there. Chauvistic sign, you tap over the angle of the mouth, and there will be, look at me, ipsilateral facial contraction. Facial muscle contraction. Treatment for tetany. For acute case, give injection calcium gluconate IV. But if tetany is occurring due to persistent vomiting, give IV saline. And sometimes, like hyperventilation, patient may just come to like, patient may come to you like this hyperventilation. It leads to respiratory alkalosis. And that can induce tetany. In such case, rebreathe from the same bag as the treatment. The treatment of tetany is different in 3 different situations. Pituitary disorder, acromegaly, growth hormone is somatotropin. Growth hormone releasing inhibitory factor is somatostatin, and somatomedin is also known as IGF-1. This is the most important. It's a one drug. Now we have got drug octreotide. It is a somatostatin analog. So in acromegaly, we give this drug because it's going to reduce growth hormone release from the pituitary gland. Investigation. Elevated IGF-1 the best initial test. Oral glucose test is the most confirmative test. Oral glucose tolerance. And to locate the tumor, we use MRI or CT scan. So for acromegaly treatment, we use somatostatin analog. Octreotide, I told you, is a type of growth hormone releasing inhibitory factor. Dopamine agonist cabergoline to this is to reduce to this is because to reduce prolactin level. Prolactin level are usually high in acromegaly that lead to galacturia. And finally, we do surgery, transfemoral surgery. Prolactinoma due to high amount of prolactin due to galacturia. Why is it so? We know that from the hypothalamus, dopamine comes. From pituitary, prolactin comes. It has got inhibitory effect on prolactin. That means prolactin is there, dopamine is there, but it has remained under inhibitory control. In pregnancy, this inhibition gone. Now more and more prolactin come, and that lead to lactation. This is a basic concept. So that means you are getting one patient, galacturia. What is galacturia? You are getting one any lady who is not pregnant. Okay, she is not pregnant and she is having milk in the breast. That is galacturia. So we will give any drug which is dopamine agonist. Dopamine agonist will lead to what? Inhibition of prolactin. Got it? But at the same time, if you are using any dopamine antagonist drug, it will lead to what? Increased prolactin level and galacturia will occur. So hyperprolactinemia occurs due to prolactinoma. That means the pituitary gland having tumor, prolactinoma. Or we are giving any dopamine antagonist drug. The cause of hyperprolactinemia may be physiological drug. I told you any drug which is a dopamine antagonist. Disease like prolactinoma or hypothyroid CRF cirrhosis, very, very important. Out of this is the single most important, hypothyroid. In hypothyroid, increased prolactin occur and that lead to galacturia. The clinical feature of a case of prolactinoma, increased prolactin lead to what? Galacturia. I told you milk in the breast of a non-pregnant lady. Otherwise, amenorrhea, galacturia, infertility in female. Males, decreased libido, again galacturia. Point to be noted, even the milk may be in the breast of the male also. Hypopituitarism. Treatment will be bromocriptine and cabergoline. Why? They're all dopamine agonists. This is the one dopamine agonist. So they will reduce prolactin level. Well, this is all for today's session. I hope in a limited time what I had, I tried to cover majority of things for you. Definitely, whatever I discussed, there will be at least few questions from what I told you. Try to revise tonight only. Well, just to inform you, just to update you, I've written a book so-called Medicine Simplified, Minnie Harrison. Okay, just to inform you, okay, that we also do MRCP and USMLE courses also DBMCI is doing. How was the session? Please do give feedback on this number. And if you have any query, you are more than welcome to talk to me on this WhatsApp number. I'll be too happy to reply to your queries. Best of luck for your exam tomorrow. Today is 20th. Tomorrow is your exam, 20th January 2024. Today is 19th of January. I wish you all the best. And I'm sure you will come up with the flying colors. But only one advice at the moment, read till 10 o'clock in the evening, then you sleep. You should have a sound sleep in the night. Don't commit the mistake of reading up to 4 o'clock in the morning. No. When you are going for exam, go with a fresh mind. Your energy level should be very high. Take a bath with the lukewarm water tomorrow morning and reach the examination center on time. Don't try to read in the examination center. Your energy level will be very fresh. You will be able to recall everything when you are in the examination hall. And I'm sure, and the moment you finish your exam, be in touch with us. We'll start preparing for your next destination, that is postgraduate MD seat in a good college. DBMCI is there. And otherwise also, if you need any guidance, you are welcome. Note it down number, or you can take a click or this photo card number. We are there to help you out in all possible way. But I hope in a limited time you could learn a lot. Am I right? So once again, wish you all the best for exam. Thank you very much. God bless you.
బాయ్ 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 తల్లి फोन नहीं देना बोल रही है उसको కానీ మాట్లాడద్దు మరి ఓకేనా మాట్లాడద్దు वो क्या हो गया राइस राइस है मैं राइस खा रही हूँ बोलना वेदांती इसको बाहर जाना है मेरे को हल्लू हल्लू से खिलाओ ये थोड़ा थोड़ा मैं स्टार्ट कर रही हूँ थोड़ा थोड़ा से खिलाओ हाँ 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 राश बैठना है वेदांशी किधर है गुड गर्ल ये मैं ఇగో కొంచెమే బుక్క మరి ఓకే స్టార్ట్ చేస్తున్నా స్టార్ట్ చేసి सर सर रहने दो वो बात नहीं किया तो काफी है ठीक है हल्लू से फिर लेके जाओ अगर बहुत डिस्टर्ब कर रहा है तो रो रहा है तो भी लेके जाना ठीक है सर दीदी इसको बोलो यहाँ पर दीदी का साथ आड़ा ఒకటి ఏదో మంచి గేమ్ నేర్పిస్తదంట ఆమె हेलो हाँ स्टार्ट करेंगे हाँ मैम हाँ आप कर दीजिए यहाँ से लाइव है अभी मेरा स्टार्ट स्ट्रीमिंग मैंने ऑन कर दिया मतलब क्लास शुरू हो गया क्या अरे आप ऑडियो वीडियो है तो बंद कर दीजिए एक सिंगल सेशन Hi students. Hi students. Welcome to the platform of Dr. Bhatia Medical Coaching Institute. Myself, I am Dr. Ramyasree. Am I audible and visible to all of you guys? Am I audible and visible to all of you? Right. So I'm going to discuss last minute important points in OBGYN in this session. So I hope I'm audible and visible to all of you. So the first thing I would like to tell you about is the decidua. The first thing what I want to tell you is about decidua. Right. So first thing I would like to speak about is the basic, that is decidua. So I just want you to keep listening. I'll share the PDF what I'm doing right now with all of you. You can use the PDF later. So this PDF I'm definitely going to share. I'm going to discuss some important points which you all should be knowing. So first thing what we are seeing here is the decidua. So we have three types of decidua. The decidua which is present below the baby. What do you call this decidua? The decidia which is present below the baby, this is called as decidia basalis. This is called as decidia basalis. Right? The decidia which is covering the baby. The decidia covering the baby is called as decidia capsularis. Correct, it is very difficult. Oh, no. The decidia which is covering the baby is called as decidia capsularis. The decidia which is covering the rest of the uterine cavity, this is called as decidia parietalis. Decidia parietalis. At 14 to 16 weeks, this decidia parietalis and capsularis can fuse with each other. And when decidia capsularis and parietalis fuses with each other, this part we call it as decidia vera. See, this part is called as decidia vera. That's all. That much if you know, more than enough. Now the MCQ which you people got is, what are the layers which form the double decidual sign? This question has come as an MCQ to you. So can you tell me what are the layers which form the double decidual sign? So what are the layers which form the double decidual sign? So the layers which form the double decidual sign are decidia capsularis plus decidia parietalis. So that is why you can remember it as cap. Decidia capsularis and decidia parietalis. So you can remember it as cap. Next, they will ask you regarding the images of the placenta. So the different images of the placenta what we have here are, so this one, the first one what you're seeing here, this is called a circumvallate placenta. This is called as circumvallate placenta. So circumvallate mainly causes antepartum hemorrhage and preterm labor. Circumvallate has double fold of amnion and chorion with a central depression. Circumvallate has a double fold of amnion and chorion with central depression. So this is uh, called as circumvallate. This is called as circumvallate, right? So it has a central depression with a double fold of amnion and chorion. So you can also call this as Panipuri placenta. Panipuri placenta, right? Now this one which has a single fold of amnion and chorion, single fold of amnion and chorion, this is called as circummarginate. Circummarginate. Circummarginate has a single fold of amnion and chorion and it has like a peripheral margin like this. Okay. This is succenturate lobe. When one cotyledon is separate from the entire placenta, this is called as succenturate lobe. Succenturate lobe. Now, because of the presence of succenturate lobe, this cotyledon can be left inside and it can cause secondary PPH. Uterus might not come back to its original size at the same time. That's called subinvolution, and it can lead to sepsis. Right? One small lobe is separate from the entire placenta is called as succenturate lobe. Right? Here itself, I would like to speak about PPH because PPH is also something very important. So whenever you have bleeding within, when do you call PPH? Blood loss of more than 500 ml during vaginal delivery. Blood loss during more than 500 ml during vaginal delivery. More than 1000 ml during LSCS. More than 1000 ml during LSCS. Blood loss of more than 10%. Dropping the hematocrit. Dropping the hematocrit. Guys, what is primary PPH? What is secondary PPH? What is primary PPH? What is secondary PPH? You got this question again. So primary PPH is bleeding within first 24 hours. Bleeding within 24 hours. Whereas secondary PPH is bleeding after 24 hours, but within 12 weeks. So primary PPH is bleeding within 24 hours. Secondary PPH is bleeding after 24 hours, but within 12 weeks. Right? Most common cause of primary PPH is atonicity, whereas most common cause of secondary PPH is tissue, retained placenta or tissue. Hi Yasir, I'm fine. How are you? Right. So whenever the placenta is attached to the membranes, it's called velamentous placenta or membranous placenta. Or kada. So whenever the cord is attached to membranes, it is called velamentous placenta or membranous placenta. What will be the risk associated with velamentous or membranous placenta, guys? The risk associated with velamentous or membranous placenta is it can cause fetal hemorrhage. Fetal hemorrhage. So this image comes, you should pakka answer in the exam. Okay? What is this, guys? What is this? When fetal vessels overlie the internal os, only fetal vessels with membranes overlie the internal os, then we call it as vasa previa. Vasa previa, right? So vasa previa can be due to which types of placenta? Vasa previa can be due to, this is not placenta previa. Placenta previa mein placenta will be over the internal os. When fetal vessels with membranes are over the internal os, this is called as vasa previa. Vasa previa may you will have succenturate lobe can present you with vasa previa, succenturate lobe, velamentous placenta, right? And placenta bilobata. All these three can present you with vasa previa. And in these patients with vasa previa, the mode of delivery will be LSCS. The mode of delivery will be LSCS, right? Yes. Whenever you have cord presentation or cord prolapse, agar only the umbilical cord is present over here, cord prolapse or cord presentation also we go for LSCS. And the cord prolapse may, you should never touch the cord. You should remember that you should never touch the cord, right? So on the whole, what is this? This is succenturate. When cord is attached to the margin of the placenta, this is called battledore or marginal. This is circumvallate, and this is velamentous, and this is velamentous, right? Yes. What is this procedure, guys? What is this procedure? When you have a small needle going into the placenta. This is called as chorionic villus sampling. This is called as chorionic villus sampling. Chorionic villus sampling. Right? Now this one, this is called as amniocentesis. 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 Here when the needle goes into the umbilical cord, this is called as chordocentesis. 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 Right? So we have amniocentesis, we have chorionic villus sampling and chordocentesis. Right? So now I want to speak about few words about the aneuploid screening. So what is trisomy 13? 13 के एज में पटाना शुरू करना है. So trisomy 13 is पटाऊ. पटाऊ. 18 के एज में एंगेज होना है. So trisomy 18 is Edward. Edward. Trisomy 21. 21 age settle down. So downs. 13 is Patau, 18 is Edward, 21 is settled is downs. So 13 Patau, 18 Edward, 21 downs. The aneuploidy screening may, in aneuploidy screening, first trimester, aneuploidy screening in the first trimester between 11 to 14 weeks. So we have combined screening method between 11 to 14 weeks. This combined screening method between 11 to 14 weeks, I ask you to remember as beta, that is beta HCG, Papa, that is PAP A, pregnancy associated plasma protein A, and ANTI, that is NT scan. So combined screening method is done between 11 to 14 weeks. And what are the parameters we have under the combined screening method? Beta, Papa, ANTI. So beta HCG, PAP A, and NT scan. Right? And in second trimester, what is the screening method choice we have? Second trimester में screening method of choice what we have is quadruple marker. Quadruple marker. So quadruple marker what we have is beta HCG plus inhibin A plus alpha fetoprotein plus unconjugated estriol. H for in downs, H for high, HCG will increase. I for inhibin A, that will also increase. Alpha fetoprotein and unconjugated estriol will decrease. So triple marker is outdated. What we have right now is the quadruple marker, which is beta HCG plus inhibin A plus alpha fetoprotein and unconjugated estriol. Now, 99% detection rate is with cell-free fetal DNA, guys. Cell-free fetal DNA. Right? Confirmatory tests are chorionic villus sampling, amniocentesis, and chordocentesis. Chorionic villus sampling is done between 10 to 13 weeks of gestation. Amniocentesis is done between 15 to 20 weeks of gestation. Chordocentesis is done between 18 to 20 weeks of gestation. Chorionic villus sampling में we take trophoblasts. Amniocentesis we take amniocytes, that is the fetal skin epithelial cells. Chordocentesis में we take fetal WBC. In chorionic villus sampling, you get the report within 1 week. In amniocentesis also you get within 1 week. Chordocentesis you get within 48 hours. Abortion rate is highest for chordocentesis, it is 2 to 3%. This is less than 0.5 and 0.5%. Right? Okay, now coming to the pelvis. So pelvis may most important is the anteroposterior diameter of the inlet. So this is called as pelvis. This is called as pelvis, right? So in the pelvis, this part is called as inlet. Of the inlet. So the anteroposterior diameters of the inlet, what we have is so we have inlet, cavity, outlet. Inlet is transversely oval, guys. So what you're seeing here, this part is called inlet. Do you agree this is called inlet? See, this part is the inlet. Then the inside is called cavity. And the outer surface is the lower part, the exit part will be called as outlet. Okay? So, inlet may the anteroposterior diameter, oblique diameter and transverse diameter. Inlet is transversely oval. So anteroposterior is 11 centimeters, oblique is 12 centimeters, transverse is 13 centimeters. Cavity is circular, everything is 12. Outlet is anteroposteriorly oval. That is 13 centimeters, oblique is 12 centimeters, transverse is 11 centimeters. If you remember this grid, you can answer everything in the pelvis. If you remember this grid, you can answer most of the things in the pelvis. Okay. So this grid is something very important for the pelvis to be understood. Okay. Right. Now, in the inlet, the anteroposterior diameters, we have 3 anteroposterior diameters, guys. Can you see here? Where the posterior point is all same, that is sacral promontory. But the lower portion is changing. From the sacral promontory to the lower part of the pubic symphysis is called diagonal conjugate. From sacral promontory to the posterior surface of pubic symphysis is called obstetric conjugate. From the sacral promontory to upper border of pubic symphysis is called true conjugate. So from below upwards, you can remember it as dot. From below upwards, you can remember it as dot. Okay. So you have diagonal, obstetric and true conjugate. Diagonal, obstetric and true conjugate. Okay, now I want you to tell me what are the pelvis may. Another thing which you should know in the pelvis is the types of pelvis. We mainly have 4 types of pelvis. Gynecoid is a good pelvis. Gynecoid, android, anthropoid and platypelloid. Right? So we have gynecoid, android, anthropoid and platypelloid. Gynecoid is most common and it is circular. Android is worst prognosis and it is triangular. Anthropoid is anteroposteriorly oval. Platypelloid is transversely oval. Platypelloid is least common. Platypelloid is least common. Which will have android will have ischial spines prominent. Android will have ischial spines prominent and subpubic angle less than 85 degrees. and subpubic angle less than 85 degrees. Yes, android is heart shaped also, you can tell. Okay, right? And gynecoid is a good pelvis. Android favors deep transverse arrest and OP position. Whereas platypelloid, anthropoid favors what, guys? Anthropoid favors face to pubis delivery. Face to pubis delivery. Whereas platypelloid favors face presentation. Platypelloid favors face presentation. Okay? Yes. What are the cardinal movements of labor? What are the cardinal movements of labor? So the cardinal movements of labor are we have engagement, descent, flexion, engagement, descent, flexion, internal rotation. After internal rotation, the baby's head will rotate once it touches the levator ani muscle. Then the baby's head starts stretching the vulval outlet. That is called crowning. After crowning, the delivery of the fetal head will be by extension. Delivery of fetal head by extension. Right? So we have engagement, descent, flexion, internal rotation, crowning, and delivery of the fetal head by extension. Once the delivery of the fetal head occurs by extension, 1/8 rotating back is called restitution. Another 1/8 rotating back is called as external rotation. Okay. Leopold maneuvers are also something very, very important. The first image, what you're seeing here, you're trying to palpate the fetal buttocks. When you're trying to palpate the upper pole of the uterus, this is called as Leopold first maneuver. This is called Leopold first maneuver. This Leopold first method is also called as fundal grip. Fundal grip. So in fundal grip, if you feel there are multiple knob-like structures, sorry, if you feel there is a smooth fundal grip mein, if you feel there is a hard curved ballotable structure, then it is head. If you feel there is a soft broad irregular structure, then it is the buttocks. This is a Leopold first maneuver. Leopold first maneuver mainly palpates the upper pole of the uterus. Leopold second maneuver is also called as Leopold first maneuver is also called as fundal grip, whereas second maneuver is called as lateral grip or umbilical grip. Correct, guys? Lateral grip or umbilical grip. So in Leopold second maneuver, if you feel there are multiple knob-like structure, then they are fetal limbs. If you feel there is a smooth curvilinear resistance, then it is the fetal back. Smooth curvilinear is the back, multiple knob-like structures is the limbs. Next we have third Leopold maneuver, which is also called as pollix. Thumb on one side, 4 fingers on other side. So when you try to hold the baby's head, and if the head is completely ballotable, it is not engaged. If head is not ballotable, then it is engaged. So it tells us whether the head is engaged or not engaged. Fourth Leopold is to confirm the third Leopold. It's also called pelvic grip, second pelvic grip. If your both hands are converging and goes below the presenting part, then it is not engaged. If your both hands are diverging, then it is engaged. Okay. Right. So what is this maneuver which you are seeing? The maneuver here, what we are seeing, this is called as Ridgen's maneuver. This Ridgen's maneuver is mainly done to for the delivery of the baby. This Ridgen's maneuver is mainly done for the delivery of the baby, right? So coming to the stages of labor. How many stages of labor do we have? So we have 4 stages of labor. We have 4 stages of labor. So in the 4 stages of labor, first stage of labor is four stages of labor. First stage is from the onset of true labor pains to full dilatation. First stage is further divided into latent phase and active phase. Latent phase is 0 to 5 centimeters, 5 to 10 centimeters according to WHO, right? So according to WHO, this is the latent and active phase. According to Williams, it is 0 to 6 and 6 to 10. Basically, if you have a doubt where to write 6, then you can write 0 to 4 and 5 to 10, 0 to 5, 6 to 10. This will be the most appropriate answer, right? Okay. Now, next coming to the second stage. And always remember, latent phase may do nothing. Just wait and watch. Don't do anything. Latent phase may don't do anything. Just wait and watch. Okay? Second stage में you have again normal. What is an average time taken for second stage? Prolonged second stage, and we have second stage arrest. Okay, so again primi multi. Primi, you can remember this as 1, 2, 3. For primi, the average duration of second stage is 1 hour, right? Prolonged second stage in primi is 2 hours. Second stage arrest is 3 hours, right? Yeah, and second stage is from full dilatation to till delivery. Correct, Lakshmi. Full dilatation to delivery. Third stage is half. Multimate is always half. On an average, it takes 30 minutes. Prolonged second stage is 1 hour. Second stage arrest is 2 hours. So normally we do Ridgen's maneuver. Prolonged second stage, you have to see the station of the fetal head. If station is above +2, then you can go for LSCS. If station is below +2, then you'll go for instrumental delivery. Second stage arrest, you'll directly go for LSCS. Yes. What is this? This is called control cord traction or Branch-Andrew method. So this is mainly seen in third stage of labor. So this is control cord traction or Branch-Andrew method, which is mainly seen in third stage of labor. है ना? Right. What are the components of active management of third stage of labor, guys? What are the components of active management of third stage of labor? So active management of third stage of labor, you can remember it as IDBI. So we have intermittent uterine tone assessment. delayed cord clamping, Brand's Andrew method, and so first actually is not intermittent, last may you can write intermittent. First is injection uterotonic drugs. Injection uterotonic drugs. So what are the different uterotonic drugs we have? So you can either give oxytocin or you can give methergin or you can give misoprostol. Oxytocin is 10 international units. IM or IV in drip. Never give oxytocin IV bolus. If you give IV bolus of oxytocin, it can lead to arrhythmias. Methergin is 0.2 milligrams IM or IV. Misoprostol is 600 micrograms per rectal. That's the active management of third stage of labor. That's the active management of third stage of labor. Now, whenever you're doing this, you don't put this above hand and then you just pull the placenta. You always carry the risk of uterine inversion. Uterine inversion. You got a question on uterine inversion, guys. So what is uterine inversion? Uterine inversion is inside out pulling of the uterus. So uterine inversion is inside out pulling of the uterus. Mainly it is due to mismanaged third stage. Mainly it is due to mismanaged third stage. So what will you do for uterine inversion? Here in the question they'll mainly tell you that shock is out of proportion to bleeding. Shock is out of proportion to bleeding. So in uterine inversion, the main treatment is reposition of the uterus back. It's called Johnson's maneuver. It's called modified Johnson's maneuver. We have to go for reposition of the uterus back. Okay. So this is the external cephalic version. What we do for breach. So external cephalic version has only 50% success rate. So external cephalic version, what are the prerequisites for doing the external cephalic version? Yeah, and one more thing, in uterine inversion, after you reposition the uterus, then you will remove the placenta. Okay, first reposition and then remove the placenta. ECV, the prerequisites are gestational age should be more than 36 weeks. Liquor should be adequate. Membranes intact. It should be single fetus. Gestational age should be more than 36 weeks. Liquor should be adequate. Membrane should be intact. Should be a single fetus. Right? And so gestational age will be more than 36 weeks. Liquor should be adequate. Membrane should be intact. It should be a single fetus. And there should be no contraindication for vaginal delivery. There should be no contraindication for vaginal delivery. Okay. This is also a method for the external cephalic version. This is called forward roll. So this is also one of the method for delivering the dorso-posterior breech. So this is called as modified Prague method. Modified Prague method. So modified Prague method is mainly used for dorso-posterior breech. Dorso-posterior breech, right? So I'm going to show you different methods for the aftercoming head of breech delivery. So here we are giving suprapubic pressure plus malar flexion, but there is no shoulder traction. This is called as Vigor-Martin. This is called as Vigor-Martin for the aftercoming head of breech. We use this. Now here if you observe, there is suprapubic pressure, there is shoulder traction, and there is malar flexion. So this is called as modified Mauritius-Smelly-Wheat maneuver. This is called as modified Mauritius-Smelly-Wheat maneuver, right? Now this is called Losset's maneuver. This we do for extended arm or nuchally displaced arm. When you hold the baby and rotate 180 degrees in the anteroposterior diameter. So it's called Losset's maneuver, which is used for after coming head of breech. So it is for the extended arm or nuchal displacement of the arm. Okay, guys. What is this? Can you guess this one? So this is done for the arrested lower limb. So this arrested lower limb, this is called as Pinard's maneuver. Pinard's maneuver. Okay. This is called burn marshal, where you hold the baby at the ankle and pull up vertically as an arm. Right. Now this also looks like external cephalic version, but this is not external cephalic version. Here you are putting your hand inside and holding the baby's feet and pulling it out. This is called as internal podalic version. So where do we do internal podalic version, guys? Internal podalic version is mainly done in second twin, transverse lie second twin. So internal podalic version is only done for transverse lie second twin. Right. So what do we have in the twins? So in twins, the mode of delivery is mainly decided by the first twin. If first twin is cephal, you'll always do vaginal delivery. You'll always do vaginal delivery. If second twin is non-vertex, if it is breech, you do assisted breech vaginal delivery. Second twin is breech, you do assisted vaginal breech delivery. You will do assisted vaginal breech delivery. Right. Next, if second twin is transverse lie, then you'll do internal podalic version followed by breech extraction. Followed by breech extraction. Right. So if first twin is cephal, you'll do vaginal delivery. If second twin is breech, you'll do assisted vaginal breech delivery. Second twin is transverse lie, you'll do internal podalic version followed by breech extraction. Okay. Right. Now that's very important about the twins. Twins may, what is the mode of delivery is, so twins may, if it is dichorionic diamniotic, it depends on the first twin. First twin vertex, you'll go for vaginal delivery. Agar first twin non-vertex, you'll always go for LSCS. So what are the indications for LSCS is, when first twin is non-cephalic, okay, MCMA, monochorionic monoamniotic, triplets, twin to twin transfusion syndrome. These are certain indications where we directly go for LSCS. Okay? Right. So these are the tamponade methods what we use in the postpartum hemorrhage. Right. So postpartum hemorrhage mein first we can do medical methods. If medical methods fail, then we go for tamponade methods. So these are the different tamponade methods what we have for the PPH. So this is called Foley's bulb. This is called Bakri balloon. Bakri balloon, the maximum fluid which can be instilled in a Bakri balloon is 500 ml. Then we have Sengstaken Blakemore. Sengstaken Blakemore. Sengstaken Blakemore is also used. Then we have the PPH tamponade. PPH tamponade is called as Shivker's pack. PPH tamponade is called as Shivker's pack. This is a condom tamponade. This is called as Shivker's pack. This is condom tamponade. This is called Shivker's pack. Okay. Right, guys? This is called Shivker's pack. If the tamponade fails, then we go for sutures. So this is called Beal-in suture. You also can get the image of Beal-in suture. This is mainly applied on the uterus. You go from the one wall of the uterus, you go to posterior wall, then go to the other side and then come out and tie it. So Beal-in uterus. This is the uterine inversion, which I already told you. In uterine inversion, you just push the uterus back. That's called Johnson's method. After you push the uterus back, then what are you going to do? Then you are going to remove the placenta and start oxytocin, right? In uterine inversion, shock will be out of proportion to the bleeding. Shock will be out of proportion to the bleeding because shock is due to two reasons. One is neurogenic shock, another is hemorrhagic shock. So that is why shock will be out of proportion to the bleeding, right? Yes. So can you tell me what are these? This is placenta previa. So if you observe the first picture is the low-lying placenta, guys. The first picture is low-lying placenta. So in low-lying placenta, placenta is within 2 centimeters from the internal os. Second picture is type 1. The first one is type 1. The second one is type 2. Type 2 में placenta is at the margin of the os. It's also called marginal placenta previa. It's also called marginal placenta previa. Third is partially covering the os. Partially covering the os. Fourth is totally covering the os. Fourth is totally covering the os. Placenta previa mainly present to you with painless bleeding. Uterus will be completely relaxed. Baby will be ulta pulta. Malpresentations will be seen. And in placenta previa, that whenever you push the presenting part into the pelvis, it will go hit the placenta and the heart rate will drop down. That is called Stahl-Worthy sign. So in placenta previa, Stahl-Worthy sign is positive. And in placenta previa, we'll do elective LSCS. In placenta previa, if the patient presents to you with bleeding before 36 weeks, then we can wait and watch, and that we call it as McAfee and Johnson's regimen. McAfee and Johnson's regimen. But here, थोड़े important points you remember, it's more than enough. So it will cause painless bleeding. They'll have uterus relaxed, malpresentations are frequent, Stahl-Worthy sign will be positive, and the expectant management is McAfee and Johnson's, and we do elective LSCS here. Okay. Now, the cervix slowly can start opening and can lead to preterm labor. The pattern of opening of the cervix is called TYVU. See this here, the cervix is completely closed. Then it will open at first above and then down. Then it will open from above to below and then it will open above to below with bulge of membranes. So it's called TYVU. TYVU. And what is when do you call cervical incompetence? Cervical incompetence is when cervical length is less than 2.5 centimeters, and this mainly present to you with second trimester abortions. And here what you have to do, mainly you have to put a cerclage from all 4 quadrants. So we do mainly McDonald cerclage. We mainly do McDonald cerclage. Okay. Right. Next, hypertensive disorders may, to check for the fetal well-being, always very important is to check the umbilical artery Doppler, guys. So this is the umbilical artery Doppler, what you're seeing here. So in the umbilical artery Doppler, this is a systole, this is a diastole. This is a systole, this is a diastole. So when we have, usually we'll always have diastole reduced. So whenever there is a blood flow to the baby is compromised, diastole will reduce. So that's called reduced diastolic flow. So reduced diastolic flow, that is when S by D ratio is less than 3, you have to deliver them by 37 weeks. Next, you have something called as absent diastolic flow. Absent diastolic flow may you deliver by 34 weeks. And you can also have reversal, the diastole blood going back. That's called reverse diastolic flow. Reverse diastolic flow, you deliver them by 30 to 32 weeks. Okay. So what does the partograph indicators? So, you know, in the pathograph, you have one column for the contractions. So this color coded, these colors are mainly for the contractions. So whenever there is a mild contraction, it is put like a dot like this. So that means less than 20 seconds only the contraction has come. When the contraction lasts for 20 to 40 seconds, you are going to put vertical lines like this. And when the contraction is lasting for more than 40 seconds, you're going to see complete black, right? So we have less than 20 seconds, 20 to 40 seconds, and more than 40 seconds. What is this, guys? So how is your preparation going on? How did you all prepare for your exam? So Yasir, Lakshmi, how is your preparation going on? I hope you're all prepared very well. So the last one day, don't think about much. Just be free, like whatever possible. Just keep seeing, and then you're gonna rock in the exam. Don't worry at all. Just be positive. Just be positive, right? Thank you, Shivam. Yes, I had two consecutive sessions to be frank. Right. So just be positive for your exam. Just give your 100%. Be cool and calm. Only if you're cool and calm, then only you can give your best. So whatever I am trying to discuss are some possible points which might come tomorrow. Hopefully, let's keep our fingers crossed that what we are discussing we get in the exam tomorrow, hai na? Right? So next, if you see this picture, thank you so much, Shivam. Thank you so much. So if you see this picture, this is a picture of anencephaly. There is no brain here. There is no brain here. So this is anencephaly. So this is also called as frog eye sign or Mickey Mouse sign. Whenever you see anencephaly, so if you see anencephaly at 28 weeks, what will you do? Whenever you see anencephaly, you have to terminate. Whenever you see anencephaly, you can terminate. So there are recent MTP guidelines which are released. So according to recent MTP guidelines, for genetic disorders, and for rape and incest, that is humanitarian ground, for genetic disorders, rape, incest, and humanitarian ground, we terminate up to 24 weeks. And for lethal anomalies like anencephaly and all, there is no upper limit of termination. There is no upper limit of termination. Here you will terminate up to, here you can terminate up to any trimester, no upper limit. But who will decide that this is a lethal anomaly? It is by a group of doctors which consists of gynecologist, radiologist, pediatrician, and members notified by the state government. Okay? And up to 20 weeks, one doctor opinion. 20 to 24 weeks, two doctor opinion. And bill has replaced married woman and her husband to woman and her partner. To woman and her partner. Right? So married woman and her husband, bill has replaced to woman and her partner. Okay? Next. And consent of the only woman is required. You don't require to take the husband consent or anybody's. And in less than 18 years, you require the guardian consent. And we are going to maintain the privacy. For contraception failure, the upper limit is 20 weeks. For contraception failure, the upper limit is 20 weeks. For contraception failure, the upper limit is 20 weeks. Okay. So this is about the new MTP guidelines which you should know. Now next, this is called Spalding sign, which is mainly seen in the intrauterine death, right? Now I would like to tell you one more thing here. So this is called lemon sign. This is called lemon sign, guys. This lemon sign is mainly seen in spina bifida. This is mainly due to scalloping of the frontal bone. This is mainly seen in spina bifida. Lemon sign mainly seen in spina bifida. Okay. See, this looks like a lemon, no? Looks like a lemon. So where you're having the scalloping of the frontal bones. You also have banana sign here. So where the cerebellum will be elongated and it will look like a banana. Okay. Yes. So this is the hydrops vitalis. Hydrops can be due to both immune and non-immune, guys. Immune hydrops vitalis is mainly due to Rh isomerization. Non-immune hydrops vitalis is mainly by most common organism is parvovirus. Parvovirus. Okay. Right. Now, regarding shoulder dystocia. So shoulder dystocia is head to shoulder delivery time taking more than 1 minute. Shoulder dystocia will happen whenever baby is too big. So what are the maneuvers we do? First we call for help. Then you bring the patient to the edge of the table. Then we do Mac Roberts. Mac Roberts may you hyperflex both the limbs on the abdomen and abduct. Okay? After Mac Roberts, you will give suprapubic pressure like this. After Mac Roberts, you will give suprapubic pressure like this. Then we have Wood's corkscrew, where with two hands you're progressively rotating the shoulder. Wood's corkscrew. See, this is the Wood's corkscrew. Then you can extract the arm from inside. That's called post-arm extraction. Baby doesn't come out by this. That also we go for Gaskins or all fours position. If baby doesn't come out by that, and repeat all like a cat or dog, you pick the mother and then you repeat all. And if baby doesn't come out by that also, you push the baby's head inside and go for cesarean section, that is Zanavelli. You can break the clavicle of the baby, that's sclerotomy, or you can do symphysiotomy, right? I repeat again all the maneuvers, just the names you remember. Mac Roberts, suprapubic pressure, Wood's corkscrew, posterior arm extraction, all fours, and then the extreme procedures. That's all. These are all the maneuvers what we have for shoulder dystocia. These are all the maneuvers for the shoulder dystocia. Next important I think might come as the biophysical profile components. The components for biophysical profile, you can remember it as BAN-MO2. So biophysical profile will mainly tell you about the fetal well-being. So BAN-MO2, B stands for breathing, guys, breathing. A stands for amniotic fluid volume. N stands for non-stress test. ये हो गया BAN. MO2. MO stands for movements. So you can see 3 discrete movements. Tone 1 episode of flexion and extension. Right? So this is all time taking because it's a 30 minutes ultrasound. So you also have modified biophysical profile. Modified biophysical profile is only NST plus AFI. Only NST plus AFI. Right? Right. So next, corpus luteum functions maximum on which day? So corpus luteum functions maximum on which day after implantation is usually day 8. So you can go for day 9. So that is why day 22 and all you can always measure the serum progesterone, and if it is more than 5 nanogram per ml, it means you are dealing with ovulatory cycles. You're dealing with ovulatory cycles. So what is the peak levels of estrogen which will cause LH surge onset? 200 picogram per ml, lasting for whenever the estrogen levels become 200 picogram per ml, lasting for 48 to 50 hours. Then it will cause LH surge. So positive feedback by LH surge will lead to ovulation. LH surge onset to ovulation will take around 36 hours. LH surge onset to ovulation will take around 36 hours. Whereas LH surge peak to ovulation, LH surge peak to ovulation will take 10 to 12 hours. LH surge peak to ovulation will take 10 to 12 hours. Right? Okay. So all of the following are raised in a patient with PCOS except, so here if you see PCOS may you'll have ovary studded with multiple small follicles. Because of this multiple small follicles, there will be rise in AMH. In PCOS, they'll also have insulin and LH. It is not inhibin A which rises, inhibin B. Always remember inhibin A is secreted only post ovulation from the corpus luteum, and PCOS will have anovulatory cycles, so inhibin A will not rise in patients with PCOS, right? So you should always remember regarding PCOS management at least. So PCOS may, when somebody is having irregular cycles, we give combined oral contraceptive pills. First principal management is weight loss in PCOS. Always first principal management is weight loss. And if somebody is having irregular cycles, you are going to give combined oral contraceptive pills. Next, if somebody is having hirsutism, then we give combined oral contraceptive pills with cyproterone acetate. Right? And if they're infertile, then you can give letrozole, clomiphene citrate, or you can give laparoscopic ovarian drilling. But laparoscopic ovarian drilling is last resort. And if they are obese and having insulin resistance, then we give metformin. Or myoinositol. Okay. 35-year-old female with heavy menstrual bleeding first tried to be on medical management, tried to be managed on non-hormonal treatment, failed. What is the next management? See, when it is reproductive age group, if somebody has heavy menstrual bleeding, we check the UPT and we check for hormonal state, like any structural disorders and all. But if they don't have any, if they're not responding to hormonal, you can always go for non-hormonal, then you can always go for hormonal. But same patient age would have been 45 years, then I will go for endometrial sampling. Because 45 years mein you're more tensed about endometrial hyperplasias and endometrial cancers. Okay. So ye keep remember this. Heavy menstrual bleeding is bleeding for more than 8 days and more than 80 ml. Right? More than 8 days and more than 80 ml. So most common cause of puberty menorrhagia is anovulation. Here you will mainly give the non-hormonal treatment itself, right? Most common cause for reproductive age menorrhagia or reproductive heavy menstrual bleeding is pregnancy related complications. And most commonly in the premenopausal is due to again anovulation, but you always have to rule out the endometrial hyperplasias and cancers. So in premenopausal always you have to do endometrial biopsy. Okay. When do you call delayed puberty? No menarche by age 15, no menarche by age 16, no breast development by 14, no breast development by 15. So, delayed puberty is called when there is no breast development by age 13 and no menarche by age 16. It's not same as the primary amenorrhea. So, no menarche by 16 or no breast development by 13. Right? 35-year-old mother of 2 children is suffering from amenorrhea for last 2 months. She has a history of failure of lactation following second delivery, but she remained asymptomatic thereafter. Skull X-ray shows empty sella. What is the hormone? First hormone to be lost. Guys, what do you think is the diagnosis here? So the diagnosis here is Sheehan syndrome. Excellent, Lakshmi Devi. Sheehan syndrome. So what do we do in Sheehan syndrome? In Sheehan syndrome, we mainly give the growth hormone. First to be lost is the growth hormone. So Sheehan syndrome is postpartum PPH leading to pituitary necrosis. Postpartum PPH leading to pituitary necrosis. Okay. This is also one of your PYQ, guys. What is the treatment of choice for septate uterus? Septate uterus is the most common uterine anomaly. So you have a septum inside the uterus. So what will you do for septate uterus? Transverse metroplasty, Jonas metroplasty, transcervical hysteroscopic septal resection, transabdominal septate resection. So for septate uterus, what we'll do? We'll remove the septum from below. That is called as transcervical hysteroscopic septal resection. Whereas Strassman's metroplasty, no, don't do a mistake here. Strassman's metroplasty is done for bicornuate and didelphys. Bicornuate and didelphys. Whereas for septate uterus, we do transcervical hysteroscopic septal resection. Septate uterus, it is transcervical hysteroscopic septal resection. Whereas for bicornuate and didelphys, it is Strassman's metroplasty. Am I clear with this point? Luteal phase is best diagnosed by serum progesterone levels, endometrial biopsy, basal body temperature, ultrasonography. To be frank, all these can diagnose the luteal phase. But luteal phase will be best diagnosed by endometrial biopsy. On endometrial biopsy, if you have secretory endometrium, then it is luteal phase. Then it is luteal phase. Okay? Right. So natural family planning method with least failure method. So all billing method is cervical mucus method, symptothermal method we have. Symptothermal is basal body temperature method plus cervical mucus method. So natural family planning method with least failure rate is symptothermal method, guys. Symptothermal method has least failure rate. As such, in contraception, the least failure rate for the contraception is due to mainly due to implant. Which implant? That is Norplant. Implanon has least failure rate. Implanon has least failure rate and it is 0.05 per 100 woman years. Implanon has least failure rate and it is 0.05 per 100 woman years. Okay. Absence of sperms in the semen is called aspermia. Sorry. Azoospermia. Absence of semen is called as aspermia. So I am just telling you in random some of your PYQs I am discussing, guys. But in particular, if you want any topic to be discussed, you can let me know. I will discuss for that. Okay. As of now, before exam, you just have to be cool and chilling and, take a proper, most important is sleep at appropriate time so that you can get up early, reach your examination hall at least 1.5 hours prior, and don't be those students who are just sitting with the books till the last minute and suddenly then till last minute you're revising something and then suddenly going. Don't do that. So already in what I have done is I have already discussed the management of labor, all the different stages of labor and all. So those were important. Yes, that's we have discussed, right? Increased FSH levels in azoospermic male indicates. Always remember, whenever the FSH and LH are more, it's a failure. Gonadotrophin, if the gonads failure. So it is testicular atrophy. Gonads failure, testicular atrophy. Right? Next, one more point I want to tell you. Cervical cancer is something very important. Cervical cancer mein cervical vaccination, cancer vaccination, that is Gardasil or Gardasil 9. This is mainly prepared from L1 capsid protein, guys. L1 capsid protein. Cervical vaccination is mainly from the L1 capsid protein. The management of cervical cancer, stage 1A1 to 2A1. You can do surgical management except 1B3. Except 1B3. ठीक है. Next. तो 1B3, 2A2 to 4B, we do concurrent chemoradiotherapy. We give chemotherapy with cisplatin, followed by we do radiotherapy. We give chemotherapy with cisplatin, followed by we do radiotherapy. So 1B3 to 2A2 to 4B, we do concurrent chemoradiotherapy. That is, we give chemotherapy with cisplatin, followed by we do radiotherapy. Okay. Next is, what is the surgical management we do? For 1B1, 1B2 and 2A1. B looks like 3, no? So we do type 3 hysterectomy. Plus pelvic lymphadenectomy. Gardasil can be given from 9 to 45 years. Gardasil can be given from 9 to 45 years. Okay. So 1B1, 1B2 and 2A1 you can do type 3 hysterectomy plus pelvic lymphadenectomy. So 1A1, 1A2 you will do type 2 hysterectomy plus pelvic lymphadenectomy. You don't remove ovaries. Clear, guys? This is cervical cancer management. I'll just recap cancer managements. So please listen again. 1A1 to 2A1 except 1B3 it is surgical management. 1B3, 2A2 to 4B concurrent chemoradiotherapy, that first cisplatin then radiotherapy. Okay? 1A1, 1A2 type 2 hysterectomy plus pelvic lymphadenectomy. B looks like 3, so 1B1, 1B2, 2A1 we do type 3 hysterectomy plus pelvic lymphadenectomy. Okay? Next is ovarian cancer management. Ovarian cancer में if you have epithelial ovarian cancers 1A, 1B and borderline, you will do only cytoreductive or debulking. Cytoreductive or debulking. सब कुछ निकालोगे but no post op chemo. ठीक है? But from 1C to 4B we'll do cytoreductive or debulking, followed by we'll give 4 to 6 cycles of cisplatin or carboplatin, cisplatin or carboplatin plus paclitaxel, plus paclitaxel. Okay. Next, management of germ cell or sex cord stromal. Germ cell or sex cord stromal. So germ cell or sex cord stromal mein what we do is we do staging laparotomy. We do staging laparotomy. Followed by we do, usually most of the time it is one side. So unilateral salpingo-oophorectomy. Followed by we'll give 4 to 6 cycles of BEP chemotherapy. So BEP chemotherapy is bleomycin, etoposide and cisplatin. Bleomycin, etoposide and cisplatin. Yes, so at least these two cancers management should be known to you. So I have just told you about those cancers management. Okay? So those are some of the important points which are useful for you. And yes, agar if you see any adnexal mass or ovarian mass, guys, in reproductive age group, and the size of the mass is less than 5 centimeters, just wait and watch. If it is between 5 to 7 centimeters, if it is simple, wait and watch. If it is complex, you have to go for surgery. If it is more than 7 centimeters, directly you have to go for surgery. This is for reproductive age group. Okay? Next, if you have premenopausal or postmenopausal women. So premenopausal women or postmenopausal women, I am more worried about this age group. I am more worried about them going into, cancers. So I'll first do CA125. CA125 is less than 35 international units per liter, and if the size is less than 7 centimeters, wait and watch. If it is more than 7 centimeters, surgery. And if it is more than 35 international units per liter, irrespective of the size, we'll go for surgery. Right? So those were the some last minute golden points which I could give for you before the exam. All the best, guys. All my prayers are with you. Just rock it. Be positive. That's the most important. Do some meditation. Just concentrate on your breath so that you're calm and composed. Your target is 200. Anything which you don't know, leave it for your 100 marks, which okay. So pakka you'll all get 200. Do well, guys. Do well. All the best. All the best. Thank you so much. If you have any doubts, you can ask me. You have any doubts, you can ask me. Right. So thank you so much for bearing me and as well as the small disturbance which you had in the starting of the session. Thank you so much.
Hi guys. Hi. Welcome. Good evening. Good evening, Heisenberg. Hi. Um, so you guys had a break, a small break. Okay, so we are going to have a pretty long session over here. I hope you guys have joined up. And yep, tomorrow you have an exam. So let me just quickly tell you what we are going to cover over here. So what I decided was I decided to take a bit kind of a longer session. And in this, what I'm trying to do is I'm trying to take the important topics which I particularly feel. Obviously, it is impossible to cover the entire general surgery over here, but I'm trying to cover the important topics from general surgery. Then we'll be talking about the important topics from GIT, hepatobiliary system, and finally the urology. So these are the four sections which we will be covering in this, and in the general surgery obviously the trauma is a part of that. Okay, so without wasting any further time, let us start and let us understand this. Okay, so the first thing, yeah, let's start with the topics of general surgery, and I want you to be a bit active, I will try my level best that your attention is kind of maintained over here, and I'll try my level best that this particular session adds decent value to you, and hopefully few of the questions show up in tomorrow's exam or in your life whenever you basically give any exam from this particular session. So yeah, let's start. So the first thing is, what is the intervention which is being showed in this particular image? Can anybody answer in the chat box? Okay, so I won't wait for your responses. You can keep on giving the responses so that that will help you be active and interactive and all those particular stuff. But because of the want of time, I will just quickly, I'll be a bit fast in this particular session, but at the same time, I will be explaining you things. Okay, so what you're basically seeing in this particular image is fasciotomy. Okay, so what is this? This is fasciotomy. Okay, now what do you understand by fasciotomy? I hope you are able to appreciate that this white colored stuff, that is what is a fascia, and we have cut that particular fascia. Now, why was there a need to do that? So what is an indication of doing in fasciotomy? It is a compartment syndrome. So yeah, all those particular knowledge is absolutely okay, but let's say if at all you are going to give an exam tomorrow, what might show up in your exam? So you might have a clinical based scenario where there will be a patient who suffered from, let's say, a crash injury, where the patient had a crash injury. So let's say there was a road traffic accident, the patient had a crash injury, the bike basically went over the leg or something like that. So what that basically creates, it basically creates the trauma to the muscle, and slowly and gradually the muscle kind of swells up. But the muscle is basically trapped inside the fascia, right? So there's a muscular fascia which is surrounding the muscle. So what happens is that the muscle doesn't get enough space to kind of expand, and over a period of time, the pressure inside that compartment basically increases, which leads to all this particular problem. Now, what happens when the pressure increases? The microcirculation is something which is getting affected. So it is just like your life, right? I mean, the common man, that is basically affected the first. So in similar manner in the legs, the microcirculation, because the muscle component of those particular vessels is very minimal. So what happens when the pressure increases? The larger vessels are able to kind of continue to give the blood, but the smaller vessels, they get compressed. And that is why what we say is the microvasculature is basically affected. So this is the first MCQ which they ask you. They ask you that, what, the dorsalis pedis will be palpable, but what is going to happen? The small vessels which are supplying the muscles, they are basically getting compressed. And this is very, very important MCQ which they ask you. What is the first sign of that? So in the clinical scenario, they might give you that, there is a pain or the pain on dorsiflexion of the toe. Usually that is what they basically give you. Okay, so there is a pain on the dorsiflexion of the toe. This basically tells you that, the microvasculature has caused ischemia of the calf muscles. Okay, so this is a hint which they are basically trying to give you over there. Or they might directly ask you, what is the first sign of crush injury? Okay, so compartment syndrome in the crush injury, it is pain on the dorsiflexion of that particular toe. Okay, but as you can appreciate over here, the peripheral pulsations will be palpable till the late. So in other words, the dorsalis pedis, like you will be able to palpate the dorsalis pedis till a long period of time. Okay, so that is what you need to understand over here. Now, coming to the treatment of it. Okay, so how do you basically treat it? The treatment is with the help of a fasciotomy. Okay, so what is this particular fasciotomy? You basically cut the fascia which is surrounding that particular muscle. So once the fascia is cut, what happens? The muscles get space, and the muscle expands, and if at all the muscle expands, the pressure is basically reduced and the microvasculature can be established even further. Now what you need to understand over here is that sometimes they can trick you. They may say that, the crush injury happened 24 hours back, and because there was no good surgeon who to do a fasciotomy in the periphery, now the patient has come to you in the trauma at this point of time. 36 hours has already passed. It is a direct line from 11 Billy. A question can be framed on that. So if at all, will you do a fasciotomy at this point of time? No. That is going to be detrimental, because now there is no way you are able to salvage that particular muscle. But if you end up doing a fasciotomy, the toxins and everything will be released into the blood, and it will make the patients deteriorate further. So myoglobinuria and all those particular stuff is going to happen. Understood? Important topic, guys. Compartment syndrome, couple of things. Clinical scenario, definitely I hope you have understood. Microvasculature is affected, the peripheral pulses are kind of palpable, and the first sign is pain on the dorsiflexion. When do you do a fasciotomy? When the pressure increases about 30 millimeters of mercury. Okay, so this is again a numerical based question which they can ask. You do a fasciotomy once 30 millimeters of mercury is kind of reached. Okay, now what is this particular image? What are you seeing on this particular image? So this is the bed sore, that's fine. What is the grade of this particular bed sore? Now the grading of the bed sore is very, very important for your exam. So I hope you will remember that. Okay, now what is a bed sore? Bed sore is basically that the continuity of the skin is basically lost. Why it is getting lost? Okay, so what, like I am sitting over here, obviously whatever the session I'm going to take, 3, 4, 4 hours, whatever, I will be moving a bit like that. Okay, but let's say if at all the patient is paralyzed and the patient is completely dependent on the nurses or the relatives to help them mobilize. Many times they are just kind of lying in the same position for hours together, and because of that, what happens? Over a period of time, the pressure is created, and the capillary pressure basically increase, like if at all the pressure in that particular soft tissue is increasing more than 30 millimeters of mercury, the capillary pressure is kind of crossed, and again the blood supply to the skin and the epidermis is basically lost, which ends up basically causing the breach in that particular continuities. Okay, so capillary closing pressure, if at all the pressure in the subcutaneous tissue rises above that, then the bed sore basically happens. Now for you, this particular classification is absolutely important. What is the grading of the bed sore? Now where they will kind of confuse you a bit, so non-blanching, so that is something which you need to understand, and of the non-blanching erythema. Okay, so erythema is going to be there, but it's going to be non-blanching. Where do you see a blanching erythema? I hope you're answering that you see that in the grade 1 burns. Okay, so in the grade 1 burns, again, there is no blister, nothing. It is just a blanching erythema. Here, you have a non-blanching erythema. That's fine. And there is no breach in the epidermis. Okay, so many of you might have answered this as 1. It's not. It is 2. It is a grade 2 because there is a breach in the epidermis. Okay, so grade 1 is non-blanching erythema with no breach in the epidermis. In the grade 2, what is there? There is a partial thickness kind of loss of that particular skin. Then in the grade 3, there is a full thickness skin loss, and the grade 4, it basically exposes till the muscles and the bones and all those particular stuff. So 2, 3 and 4 are still acceptable, but you have to understand in the grade 1, first it is a non-blanching erythema. Second of all, there is no break in the epidermis. Okay, everybody is with me over here? Okay, understood? So this is very, very important. This particular classification is very, very important for you. Now coming to the site, what is the most common site of your bed sore? Okay, so the most common site of your bed sore is ischium, and it is a MCQ which you have to kind of remember, no doubt about it. So this is an ischium. Don't mark it as sacrum. That is not the correct answer. This is the most commonly marked wrong answer. So the most common site is ischium, then followed by the greater trochanter, sacrum, heel, lateral malleolus, and medial malleolus. But just remember ischium. That is the most common site. Understood? Now, right. Now, what you need to understand over here, what is this, guys? What is this? So this is basically a vacuum dressing. So how do you kind of manage a bed sore? So if at all, let's say there is a grade 3 or the grade 4 bed sore, obviously it is infected and all those particular stuff, so you have to debride it completely. And in order to increase the granulation, you basically go ahead with this vacuum dressing. So this is something which you need to understand. Image is important. What is this? This is vacuum assisted closure or the vacuum dressing, which basically helps you increasing the granulation of that particular tissue. Okay. Now, what is this, guys? Now again, a very, very high yield topic for you. Very simple, but very high yield. What is this? This is a keloid. What is this? This is a hypertrophic scar. Hypertrophic scar. Now, what is the basic difference between the keloid and the hypertrophic scar? So both are basically the abnormalities of the scar maturation. Okay, but in the keloid, it basically grows beyond the boundary of that particular scar. In the hypertrophic scar, it is basically within the boundary of that particular scar. So that is a basic difference, a very, very simple MCQ. But yes, you have to kind of remember this. This is a keloid, this is a hypertrophic scar. So this is a table telling you the differences between them. Now, okay, so let's kind of go through it. But the important one is that it extends beyond the boundary. The answer is no, hypertrophic scar doesn't extend. And the keloid, yes, it does extend. Others are, it's okay, we can go through it. Time is, let's say, within 4 weeks. 3 months to a year, not that relevant, at least for tomorrow's exam or something. Familial association, well, yes, you can say that keloid has some amount of familial association. It gets better with time. Yes, hypertrophic scar does get better with time. And the collagen, it is a type 3 and which is kind of well organized. And in the keloid, what we have is a type 1 and the type 3, but it is a disorganized. So with normal skin, we have both, right? We have type 1 and type 3 collagen. So in the keloid, we have both the collagens, but it is in a disorganized manner. In our normal skin, we have it in the organized manner. Okay, so these are all in-depth kind of things. Just to brush it up, what you need to understand is the image is very, very important, and they might give you which of the following is true about keloid or hypertrophic scar, except. So this is what they might give you. Okay, now again, a very, 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 very high yield topic for you. That is what is a classification of hemorrhagic shock. Okay, now usually they don't go into a lot of it. Okay, so 2 types of questions can be asked over here. Okay, so what are the 2 types of questions which can be asked over here? So first is they will directly ask you, how would you classify the hemorrhagic shock? So that is based on the blood loss. If at all the blood loss is less than 750 ml, it is kind of class 1. 750 ml to 1.5 liters, it is basically class 2. 1.5 to 2 liters is class 3, and more than 2 liters is class 4. Okay, so that is one simple straightforward question which they might ask you. Another question which they might ask you, they might give you a clinical scenario that the patient suffered from a road traffic accident and blah 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 happened. When the patient came, the vitals were, let's say, they will give you the heart rate is, let's say, 130, or they will give you that the systolic blood pressure is kind of normal, but the diastolic blood pressure is kind of raised. So something like that. Okay, so they will give you the clinical scenario. Okay, now let's kind of go through it. In the class 1 hemorrhagic shock, now let's say if at all I suffer from some injury, let's say 50, 100 ml of my blood is kind of lost. Is my physiology going to change? Absolutely no. So broadly what you need to understand, in the class 1 hemorrhagic shock, the blood loss is 750 ml, less than 750 ml, which you, if you want to extrapolate in the form of a percentage, because sometimes percentage is asked, so that is less than 15% of our entire kind of blood volume. So that is something which is there, but the physiology is absolutely normal, like normal individuals. Okay, so physiology is absolutely normal. There is no change in the physiology. In the grade 2, class 2, the blood loss is between 750 ml to 1.5 liters, which basically comes down to 15 to 30%. But here, as you can see, the systolic blood pressure, there is no change at all. So yes, the heart rate is slightly increased, the respiratory rate is slightly increased, urine output is slightly decreased. All those things are going to happen, but the systolic blood pressure is absolutely normal. So this they might give you. This is usually they ask you, if at all they ask you a clinical based scenario, they will usually give you the class 2 hemorrhagic shock. They will say that the heart rate is 110, they will say that the respiratory rate is 24, and let's say the urine output of last year was 25 ml, and they will say that the systolic blood pressure is absolutely normal. You might feel that, you know what, everything is normal, this is a class 1 hemorrhagic shock, but no, the vitals are slightly denatured, systolic blood pressure is normal, the patient is having class 2 hemorrhagic shock. And class 3, class 4 are self-explanatory. As we go towards class 4, obviously the blood loss is more, and over a period of time, the physiological changes are also going to be very, very high. In the class 4, ultimately there is going to be, let's say, the organ failures are going to kind of start, and the neurologically the patient is going to be confused and unconscious and all those particular stuff. Did you understand it, guys? I hope you have understood, right? Now, coming to the next topic. Okay, so what is this? Very simple. This is what is a nasogastric tube. But yeah, that is, I don't think so. They'll ask you this. What is this? Okay, so this is what is a nasogastric tube. Okay, so there are various uses of this. One is basically to decompress the stomach when, let's say, if at all the patient is having intestinal obstruction, you basically decompress the stomach by putting this nasogastric tube. Or let's say if at all the patient is having paralytic ileus, then you put this nasogastric tube. That's all fine. But other things they have asked. So this was the question which was asked a couple of years back. What is the best position in which you put the nasogastric tube? Anybody, guys? Can you put it in the comment box? The answer is sitting position. Okay, so you basically put this nasogastric tube in the sitting position. That is the best position to put that. Okay, yeah, that's fine. With the neck kind of flex, that's fine. Now, what about this? How do you check this particular position? Because when you're putting this nasogastric tube, you want that this end should have reached to the stomach. Now, how do you kind of check that? A couple of ways to kind of check it. The most crude method is you basically push an air and then you put a stethoscope in the epigastric region and then you can hear a gurgling sound. Is it a very reliable method? The answer is absolutely no. It is not a very reliable method. Another method is, okay, you can get an X-ray done. Why? Because over here you have a marking which is radio opaque. So there is kind of a green colored line which is radio opaque. Well, yes, you can do that. That's fine. But another method is you aspirate some amount of it. Okay. What is the pH of the stomach? The pH of the stomach is acidic, right? So whatever the aspirate you're kind of taking out of this particular tube, and you basically do the litmus test, if at all it turns out to be kind of acidic, 3-4 pH or something, that basically indicates that, you know what, you have placed successfully the tip of this particular kind of tube into the stomach. Okay, so if at all somebody asks you, best method is aspiration along with the litmus test. Okay, so yeah, chest X-ray can also be there, but usually they do not kind of put that in a kind of a question in the options. Okay, understood, guys? Right. Now coming to the length. Okay, so how do you calculate the length? Because nasogastric tube, the indication can be in the small child or in an adult. So how do you kind of calculate the length? So this is basically from the tip of the nose to the ears to the xiphisternum. So this is usually the kind of a length which we kind of use, because this will give you a rough idea, because then you will understand that how much you have to kind of push the tube, because if you push a bit more, the tube will land up into duodenum. That is not what you intend to do. Or if you push a bit less, it will stay inside the esophagus. Understood, guys? I hope you have understood. Okay, now coming to this, what is this, guys? What is this? So this is obviously very simple. This is a Foley's catheter, but they are in different colors. So one is basically transparent, one is basically yellow. So what is the basic difference between them? So the basic difference between them is this is what is a latex. Okay, so this is made of a material which is called as a latex. This is basically made of a material which is called as a silicone. Now you will ask me which one is kind of better. So silicone wala is a bit better. Why? Because you can keep it a bit longer. So it can be kept for around 3 to 4 weeks. Latex is ideally to be changed within 2 weeks. Okay, so that is the first difference which you're basically seeing on your images. What is another difference? I hope you're able to appreciate. Another difference is that over here there is only 2 channels. Okay, what is this? There are 2 channels. Over here there are 3 channels. Okay, so what you need to understand over here, guys, that the latex one, which is on your screen, is a 2-way Foley's catheter, and the silicone one is a 3-way Foley's catheter. Understood? Now, why 3-way Foley's catheter? So 3-way Foley's catheter is basically used for irrigation. Okay, so what is the use of this? This is a irrigation. They might ask you the name of that. They might not ask you the actual indication. So when will you need an irrigation? We are going in a bit detail. Okay, let's kind of stick to the basics, but I'll just tell you. So irrigation, let's say if at all there is a hematuria in the bladder. So whenever the patient has hematuria, we basically put a 3-way Foley's catheter. We start the irrigation from one channel and the outflow. So yeah, over here, what we attach is a Eurobag. Over here, what you have is what you call as, over here you attach a Eurobag. Over here what you have is basically a irrigation channel which basically goes in. Understood, guys? Yeah, I hope you have understood. Now coming to the blood transfusion. Okay, now quickly I'll kind of cover this. So this will summarize the important points about blood transfusion for you. Okay, so what do you understand by the blood? Okay, so what happens? Let's say if at all I wish to donate the blood, I might go to the blood bank, or there can be some blood kind of camp in the periphery. Let's say if at all there is some NGO has organized some blood camp at some place or something like that. Okay, in that particular scenario, what happens? We have to shift whatever the blood has been collected, 15, 30, 40 units, whatever has been collected, that has to be transferred to the blood bank. How do you transfer that? That is basically done like we have the ice chamber or something like that, but here the temperature is usually 20 to 24 degrees Celsius. Okay, and you have to transfer that to the blood bank within 6 hours. So that is something which you need to understand. So this is transport time, but most of the times you directly go to the blood bank and you donate. So you have a whole blood. What we have in our body is a whole blood. Now we do understand that what we have the components of the blood. Now what are the components of the blood? So we have red cell concentrate, then we have the platelets, and then we have a fresh frozen plasma. So these are the different components of the blood. Now we as a physicians, doctors, whatever, we have an option. We can use directly the whole blood, or we can use the components of the blood. Okay, so what will you prefer to use? So it's basically one hour lecture, but I'll just try to summarize all these particular stuff. So we usually do not, at this point of time, we do not prefer to use whole blood. Why? Because we do understand that the lifespan of the RBCs is a bit more, and we can store this whole blood for around, let's say, 28 to 35 days, depending on what anticoagulant we are using. But the lifespan of the platelets is very less. 4-5 days. The lifespan of the clotting factors is pretty less. So let's say if at all we use this particular blood after 7 days, 10 days or something like that, it is not going to fulfill our purpose, and it is just going to cause the volume overload to the patient. Okay, so because this particular bag is around 450 ml and the red cell concentrate, this is around 320 ml. Okay, so obviously if at all you want to transfuse 3 packs of blood, then obviously the volume overload will be higher if you transfusing the whole blood. Okay, that's fine. So this is all conceptual, that's fine, might not come in your MCQ. What might come in your MCQ? How do you store these particular stuff? Okay, so this whole blood and the red cell concentrate, they are basically stored at 2 to 6 degrees Celsius, and they can be stored for around 28 days to 35 days. I will talk to you about the days of it, but yeah, please understand whole blood or the packed, we call it as a packed cell volume, PCV, that can be stored for around 28 to 35 days, and that has to be stored at 2 to 6 degrees. Why not 0 degrees? Very, very important. You should not allow the blood to freeze. because if it freezes and if you transfuse it to the patient, that is going to be very, very detrimental for the patient. Okay, so never ever like you have to maintain that this doesn't reach 0 degrees Celsius. If it reaches 0 degrees Celsius, you'll have to discard that particular blood. That is not usable at this point of time. Okay, then we talk about the plasma component. Now, how do we get these particular components? Whatever the whole blood is there, we centrifuge it, and after centrifuging, we get different kind of components out of it. Nobody's going to ask you in the MCQ, but this is how you kind of get it. So we have plasma component and we have a platelet component. So plasma is basically fresh frozen plasma, and cryoprecipitate. These are the two things which you kind of get out of it. This is stored at minus 30 degrees Celsius, and this can be stored for around 2 years. So this can be stored at minus 30 degrees Celsius for around 2 years. Understood? Now, coming to the platelets. So platelets are stored at room temperature. Okay, so they are basically stored at room temperature and they can be stored for around 5 days. These are the direct MCQs which they might ask you. Now, what we have, now this is important, you have to understand the full forms of this. So we have CPDA and then we have a SAG-M. So these are the anticoagulants which we use in order to preserve the blood or the packed cell volume. So CPDA basically stands for citrate, phosphate, dextrose and adenine. Okay, CPDA. Over here, we have to like the lifespan basically becomes around 28 days, 4 weeks. What about the SAG-M? So we have saline, adenine, glucose and mannitol. Understood? So please, the biggest mistake which the students do is this. It is not sucrose, it is saline. Okay? So saline, adenine, glucose and mannitol, it is around 5 weeks. That's what they say, but it's around 28 to 35 days. That's fine. Understood? Okay. Earlier we had CPD. A was not there. A was introduced later. So CPD ka it is around 21 days. Forget about it. CPD 21 days. CPDA, that is something which is commonly used, 28 days. SAG-M, if they have the option of 35 days, mark it. Otherwise 28 days. Understood? Now, coming to this, I will not go through these particular aspects because that's fine. That's more of a theory and would have been covered in your medicine. SIRS is a very, very pet question. They might ask you which of the following is not a component of SIRS. So what you need to understand, SIRS is systemic inflammatory response syndrome. It is not always related to the infection. It can happen after trauma, it can happen after surgery, XYZ reasons, that's fine. So in order to call that the patient is in the systemic inflammatory response syndrome, we should have at least 2 out of these 4 features which we are going to discuss, and these 4 features are important for you for tomorrow's exam. So what are these 4 features? The temperature, if at all it is less than, if at all it is more than 38 degrees or it is less than 35 degrees Celsius. Then heart rate, if at all it is more than 90 beats per minute, and respiratory rate, if at all it is more than 20, and the PCO2 is less than 32. But RR is important, respiratory rate is important if at all it is more than 20. Then WBC count, if at all it is more than 12,000 or less than 4,000. Okay, understood this guys? So this is WBC count, respiratory rate, heart rate and the temperature. These are the 4 components of systemic inflammatory response syndrome, SIRS. At least 2 out of these 4 has to be present in order to call that. Understood? Okay. Now coming to this. Okay. So let's talk about the sutures. Okay, so let's talk about the sutures. Now, what do we have in the sutures? In the sutures, we have either an absorbable or a non-absorbable sutures. Now, what are the absorbable sutures? Absorbable sutures can be the natural sutures or they can be synthetic sutures. Okay, so what about the natural sutures? In the natural, we have catgut and we have a chromic catgut. In the systemic, we have monocryl, vicryl and PDS. Okay, so this is the classification, the basic classification. Absorbable, it is either synthetic or natural, and non-absorbable, that is again either natural or synthetic. In the non-absorbable, what we have is silk, and then we have a proline and nylon. Now, how questions can be asked from over here? Okay, so first of all, they might ask you whether this is a monofilament suture or a multifilament suture. So monocryl, this is a monofilament. What about the vicryl? Vicryl is a multifilament suture. Okay, it is a multifilament suture. Now, let us first talk about what is the difference between the monofilament and the multifilament suture, guys. Okay, so if I ask you, out of these two, in which of these particular sutures the infection chance is a bit more? Okay, so out of the monofilament and multifilament, out of these, in which of these the chance of infection is a bit more? So it is in multifilament. Okay, there's a higher risk of infection over here because of the high capillary action. More infection. What about the tissue injury? Sorry. So we have the tissue injury. The chances of the tissue injury is more with the multi-filament suture, because here there are multiple filaments. When you basically pass it through the tissue, it is going to cause a friction and it is going to cause the injury to the surrounding tissue. Okay, now if we talk about handling, okay, so what about the security of the knot? So the security of the knot is better with the multi-filament suture, because in the monofilament suture, what happens? The knot basically tries to untie itself. So these are the basic differences. You can go through it. They might give you that which of these is not a feature of a monofilament or a multifilament suture. Okay, now coming to the absorption time and the tensile strength. So what happens is that if you have tied a suture, after one point of time, that suture is going to become ineffective. So let's say if at all there is an absorbable suture. In the absorbable suture, it is not like within a fraction of a second the suture is going to disappear. It is going to be a gradual process. So what happens is that after the 50% of the strength of that particular suture is lost, it is no more able to approximate the tissue together. So that is a basic difference between absorption time and the tensile strength. Now what you need to understand over here is that, okay, now one direct MCQ which I will just give you, in the natural sutures and the synthetic suture, absorbable. If I ask you, what is the method by which the absorption takes place in the natural sutures? Anybody, can you put it in the comment box, guys? Okay, so this basically happens by the process of an enzymatic degeneration. Okay, enzymatic. Okay, by the enzymatic action, this particular natural absorption basically takes place. The synthetic sutures, they are basically absorbed by the process of hydrolysis. Okay, so because it is basically dissolved by the hydrolysis, the tissue reaction is very less with the synthetic sutures, but the tissue reaction is pretty high with the naturally occurring absorbable sutures. Okay, and that is important, because let's say if at all you're suturing the bowel and if at all the tissue reaction is more, the chances of stricture is going to be more with the naturally. So you would have noticed that the use of catgut has reduced very, very drastically. So if I ask you, what are the sutures which you basically use for different kind of purposes? Okay, so the proline, where do you use proline? It is used for, okay, so vascular surgery. If at all you want to do a vascular anastomosis, yes, proline is the suture which you use. For hernia surgeries, that's fine. For the sheath closure, please remember, vascular surgery, sheath closure, what we use is proline. What about the vicryl? So vicryl is basically called as a workhorse suture. It means that it is used very, very commonly. So bowel anastomosis and various other purposes, wherever you want to kind of use, let's say subcutaneous suturing, any kind of suturing, vicryl is very, very commonly used suture. Then what about the nylon? Nylon is used for the skin suturing. Okay, for the skin suturing. Then we have PDS, which is used for pancreatico-biliary anastomosis. Okay, so so PDS is also called as a delayed absorbable suture. Okay, so PDS, it is an absorbable suture, but it is a delayed absorbable suture. Can anybody tell me what is the absorption time for the PDS? How many days it takes for the PDS to kind of get absorbed? It is around 180 days, guys. Okay, it is around 180 days. 180 days is the time for the PDS to get absorbed. That is why it is called as a delayed absorbable suture. Understood? Right. Okay, so monocryl is basically used for the subcuticular suturing. So this is the uses of the different sutures which we have. Now coming to what is the ideal time of removal. So one thing which you need to remember over here is phase. Okay, so after, let's say, the cleft lip surgery, what is the time after that you basically do the suture removal? It is around 3 to 5 days. Okay, so any kind of surgeries of the face, cleft lip surgery is something which you would have kind of noticed in your wards. So this is, the suture is removed after 3 to 5 days. Then we have a scalp, that is around 6 to 8 days, abdomen is 8 to 10 days, earlobes is 10 to 14 days, back extremities 12 to 14 days, foot and sole is again 12 to 14 days. Okay, so this is the time of removal of the sutures in different kind of places. Okay, now let's talk about these things. Very, very important. What is an ear of a suture? Okay, so let's say if at all I have, this is a direct line from your love and belly, guys. So it can be asked to you. Maybe it has been asked a couple of times. So let's say if at all I have tied a knot over here. I have to cut the end of the suture, right? So what is the length of this particular thing which I am going to leave? So if you leave a bit more, that is going to irritate the kind of patient. If you kind of cut very, very close to the knot might untie. So this is what is called as an ear of a suture, and what they basically say is that at least 2 millimeters has to be kind of left in order to secure that particular knot. That is something which is important. Jenkins rule, extremely important. What is this Jenkins rule? So what this basically says that if at all, let's say this is the wound and this is the suture. Okay, so we have the wound and we have the suture. What is the length of the suture which is needed in order to close this particular wound. So what you need to understand, the ratio of the suture is going to be 4:1. Okay, so if at all, let's say the length of the wound is X, we need 4x the suture in order to close that particular wound in a proper manner. That is what is the Jenkins rule. Then we have an Aberdeen's knot. What is an Aberdeen's knot? Have you ever heard of this? So which is the suturing technique where the Aberdeen's knot is kind of used? Anybody guys? Guys, please. See guys, I'm not waiting for your responses in the chat box because I want to cover the maximum content which I can. But at the same time, I would encourage you to kind of put the answers in the chat box because that will help me understand that, you are there and you are basically following what I'm trying to tell you. Okay, so I'm not trying to put up an MCQ and trying to discuss that particular MCQ because in that way I will be able to cover very, very less stuff. So I'm just trying to revise the maximum topics which I can. So I'm pretty sure that if you have ever read these particular topics, it will help you getting revised. Okay, so yeah, can you please tell me guys what is the suturing technique where the Aberdeen's knot is used? So yes, continuous suturing. Okay, so if at all you basically do a continuous suturing, okay, what happens is that if you take a continuous suturing, if at all the end knot basically breaks, the entire suture line is going to open up. So Aberdeen's knot is basically used in order to give a support to the continuous suture. It is basically a knot which you basically tie in middle of that particular continuous suture so that that particular knot is basically stabilized. Okay, so Aberdeen's knot, just understand, it is basically used for the continuous suturing techniques. Okay, it is used in the continuous suturing technique. Now what is this? This is what is your monopolar cautery. Okay, what is this? This is a monopolar cautery. Okay, so what you need to understand over here, that they will ask you this particular image and they will ask you which button is used for what. So this yellow button is used for cutting current or a coagulation current. Okay, so yellow is basically used for the cutting and this blue is basically used for coagulation. Okay, right. What is this? This is what is your patient plate. Patient plate. Do you need this particular kind of patient plate in the bipolar cautery? The answer is no. In the bipolar, this is a bipolar. This is a bipolar cautery, and over here you do not need a patient plate. Okay, here you do not need a patient plate. Okay, now coming to this. This is important. What is this? This is a BP handle. What does this BP handle stands for? BP handles basically stands for barred Parker handle. Okay, BP handle is the barred Parker handle, and over here what you have is these are the different types of knives. So okay, so we have the different numberings of the knives. At least what you should remember is the knife number 11. Okay, so what you should remember is the knife number 11, knife number 15, and then there is, let's say, this whole range from 20 to 23. So okay, so 11 number knife, this looks like this. Okay, so this is a stab knife. What is 11 number knife? 11 number knife is a stab knife. Where do you use it? A couple of kind of indications for that. If you're doing a tracheostomy, you want to directly enter into the trachea in one go, or let's say you're performing an incision and drainage, or let's say you have to perform an arteriotomy. So these are the places where you use this stab knife. Okay, what about the 15 number knife? This is what is called as a D knife. Okay, this is what is called as a D knife. This D knife is basically used in order to what is called as the give a precise incision. Okay, so this D knife is basically used in order to give a precise incision. Let's say you want to remove some mole of the face or something, you want to be very, very precise in giving the incisions, there you use that. Do not forget the indications of the stab knife, very, very important. And then if you want to do a debridement, in that particular scenario what we basically end up using is this what you call as a blade from 22, 23 or something like that. Okay, understood? These are the three things. Now how do you mount these particular stuff? Okay, so this knives, they are mounted on this BP handle. These are the barred Parker handles. So this whatever, let's say 11. Okay, so what we need to understand, the 11 and 15 kind of number knife, they are basically mounted on the barred Parker handle 3, and this 20 to 23, this is mounted on the barred Parker handle 4. Okay, have you understood this particular point? These are important. Which is the handle which is used for mounting these particular stuff. Okay, so now let's move on to the trauma. We will start with the head injury, guys. Okay, so base of the skull injury is absolutely important. Can anybody tell me what is this particular figure and what is this particular figure? Okay, so in the first figure, what you're basically seeing is a raccoon eyes. Raccoon eyes. And over here, what you're basically seeing is a mastoid sign. What is this? This is what is a mastoid sign. Okay, so we have a raccoon eyes and we have a mastoid sign over here. So what these particular things indicate? So what we have in the base of the skull, we have an anterior cranial fossa, we have a middle cranial fossa, and we have a posterior cranial fossa. So what are the things which tell that the patient might be having a anterior cranial fossa injury? If at all the patient has CSF rhinorrhea. So in this, the clinical scenario which they will give you is that the patient has suffered from an injury and there is a continuous drooling of fluid from the nose of that particular patient. And when the patient basically lies down and patient gets up, the kind of fluid basically keeps on draining. So this is what is a reservoir sign, and CSF rhinorrhea, the clinical scenario is kind of important. Or they might give you this particular image, raccoon eyes, and they might ask you that, where is the injury in these particular patients? So answer is, it is in the anterior cranial fossa. What about the middle cranial fossa? So over here we have a CSF coming out of ears, that is CSF otorrhea. Then we have hemotympanum. If you basically do a kind of otoscopy, you are going to see that the tympanic membrane is basically bulging out and there is a blood collected behind that particular tympanic membrane, that is a hemotympanum. And there is a battle sign where there is a ecchymosis at the mastoid process. Okay, so this is what they might kind of give you. They might give you a clinical scenario. Along with that, they might give you an image and they might ask you, where is this particular injury? I hope you're able to appreciate over here. This is what is a what you call as the ecchymosis at the mastoid process. So this is what is called as a battle sign. Okay, right. Okay, now this is the indication of performing a CT scan. So if at all the GCS is less than 15 at 2 hours, you basically end up performing a CT scan. So these are the indications of performing a CT scan. So if at all there is any episode of seizure, or if at all there is, let's say, more than one episode of vomiting, or let's say you suspect that there is any sign of this particular uh, like base of the skull fracture, then yes, you have to perform a CT scan of this particular patient. Now, if at all you perform a CT scan and you get an image like this, a very, very important image for you guys, okay? So what is the diagnosis of this particular patient? Okay, it's a very simple question, but yeah, what is the diagnosis? This is a extradural hemorrhage. Okay, what is this? This is a extradural hemorrhage. Why this is an extradural hemorrhage? Because I hope you're able to appreciate this is a biconvex shaped opacity which you're basically seeing. So this is what is an extradural hemorrhage. Okay, now what you need to understand over here is, okay, now if at all, let's say there is a patient with a head injury. First of all, if at all there is a patient with a head injury, what is the investigation of choice? The investigation of choice in this particular patient is non-contrast CT scan of the head. Okay, so investigation of choice is non-contrast CT scan of the head. That is the investigation of choice, not the contrast enhanced CT scan. Why? Because acute extravasated blood, as you're basically seeing over here, this acute extravasated blood, that is basically appearing white, and that is what you need to understand over here. Now coming to this, this is what is a subdural hemorrhage. Okay, over here, what you basically get is a concavo-convex opacity, or a banana shaped or a crescent shaped opacity. So this is what is a like subdural. Okay, subdural hemorrhage, SDH, and this is what is an extradural hemorrhage. Are you understanding my point? So this is an acute subdural hematoma which you're basically getting over here. So this is, at least the image is very, very important. Please do understand this point. Okay. Oh yes, over ADH, the most common kind of injuries to the middle meningeal artery, and in the subdural hemorrhage, what you have is a bridging veins or the emissary veins. These are the ones which are basically injured in the subdural hematoma. Okay. Now what you're basically seeing over here, this is what is a cerebral contusion. Okay, this is a cerebral contusion. Why does this happen? So this is basically happening because of Cope counter Cope mechanism. So whenever there is a kind of a trauma and your basically head basically comes to a halt after hitting to a surface, the brain continues to move forward, and that particular brain comes and hits your skull, and that is why there is a hematoma which is basically getting formed, and this is what is a contusion of the brain. So that's it. This is what is called as a cerebral contusion. Okay. Now what is this? This is what is a subarachnoid hemorrhage. Okay. So this image is not that important. That's fine. But these two images you cannot forget. Extradural hemorrhage and the subdural hematoma. Very, very important images, guys. Please do not forget them. Okay. Right. So subarachnoid hemorrhage, most common cause is the trauma. It can also happen because of the rupture of the aneurysm and all those particular stuff, but not that important. Okay. So let's kind of skip it because of the want of time. Now, this is an important image which they might kind of show you. So if they might tell that, you know what, the patient had a road traffic accident, and after that the patient came, the patient was having difficulty in breathing, and this is the image which they are basically trying to show you. Okay. So what is the kind of diagnosis of this particular patient? Can you please tell me, guys? So over here, what you have is a hemothorax. Okay, so what is this? This is what is an hemothorax. So, okay, so when the patient comes to you, okay, so when the patient comes to you, what this is important. The clinical scenario they can ask you. So they will say that the patient is having like difficulty in breathing. When you go, the patient is in the respiratory distress. Then you will examine the patient. What are you going to find? You're going to find that the trachea is deviated to the opposite side. Trachea is deviated to the opposite side. That's fine. Now, when you basically try to auscultate this particular patient, there will be absence of the breath sounds. But I will come to this. Okay, dull note on percussion. I will come to this. But all these particular findings you will also find in the patients of a pneumothorax. That is respiratory distress, trachea deviated to the opposite side, and the absence of the breath sounds. But the only difference will be over here there is going to be a resonant note, because in the pneumothorax what you have a air underlying the chest. But over here in the hemothorax, what you're basically find, you're going to find the dull note on percussion. So on the hemothorax, there is a dull note on percussion. Over here, what you have is a resonant note on percussion. Understood, guys? I hope you have understood this particular point. And these images are absolutely important. Over here, I hope you're able to appreciate this is a radio opaque kind of a density. So that is what is your telling after the trauma. It can be the pleural fission as well. But if at all the patient is coming to you after trauma, what does this indicate? This indicates that there is a hemothorax. Understood? Now, over here, what you are seeing, this is what is the blackout of the lung, and this is a collapsed lung which is lying down over here. Very, very important image. Very, very important. This is the image of a pneumothorax. Over here, it is a normal lung. I hope you are able to appreciate this is more black as compared to the opposite side. So why? Because over here, there is a bronchovascular markings are still present in this particular side. But on the opposite side, what you are basically seeing that there is absolutely pitch black. So that is basically trying to tell you that the lung has collapsed, and what is there is basically just the air. That's it, nothing else. Are you understanding? These two images, please do not miss. Very, very important. For the hemothorax, what is the kind of treatment you have to put? ICD has to be put, no doubt about it. And then there is a indication of thoracotomy also. Important images, important MCQ is, if at all the stat output is more than 1.5 liters in case of a blunt abdominal trauma, or more than 1 liters in the penetrating trauma. If you want to remember one value, just remember 1.5, but there's a bifurcation between the blunt and the penetrate. Okay, or if at all the output is more than 200 ml per hour for 3 consecutive hours. Okay, so if at all the output is more than 200 ml per hour for 3 consecutive hours, this is an indication to perform a thoracotomy in these particular patients. Important MCQ. Understood? Now, this is what is a kind of a boundary of the safety, which is like where will you put this particular ICD? So usually you basically put it in the 5th intercostal space in the mid-axillary line, but there's something which is called as a triangle of safety. So what is this triangle of safety? It is bounded by the lateral border of the pectoralis major, lateral border of the latissimus dorsi, 5th intercostal space, and the base of the axilla. So this basically corresponds to the triangle of safety, guys. Okay, that's fine. So here you can put a ICD. Okay, now coming to the management of the pneumothorax. So there are two things. One is basically the tension pneumothorax. So if at all there is a tension pneumothorax, this is a life-threatening condition. What is the difference between the pneumothorax and the tension pneumothorax? In the tension pneumothorax, with every breath you take, the pressure inside the thoracic cavity keeps on increasing. And if at all it is keeping on increasing, what is going to happen? The patient is going to be hemodynamically unstable. So when you look at the clinical scenario, the difference between the pneumothorax and the tension pneumothorax, all the things will be same. The respiratory distress will be there, trachea will be deviated to the opposite side, you will not be able to hear the breath sounds, and when you kind of percuss, there is going to be the resonant note. But in the simple pneumothorax, there is going to be the two-way motion of that particular air from the thorax to the outside. But in the tension pneumothorax, there is a flap valve mechanism. So every time you take a breath, the pressure inside the thoracic cavity increases. That basically compresses on this particular superior vena cava and all those particular stuff. And there is a back pressure changes which basically takes place. Are you understanding my point, guys? So tension pneumothorax, that is a life-threatening condition. And in the emergency, you have to put a needle thoracocentesis that is basically done in the second intercostal space in the mid clavicular line. Okay, so the needle thoracocentesis is done in the second intercostal space in the mid clavicular line. And what about the ICD? ICD is obviously the definitive kind of treatment. Just by putting a needle thoracocentesis, it's not going to help. So you have to put an ICD. ICD is usually put in the fifth intercostal space in the mid axillary line. So that is what you need to understand over here. Okay, now coming to the diaphragmatic injury. Okay, so how will be the clinical scenario? The clinical scenario of diaphragmatic injury is kind of important. Not very, very important, but yet is important. So two things they can ask you in the diaphragmatic injury. One is that they will tell you that there is a patient who is having a stab injury in the kind of, let's say, back or something. And then the patient came with the patient is absolutely asymptomatic. So most of the patients of the diaphragmatic injury are absolutely asymptomatic. And you are suspecting that there's something wrong or something like that. And if at all they ask you straightforward, what is an investigation of choice for the diaphragmatic injury? Do not answer it as MRI, because that is the most common wrong answer which you guys kind of end up giving. So the investigation of choice for the diaphragmatic injury is diagnostic laparoscopy, or you can do a VATS, video assisted thoracoscopy. So this is like so you have to just put in a camera and you have to see whether there is any breach or not. So if you suspect that there is an intra-abdominal injury as well along with it, then in that case you can perform a diagnostic laparoscopy, and if at all there is some intra-abdominal injury, you can handle that at the same particular time. So they might give you the clinical scenario. See, if at all there is a very, very large defect in the diaphragm, definitely the intestine and everything will be up and the patient is going to be in the respiratory distress. But most of the times the breach is very, very small. And then in that particular scenario, the patient is usually asymptomatic. For the diagnosis, you have to kind of you have to put in a camera and see. Either you can put it in the thorax. If you put it into thorax, that is what is called as a video assisted thoracoscopy. If you put it inside the abdomen, that is what is called as a diagnostic laparoscopy. Understood it, guys? Now, if at all the defect is very small, can you just leave it like that? The answer is no, you cannot. So conservative management is not an option for the diaphragmatic injury. You always have to repair it. How do you repair it? You repair it with the help of a non-absorbable suture. Okay, non-absorbable suture. That is basically used in order to repair a diaphragmatic injury. Very, very important. You always have to kind of repair it. You cannot kind of leave it like that. Okay, now coming to the abdominal trauma. Okay, so guys, coming to the abdominal trauma, what I wish to ask you is that what is the most common organ injured after a blunt abdominal trauma? These are the one-liners which they might ask you. So the most common organ injured after blunt abdominal trauma is the spleen. The most common organ injured after the penetrating abdominal trauma. Please understand, it is not the small intestine. It is the liver. If they ask you overall, what is the most common organ injured after the penetrating abdominal trauma? The answer is liver. It is not the small intestine. Understood, guys? And if they ask you after the gunshot wound, then yes, you can answer the small intestine. Okay. Now, what is fast? Okay. So, by the time I explain you the fast, please put in the comment box, what is the minimum amount of the fluid which can be detected on the fast? Okay. So, can you please tell me what is the minimum amount of the fluid which can be detected on the fast? Okay, so what is fast? Fast is basically a ultrasound itself. It is an ultrasound which is basically performed in the emergency room. It is an ultrasound which is basically performed in the emergency room, and whatever we do in life, that has to have some aim, right? So what is the aim of performing a fast? The aim of performing a fast is to check for intraperitoneal fluid. Okay, so the aim is to basically check for intraperitoneal fluid. Okay, now why do you want to check for the intraperitoneal fluid? Normally, you and I, we do not have an intraperitoneal fluid, a significant amount of it, right? But let's say if at all the patient has come after the trauma and you do an ultrasound, a fast ultrasound, and if at all you find that there is a significant amount of fluid inside the peritoneum, it is an indirect indication that there has been some major injury inside the abdomen. So what is fast? Fast is a quick investigation which you basically perform in order to detect the intraperitoneal fluid, because that is going to indirectly tell you whether any significant injury has happened inside the abdominal cavity or not. So that is what you need to understand over here. Okay. Now, where do you put these particular probes, guys? Okay. So in the fast, what you basically do is you keep your probes at 4 locations. So you keep it in the epigastric region, in the right hypochondriac region, in the left hypochondriac, in the pelvic region. So these are the 4 places where you put, and when you're putting it in the epigastric region, you're checking whether there is any fluid inside around the heart. That is, you're checking for pericardial tamponade. In the right hypochondriac region, you're checking for the fluid around the liver. In the left hypochondriac region, you're checking for the fluid around the spleen. And in the pelvic region, you're basically checking for the fluid around in the pelvic cavity. So this is what is a fast. I hope you're understanding this particular point. So this is how you perform a fast. And nowadays, what we basically perform is something which is called as an e-fast. What is this e-fast? E-fast is extended fast, where we also check for the thoracic cavities. Now, very, very important thing which they have asked you in past as well is, what is the barcode sign and what is the seashore sign? So what is the barcode sign? Barcode sign basically indicates that there is pneumothorax. Pneumothorax. Okay. Why? See, ultrasound and air, they do not go hand in hand. Okay. So whenever there is a large amount of air, what is going to happen? It is going to create a lot of artifacts. So if at all the air is going to create a lot of artifacts, that basically shows up as a barcode sign. Seashore sign is basically if you put an ultrasound probe on my chest and your chest, we both are normal. So it is going to show a seashore sign. So just remember, seashore sign is present in normal individuals, but if at all the patient is having a pneumothorax, that is what is a barcode sign. What you basically get. Now, in the extended fast, you keep your probe at 6 positions. Okay. Now, this is what is a fast method, what you're basically performing over here. So the entire process of this fast or an e-fast, it has to be over in 3 to 5 minutes. Our aim is not to look for any like let's say the patient is having a gallstone or not or something like that. We are not trying to look for that. We're just trying to see whether there is any intraperitoneal fluid collection. Is it good for retroperitoneum? The answer is no. And what is the amount of the intraperitoneal fluid which is kind of detected by this? Nobody answered, but yeah, the answer is around 100 to 150 ml. Okay, so 100 to 150 ml, that is the minimum amount of fluid which is basically needed in order to detect it on the fast. I hope you are able to understand. This is an intraperitoneal fluid. Okay, now this is important. Okay, now they might ask you, what is the first investigation which you perform in the patients of a blunt abdominal trauma, and what is an investigation of choice? Okay, so these are the 4 MCQs which they might ask you. First investigation and investigation of choice. So whenever you have a patient of a blunt abdominal trauma, what you basically do is you divide it into hemodynamically stable patients and hemodynamically unstable patients. So if at all you have a hemodynamically stable patient, in that the first investigation is the fast, and the best or the investigation of choice is a contrast enhanced CT scan. For the simple reason that the patient is stable, you can shift the patient to a CT scan and that is going to give you a very good information about it. What about the hemodynamically unstable patient? In that, the fast is our first investigation and fast itself is our investigation of choice. So we have to take a decision based on the findings of the fast along with the clinical judgment, whatever you are basically having. Are you understanding my point? So this is important. First investigation and the investigation of choice, direct questions which can be asked to you. Okay, now coming to the splenic injury. So over here, just remember there's something which is called as a Kehr sign. So can anybody tell me what is a Kehr sign, guys? Okay, don't tell me, just talk to yourself. What is a Kehr sign? So let's say if at all there's a splenic injury, what is going to happen? There's going to be the blood accumulated in the left hypochondriac region. So that is what is going to irritate the diaphragm. So if at all it irritates the diaphragm, what is it going to happen? The pain is going to get radiated to the left shoulder. So this is what is a Kehr sign. So this, they might give you a kind of, in the clinical scenario, the patient came with blunt abdominal trauma and the patient is hemodynamically unstable, like the so let's say the BP is slightly on the lower side, and the patient is having a pain radiating towards the left shoulder. So this is what is a care sign, which basically tells you that the patient is having a splenic injury. Diagnosis will depend on, okay, obviously you're going to perform the fast, but if at all the patient is hemodynamically stable, you will also perform the CT scan, and based on whatever the report is kind of coming, the decision of whether you want to operate on these particular patients or not will depend on hemodynamic stability. So very, very important. Please do remember, I'm not going to the grading and the classification, AAST classification of the splenic injury, but whatever the kind of grade of the splenic injury is there, if at all the patient is hemodynamically stable, you have to give a conservative management, or rather you can give a conservative management. You do not need to operate. But if at all the patient becomes hemodynamically unstable, then it doesn't matter what the grade of the splenic injury is there, you have to kind of operate. Because I have seen a couple of questions where they have kind of twisted these particular facts, and they have asked you, doesn't matter whether it is a grade 4 injury or a grade 3 injury or a grade 5 injury, if the patient is hemodynamically stable, you can prefer to go ahead with a conservative management for these particular patients. Okay, I hope you have understood this particular point. Okay, now let us talk about, okay, so why is spleen needed in our body? That is basically to for the immune response. Okay, so like the antibodies and all those particular stuff. Now, once we remove, okay, and it is especially important for encapsulated organisms. So H influenza, pneumothorax, pneumococcus, and the meningococcus. So these are the encapsulated organisms, and whatever the spleen is basically plays a major role in preventing these particular infections in our body. So if at all you are planning a splenectomy, elective splenectomy, you have to give the immunization to these particular patients before the surgery, 2 weeks before the surgery. But if at all, let's say it was an emergency splenectomy, then before you discharge the patient from the hospital, usually 5th post-operative day, you have to immunize these particular patients. If you don't immunize, what is going to happen? The patient might suffer from OPSI. Now, please understand, the full form of OPSI is overwhelming post-splenectomy infection. It is not an opportunistic post-splenectomy infection. It is an overwhelming post-splenectomy infection. Very, very important. Okay. Why this is important? Because it is having high mortality. So if you kind of don't take care of that, the patient might not survive. So that is something which is important about the OPSI, what you need to understand over here. Okay, now coming to the liver trauma, well, it can happen, that's fine. One of the important things over here, what you need to understand is the Pringles manure. Now, what is this Pringles manure, guys? So they might show you this particular image, an important image, okay? So, okay, now I'll ask you a question. Okay, I'm just talking for such a long period of time, I'll just ask you a question. So this is the Pringles manure. You basically obliterate this particular hepaticoduodenal ligament, and the bleeding basically doesn't stop. What does it mean? Whether the bleeding is rising from the hepatic artery, or let's say the portal vein, or the hepatic vein. Can you please give me that particular thing in the answer? The answer is, it is arising from the hepatic vein. Now let me just explain you what is this Pringles manure. So this is a hepaticoduodenal ligament. Okay, what are the contents of the portal triad? What is the contents of the portal triad? We have the common bile duct, that's fine. Then we have the portal vein, and then we have a hepatic artery. Now, if at all the patient is having the bleeding, and the bleeding source is the liver, if you come, either you press this with your kind of fingers, like with this particular finger and the thumb, or you apply a soft clamp. Soft clamp means an atraumatic clamp. If you apply that, and if at all the bleeding stops, it means that the source of the bleeding was either the hepatic artery or the portal vein. But if at all the bleeding continues, so there is another kind of blood which kind of blood goes out of the liver from the hepatic vein, right? So here there is a portal vein and the hepatic artery which is bringing the blood inside, and the hepatic vein is basically taking the blood away from here. So that is what you need to understand. If at all you compress the hepaticoduodenal ligament and the bleeding doesn't stop, it means that the source of the bleeding was hepatic vein. Okay, so compress the hepaticoduodenal ligament. If at all the bleeding continues, the source of the bleeding is hepatic vein. And if at all the hepaticoduodenal ligament you compress and the bleeding stops, it means that the source of the bleeding was either portal vein or the hepatic artery. And you can apply this particular clamp for around 30 minutes. After that, you have to kind of release it for at least some period of time. That is something which is important. Okay, now this is important. What is a deadly triad? Okay, so the concept of a damage control surgery. Damage control surgery. This is important. What is a damage control surgery? So the whole concept of the damage control surgery is that we only want to address the pressing issue. let's say if at all there is a bleeding from a major vessel, or let's say there is a contamination of the abdomen because of the leak of the contents from the intestine, in this particular scenario, you have to kind of do something, right? So this is what is a damage control surgery. We do not intend to kind of do the primary anastomosis over here. We do not intend to do a major surgery which is going to last for 8 to 10 years. Why we don't want to do that? Because if you do a prolonged surgery, it will be detrimental for the patient. So they might ask you, what is the damage control surgery? Damage control surgery has 3 phases into it. In the first phase, what you basically do an emergency intervention. So obviously, if at all, let's say some vessel is kind of bleeding, obviously it is empirical to kind of go and stop that particular bleeding. Let's say if at all the intestine is kind of uh, the continuity of the intestine is kind of lost. In that particular scenario, the contamination is taking place inside the peritoneum. So you have to kind of stop that particular contamination. So that is what you need. That is what is done in the phase 1 of the damage control surgery. That is an emergency intervention. Then after you have controlled the bleeding, taken care of the contamination, you do not try to do the anastomosis and everything. You shift the patient to the ICU. Okay, intensive care unit. So the second phase of the damage control surgery happens inside the ICU. Here, what you basically take care of, you take care of this lethal triad. Okay, so here you basically take care of this deadly or a lethal triad, which basically comprises of hypothermia, metabolic acidosis, and hypercoagulable state. Okay, so what we have seen is that, okay, so this is important. What is a lethal triad? Lethal triad comprises of hypothermia, metabolic acidosis, and hypercoagulable state. So in the ICU, you address these particular lethal triad, and after the patient is stable, let's say after 3 days or 4 days or something like that, at this point of time, you again bring the patient to the kind of surgery, and then you do a definitive surgery. So that is what you need to understand about the abdominal like damage control surgery, and this is how you basically tackle the lethal triad. In other words, if you do a prolonged surgery, the patient is it is going to be more harmful for the patient, because this lethal triad is going to kill that particular patient. So rather than doing a surgery in one stage, what you basically do, you divide it into 3 phases. In the first phase, you take care of whatever the pressing issue is there, let's say bleeding or contamination or whatever. In the second phase, you shift the patient to the ICU, where you resuscitate the patient and you take care of this lethal triad. And in the third stage, you bring the patient back to the operation room, and then you do a definitive surgery. So this is what is a damage control surgery, which you need to understand over here. Okay, now let's talk about the abdominal compartment syndrome. Okay, so what is this abdominal compartment syndrome, guys? So it can happen because of various reasons. Okay, so this abdominal compartment syndrome, it can happen because there is a lot of blood which is accumulated inside the abdomen, or it can happen because let's say there is let's say a lot of fluid resuscitation has been given, or let's say there is a paralytic ileus. So due to any reason, if at all the pressure inside the abdomen is very increased, that is what can lead to an abdominal compartment syndrome. If at all the pressure is increased to more than 20 millimeters of mercury, we call that the patient is suffering from an abdominal compartment syndrome. Why this 20 millimeters of mercury? Because at this point of time, what happens? The physiological changes start to happen. It means that the cardiac output is getting reduced, the central venous return is getting reduced, the renal blood flow is basically getting reduced, and the urine output is getting reduced. So they might ask you, what are the factors which get reduced? Cardiac output, central venous return, renal blood flow, and the urine output. That is basically getting reduced. And what is getting increased? Heart rate, pulmonary capillary wedge pressure, central venous pressure, and the systemic vascular resistance. So these are the physiological changes which takes place, and that is which is not good. And our aim is to reduce the pressure inside the abdomen. How do you do that? If at all the pressure is significantly high, more than 30-35 millimeters of mercury, in that particular scenario, you have to perform something which is called as a decompressive laparotomy. Okay, so here you have to perform a decompressive laparotomy. Okay, understood? Now, after you have performed a decompressive laparotomy, okay, it is exactly like your compartment syndrome of the leg. There, what you did, you basically put an incision on the fascia so that the muscles got space to kind of expand. Over here, what you're doing, performing a decompressive kind of laparotomy, so the intestine and everything will get kind of space to kind of expand. Are you understanding my point? So after this, if you again bring the edges together, that is going to be detrimental, because again the pressure is going to rise. So you have to perform a temporary closure. You cannot keep the abdomen open, right? So can you please tell me what are you basically seeing on this particular image? How is the closure has been performed over here? So the closure has been performed with the help of a Bogota bag. Okay, what you're basically seeing over here, this is the Bogota bag closure or the temporary closure which has been performed over here, because obviously you cannot keep the abdomen open. This is an abdominal compartment syndrome. And after the primary pathology, let's say it was a bleeding, or let's say it was a paralytic ileus, or let's say the edema of the bowel, after that basically subsides, then you can bring that particular edges together and you can close that particular abdomen. So that is all about the general surgery part which we have covered. Now, are you guys still here? I just want to hear from some of you. Okay, so is my speed fine? Should I reduce the number of topics, or I should reduce my speed or something? So before I start GIT, I just want a feedback from you guys. Okay, so I'm here. Please write it in the comment box. See, the whole point is I could have, let's say, discussed 25 questions or 30 questions or something like that, but I just wanted to revise the basic stuff with you. So just give me a feedback, guys. Like, is this particular pace and everything is fine, or you want to do some changes over here? Just give me 1 minute of feedback over here. Anybody, guys? Anybody? It's okay? Okay. Okay. So what we are going to do is, we are just waiting for your response. Okay, that's great. Okay, so now let's kind of start with our GIT, guys. Okay, so let's start with the GIT. What we'll do is we will read till around 6:15 or something, and then we will take, let's say, 15 minutes break, and then we will join back. Okay, so we have around 4.5 hours session. Okay, now let's start with the esophagus. The first thing is GERD. What is GERD? This is gastroesophageal reflux disease. Okay, now this is very, very important. Okay, now what happens in the gastroesophageal reflux disease is that, okay, a couple of things can be asked. What is the cause of the GERD? You and I, we don't get a GERD, right? So there is an intra-abdominal part of the esophagus, and that is basically responsible for preventing the reflux, because when the abdominal kind of pressure increases, that particular part gets compressed and the reflux is not there. And then there is the external urinary sphincter, like esophageal sphincter and all those particular things. That's fine. So one of the main reasons why the acid reflux takes place is reduced intra-abdominal length of the esophagus. Okay, now over here they will ask you the clinical based scenario. They will give you the scenario that the patient has a heartburn, or when the patient basically lies down, there is a cough, or let's say the patient has suffered from dental caries. Why dental caries? Because the acidic environment causes demineralization of that particular teeth, right? Okay, now over here, the pet question which they usually ask is, what is the investigation of choice to diagnose a GERD? So the investigation of choice to diagnose a GERD is 24-hour pH monitoring. Okay, so what is the investigation of choice? It is a 24-hour pH monitoring. And how do you kind of manage it? So you give antacids to the patients, you kind of ask them to go ahead with the lifestyle changes and all those particular stuff. But if at all it doesn't help, then you have to wrap the stomach around the esophagus. Now I do not have the image of this, but this is an important image. They might show you that. Okay, so if at all there is a surgery where this stomach has been wrapped around the esophagus, this is what is called as a gastric fundoplication. Okay, so gastric fundoplication is the surgery which you basically do for gastroesophageal reflux disease. Okay, now if at all, let's say there is a GERD and you do not treat it, what is going to happen? The acid reflux will continue to happen, and if at all the acid reflux continue to happen, there is going to be esophagitis. Why esophagitis? Because the lining of the esophagus is not trained, or the God has not made it in order to kind of withstand the acidic environment of the stomach. So there's going to be esophagitis, and over a period of time there's going to be a Barrett's esophagus. Now guys, can anybody tell me what is a Barrett's esophagus in one word? Is it like a squamous metaplasia or a columnar metaplasia? Can you please tell me? Okay, so there's going to be a Barrett's esophagus, and because of that Barrett's esophagus, there's going to be the dysplastic changes in that, and ultimately the cancer can happen, which is an adenocarcinoma. So a cancer which develops in the Barrett's esophagus is an adenocarcinoma. Understood? Now, so Barrett's esophagus is a columnar metaplasia. Why columnar metaplasia? Because the squamous epithelium is getting converted into a columnar epithelium. Okay, that is why it is a columnar metaplasia. Simple, basic pathology question, important one. They ask you this, I don't know why, but yeah, it's a very, very basic question. Squamous epithelium is getting converted to columnar epithelium. That is why it is called as a columnar metaplasia. Understood? Now, what is an investigation which you perform? Let's say if you suspect a Barrett's esophagus, what is like? How can you get to know that? Okay, yeah, actually this particular patient is having a Barrett's esophagus. The only way is you have to put a scope down there and you have to see whether there has been any change in the epithelium lumen or not. So yes, I mean the investigation of choice is an upper GI endoscopy, and obviously if at all you find that there is a Barrett's esophagus, you should not just come out. You have to take a biopsy out of it. Why you want to take a biopsy out of it? Because you want to see whether there is any dysplastic changes or not, because if at all there is a dysplastic changes, there are high chance that the adenocarcinoma might develop over there. So yes, the investigation of choice for the Barrett's esophagus is upper GI endoscopy along with biopsy. Investigation of choice for GERD was 24-hour pH monitoring. Okay, now once you take a biopsy, obviously you are going to diagnose the Barrett's esophagus, but at the same time you will get to know whether there is any dysplasia or not. So if at all there is let's say only simple Barrett's esophagus, then it's fine. You just monitor that particular patient. Maybe you repeat like upper GI endoscopy once in a year or something like that. But if at all there is a dysplasia, then you have to kind of repeat this particular what you call as a upper GI endoscopy at more frequent interval. And if at all there is a high grade dysplasia, then you can also perform an ablative procedure. Forget about it. But yeah, you can perform a locally ablative procedure. But if at all, let's say you took a biopsy and obviously it showed an adenocarcinoma, no way around it. You have to proceed with a esophagectomy. Everybody understood this, guys? Okay. Now coming to this, what are you basically seeing on your image? So this is what is a hiatus hernia. What is this? Again, a very, very important topic, guys. Okay, so this is, esophagus is an important topic for you guys. Okay, so this is what is a hiatus hernia. Now, there are two main types of the hiatus hernia. One is called as a sliding hiatus hernia. Another one is called as a rolling hiatus hernia. Now, very simple. Sliding. What is basically sliding? So, gastroesophageal junction is basically sliding up. Okay, so this is a sliding hiatus hernia. As you can see over here, the gastroesophageal junction has kind of slided up. What about this? Over here, the GE junction is at a normal position, but what has rolled up? So the fundus of the stomach. Okay, so here the fundus of the stomach has basically rolled up. So this is what is called as a rolling hiatus hernia. This is what is called as a sliding hiatus hernia. Okay, now just by logic, can you please tell me, guys, that out of these two, in which of these there is going to be the GERD? Yep, I hope you understand that in the sliding hiatus hernia, because the GE junction has been pulled up, so there's going to be the reflux of the acid into the lower part of the esophagus. So that is what is a, so the GERD is basically associated with the sliding hiatus hernia. So let's talk about the hiatus hernia. It is hernia through the diaphragmatic hiatus, that's fine. So there's an esophageal hiatus. Through that, the stomach is basically getting herniated into the thoracic cavity. It is 4 types. So there's type 1, there's type 2, then there's type 3, type 4 as well. But the most important ones are the type 1 and the type 2. So what is type 1? Type 1 is the sliding hiatus hernia. Type 2 is the rolling, and rolling is also called as a paraesophageal. I did tell you that GERD is associated with the type 1 hiatus hernia. Okay, we have talked about it. Why? Because the GE junction is basically moving up, and if at all the GERD is happening over here, yeah, there is a scope for a what you call as a conservative management. We have already talked about it, right? That if at all there is a GERD, we can go ahead with the conservative management in the form of a proton pump inhibitors and the H2 blockers and all those particular stuff. But if at all it doesn't help, like if it doesn't kind of the patient's symptoms continue to happen, then we can go ahead with a gastric fundoplication. So the surgery is going to be the same. What about the rolling hiatus hernia or the paraesophageal hiatus hernia? Over here, there is a risk that this particular part of the stomach can become necrotic and gangrenous. So there is no role of the conservative management in the type 2 hiatus hernia. Type 2 is rolling or the paraesophageal, no role of the conservative management. Here what you basically do is the surgery. Okay, so that is what is kind of needed in the rolling hiatus hernia. In the type 3 is nothing but it's a type 1 and type 2. Both combined together, and type 4 is basically along with that if at all the defect is very big, and let's say the part of the liver is also kind of going up. So that is what is your type 4 hiatus hernia. Not that important, that's forget about it. Please remember at least type 1 and type 2. Now one kind of thing which they might ask you is Cameron's ulcer. So this is what is an ulcer. So this is what is a rolling hiatus hernia, right? The part of the stomach was up. So if at all there is an ulcer formation in this rolled up part, this is what is called as a Cameron's ulcer. What is the Cameron's ulcer? So this is the ulcer which is forming in the rolled up part of the esophagus. That is what is a Cameron's ulcer. Okay, now let's talk about the motility disorder. So one word, Okay, so what is the name of the classification system? Just remember the name, nothing major about it. So there's something which is called as a Chicago classification. Chicago classification is the classification system which is used for motility disorder. Now, motility disorders of the esophagus, it can be either a hypermotility disorder or a hypomotility disorder. So the hypomotility disorder is the achalasia cardia, and the hypermotility disorder is the diffuse esophageal spasm or the nutcracker esophagus. These are the two. Okay. Now, important image based question, very very important. What are you basically seeing on this particular image? Can anybody tell me on the comment box? What is this? This is what is a diffuse esophageal spasm. Okay, what is this? This is what is a diffuse esophageal spasm. Are you understanding point? So this is what is a corkscrew esophagus or a diffuse esophageal spasm. This is what you're basically seeing on this, right? Now, what is this? This is what is your like bird's beak appearance, or a pencil tip appearance. Okay, and what is the diagnosis of this? The diagnosis of this is achalasia cardia. Okay, so achalasia cardia is a hypomotility disorder, and this corkscrew esophagus is basically the like the diffuse esophageal spasm. This is what is a hypermotility disorder. I hope you have understood this point. Now let's quickly talk about the achalasia cardia. So what was achalasia cardia? Achalasia cardia was the hypomotility disorder. Now what do we have? We have a ganglion cells. Ganglion cells are the like local brains of the intestine, which are basically responsible for the intestinal peristalsis. Now, if at all there is an absence of the ganglion cells, that is what is called as the achalasia cardia. Now, this particular thing can happen either congenitally. If at all it is a congenital, that is what is called as a primary achalasia cardia, or it can be secondary. Now, can you tell me what is the cause of a secondary achalasia cardia? So, the cause of the secondary achalasia cardia is Chagas disease. Chagas disease. This basically helps, like it basically comes and it destroys the ganglion cells, and that can lead to your achalasia cardia. Understood? I hope you have understood this particular point. The absence of the ganglion cells, that is what is responsible for the achalasia cardia. Now, the characteristic, so a clinical based scenario can be asked, or it might be asked to you in this kind of achalasia cardia. What they will give you that, you know what, the patient has come and the patient is complaining of dysphagia, and characteristically they will say that, you know what, the dysphagia is more to the liquids as compared to that of the solids, because when they eat the solids are able to kind of push through that particular narrow portion and kind of go into the stomach, but the liquids they kind of find it a bit more difficult. Okay, so more to the liquids, that's fine. And dysphagia, that is what they're going to give you, and because of this, what is going to happen? All those complications. So if at all, let's say there is a food accumulated inside this kind of esophagus, the reflux is going to happen, and then that particular food particles might get aspirated into the lungs, and the patients might develop from aspiration pneumonitis. All those things are going to happen. Important. Along with the clinical scenario, they can give you this particular image and they can ask you the diagnosis, or they can ask you what is the investigation of choice for this particular stuff. The investigation of choice is manometry. What is the manometry? Manometry is basically you put in a probe and you check for the pressure, because when the peristalsis reaches to the lower end, what should happen? When the peristalsis reaches to the lower end, the like the lower esophageal sphincter should relax. And once the lower esophageal sphincter is relaxing, the pressure should basically go down. But if at all the lower esophageal sphincter fails to relax, that is what is telling you that the patient is having a achalasia cardia. And we have already seen this barium steady image. That is very, very important. Bird's beak appearance or the pencil tip appearance. That is very, very important. Now coming to the management. So there are 4 basic managements which you can use for the achalasia cardia. One is drugs. So over here you can give, let's say, the calcium channel blockers. Yeah, they can help a bit. Balloon dilatation can be done. Botox injection can be given. That's fine. But the kind of surgery of choice is Heller's cardiomyotomy. Now, what do you basically do in the Heller's cardiomyotomy? You basically cut the muscle. So, because the muscle strength is very high, what you do is you cut the muscle so that muscle becomes a bit weaker, and then it is easier for you to kind of eat the food. Okay, so that's fine. So that is the Heller's cardiomyotomy. And around 2 to 3 years back, they asked you poem. They just give you poem. Poem is basically a treatment for. So poem is a treatment for your achalasia cardia. Poem is what? It is a per oral endoscopic myotomy. So over here also you are basically cutting the muscle, but you're not opening the abdomen. In the Heller's cardiomyotomy, you're basically opening the abdomen and then you're kind of giving the incision. In the Poem's procedure, what you basically do is you do it by the endoscopic route. So that is what is a per oral endoscopic myotomy. That is a Poem's procedure. Please remember that is a treatment for your achalasia cardia. Now, achalasia cardia is a very, very important topic, guys. Please go through this. This is very, very important. A clinical based scenario can be asked to you. The image based questions can be asked to you. The question on the treatment of the achalasia can be asked to you. The investigation of choice is manometry. Okay, I hope you have understood this point. Now, you did tell me about the diffuse esophageal spasm and the achalasia cardia. Can you please tell me the diagnosis of this particular patient? So again, the patient had come to you with dysphagia and you had got a kind of a barium swallow done. And yeah, what is the diagnosis? Diagnosis of this particular patient is carcinoma esophagus. Okay, what is the diagnosis? It is a carcinoma esophagus. Why? What you're basically seeing is here there is an apple core appearance. I hope you're able to appreciate. Okay, so there are two things which you basically find. One is the shouldering of the esophagus along with this apple core appearance. Are you able to appreciate? It looks like somebody has eaten this particular apple away, right? So this is what is an apple core appearance which you basically characteristically see in the carcinoma esophagus. Okay, now coming to the carcinoma esophagus, it can be of two types. It can be the squamous cell carcinoma or an adenocarcinoma of the esophagus. What is the risk factor for the adenocarcinoma of the esophagus? The risk factor for the adenocarcinoma of the esophagus is Barrett's. We just saw that, okay? Now what about the risk factor for the squamous cell carcinoma of the esophagus? It is smoking. Okay, smoking is the risk factor for your kind of squamous cell carcinoma of the esophagus. The most common cancer is the squamous cell carcinoma. Or if at all they specifically ask you about the lower 1/3, then yes, the chances of the adenocarcinoma is a bit more. But overall, or in the middle part of the esophagus, the most common cancer is your squamous cell carcinoma. Now, these are the few of the one-liners which they can ask you. Now, see guys, one-liners are usually not asked nowadays as direct one-liners, but they will give you a clinical based scenario, but actually what they are asking is a one-liner. So they will give you the clinical based scenario to tell you that, okay, this is the diagnosis, and then they will ask these particular things as the last sentence of that particular clinical based scenario. So the presenting symptom of the carcinoma esophagus is dysphagia. That's fine. Now, when we talked about the achalasia cardia, what did I tell you? That the dysphagia is more to the liquids. Over here, it is kind of more to the solids, and mota mota it is basically same to each other. But yeah, like the liquids find it a bit like liquids go dysphagia develops a bit later as compared to that of the solids. Now, first investigation is the barium swallow. So whenever you suspect anything in the kind of esophagus, you have to know at the anatomical boundaries or anatomical structure, whatever the lesion is there. So first investigation is always the barium swallow. May it be a diffuse esophageal spasm or the achalasia cardia or something like that, you have to get a barium swallow done. Now, investigation of choice is endoscopy with a biopsy. Most of the cancers in the body, for the diagnosis, what you have to get in is the biopsy. Now, only way to get a biopsy from the esophagus is do an upper GI endoscopy, get a biopsy, come out. A very, very important question. Investigation of choice for the T and N stage. Okay, so here what we have is something which is called as an endoscopic ultrasound. So whatever the endoscope you're putting, at the end of it, there can be an ultrasound probe attached to it. So EUS, that is an endoscopic ultrasound, that is the investigation of choice for the T and N stage of this particular cancer. And if we talk about the overall staging of this particular cancer, the overall staging is done by the PET CT or the CT scan. That's irrelevant, but the important ones are this. Investigation of choice for the T and N staging and first investigation, blah, blah, blah. This is very important. For T and N staging, the investigation of choice is endoscopic ultrasound. Now, talking about the esophagectomy. So if at all, if at all there is a cancer, you have to perform an esophagectomy. And there are three main types of the esophagectomy. There is a transhiatal or an Oringer's esophagectomy. Then there is a Ivor-Lewis, and then there is a McEvans. Okay, now just understand very, very briskly that in the transhiatal, what you're basically doing, you're putting an abdominal incision and then you are basically putting a cervical incision. So you basically so you are basically putting only two incisions, one in the abdomen, one in the left cervical. That's fine. Now, let's kind of complete this Oringer's or the transhiatal one. Okay, so after you have removed that particular esophagus, you have to kind of replace it with something. So whatever the conduit you are going to use, we are going to talk about the conduit. Whatever the conduit you're going to use in the Oringer's or the transhiatal esophagectomy, that particular conduit is anastomosed in the left cervical region. Over here, the most common complication is the leak, but that is not fatal because whatever the mucus fistula is going to form over here, that is what is going to heal kind of spontaneously. I hope you are understanding this point. Okay, so this is the most commonly done procedure, transhiatal esophagectomy. Then we have a Ivor Lewis. In the Ivor Lewis, again you put two incisions. One is in the abdomen, one is in the thoracic cavity. Now over here, once you okay, here the anastomosis is basically happening in the thorax. So over here also the most common kind of complication is the leak, but if at all the leak happens in the thorax, the patient is going to land up into mediastinitis, and that is going to be not good for the patient, and the patients might die in these particular scenarios. So yes, that is what you need to understand. And finally, you have something which is called as a McEvans. We usually not perform it very commonly because here there are three incisions which you basically give, one in the cervical, one in the thoracic, one in the abdominal. It is associated with a lot of respiratory comorbidity, so usually it is basically not preferred. But do remember the transhiatal or the oringus or the Ivor Lewis. Ivor Lewis, the anastomosis in the thorax, the transhiatal oringus, the anastomosis in the left cervical region. Okay, now I told you that once you're removing the esophagus, what you need is you need a replacement for that. Okay, so what is the most common conduit which is used? Stomach. The good old stomach is basically lying down in the abdomen. You can just pull that stomach up and you can anastomose it either in the cervical cavity or in the thoracic cavity, right? Are you understanding my point? So stomach is basically used. They ask you it is based on which artery. So the stomach, the conduit which you basically make, that is usually based on the right gastric or the right gastroepiploic artery, because that is basically along the greater curvature and basically gives you a larger portion of that particular stomach. So it is based on right gastric or the right gastroepiploic artery. Then we have a colon. In the colon, what you need to understand, we use the left side of the colon. So obviously that is going to be based on the left colic artery. Then we have a jejunum. Jejunum is used for very, very short segments, usually not used, and duodenum is never used as a conduit. That is what you need to understand. Okay. Now, okay, so colon and the stomach, these are the two conduits which are usually used. Okay, if at all, let's say there is a metastatic CA esophagus. Okay, metastatic CA esophagus. Okay, and like the survival of this particular patient is very less. So the patient might not survive more than 3 months, 6 months, or something like that. And then you want to give some palliative option to that particular patient because the dysphagia is very real, right? So for whatever the 3-6 months, how will the patient eat? So one of the palliative things which you can do for these particular patient is this. So can you please tell me what are you basically seeing on this particular image? So this is what is a SEMS, self-expandable metallic stent. So this is an uncovered variety. You also have a covered variety. So usually what we use is a covered self-expandable metallic stents. That is what you basically use in order to kind of treat, to give a palliative kind of option for the metastatic CA esophagus. Okay, so esophagus is important, guys. I hope you have understood. Everybody is okay with it? Yeah, shall we move on? Okay, now let's talk about the congenital hypertrophic pyloric stenosis. Now this is again a very, very important topic for you. They keep on asking you questions over this, and this might come in, let's say, one of the top high yield 20 topics. So yeah, let's kind of discuss this. So very commonly they will give you a clinical scenario that, you know what, do you have a firstborn male child? The patient is brought to the emergency with the kind of non-bilious vomiting, and on the examination, on palpation of that particular patient, what you're basically going to see, you are going to palpate a olive-shaped lump, and the patient basically is dehydrated and there is kind of failure to thrive kind of picture, and that is how the clinical scenario is going to be. Okay, now very, very important. Firstborn male child, 3rd to 4th week, that is usual presentation time. The patient comes with a non-bilious vomiting because whatever the obstruction is, that is at the level of the pylorus, and the bile basically enters in the duodenum. So yeah, whatever the vomiting is happening, it is above the pylorus, and that is why what you have is a non-bilious vomiting. You have a palpable lump, which is usually olive-shaped lump, that's fine. And there is a visible peristalsis because the stomach is distended and the peristalsis of the stomach is basically visible. So yeah, there is a visible peristalsis. Investigation of choice for this is an ultrasound. Very, very important. Very, very important MCQ. The investigation of choice for the congenital hypertrophic pyloric stenosis is an ultrasound. Okay. Now, depending on whatever the length and the width, there's 16 millimeters of the length and 4 millimeters of the width. That is kind of the diagnostic criteria on the ultrasound for the congenital hypertrophic pyloric stenosis. Do remember the investigation of choice, very, very important. Another thing which you need to remember is what is the metabolic abnormality which is associated with this. So the metabolic abnormality which which is associated with congenital hypertrophic pyloric stenosis is hypochloremic, hypokalemic metabolic alkalosis. Now it is very, very logical. So what is happening? Whatever the vomiting is happening, it is from the stomach, right? So in the stomach, what is basically present is a HCl. So what is happening? The H plus is getting lost and the chlorine is getting lost. So obviously what you're going to have is kind of chloremic, hypokalemic. Why hypokalemic? Because if at all the kind of H plus is getting lost, so in the kidney, the potassium is also not getting absorbed in a good manner. So because the potassium is basically used in order to absorb the sodium because the hydrogen is not available, and that is why we end up excreting a lot of kind of this. And the patient is having a metabolic alkalosis, but in the last stages of this, what the patient develops is a paradoxical aciduria. Now there's a very good explanation for this. Let's not get into it. Just remember there's a hypochloremic, hypokalemic, metabolic alkalosis along with paradoxical aciduria. So if you understand the renal physiology, you would have already understood why there is a paradoxical aciduria. That's fine. But yeah, I hope you have understood this point, because a point comes when the patient cannot no more excrete the potassium, and even though the hydrogen ions are very, very less in the body, still the hydrogens are basically kind of lost inside the kidney because they want to absorb the sodium. Okay, I hope you are able to understand this point. Do remember hypochloremic, hypokalemic metabolic alkalosis with paradoxical aciduria. Ultrasound is the investigation of choice, and this clinical based scenario very, very important. Now when you have to manage these particular patients, so the first thing is resuscitate of the patient, because the patient is already hypokalemic and all this particular stuff. If you give anesthesia, it is going to be very detrimental for the patient. So first is resuscitate, collect the electrolytes and everything. And after the patient is stable, then you can perform a Ramstedt spiloromyotomy. So like in the esophagus, you had achalasia cardia, so the sphincter was very tight. So what you ended up doing is you ended up doing a myotomy. You cut the muscle layer so that the muscle kind of gets relaxed and the food is basically allowed to go into the stomach. Over here also, because the pyloric sphincter is very tight, you are going to cut that pyloric sphincter. That is what is called as the Ramstedt spiloromyotomy. Understood? Now, let's talk about the peptic ulcer. Very important. Okay, so they might ask you this, like, what is the location of the type 1, type 2, type 3, type 4, type 5 peptic ulcer? I'm pretty sure you know that. Just kind of let's revise with me. So what is the type 1? The most common type, that is at the incisura angularis. Okay, so at this particular portion, that is what is your incisura angularis. At the type 2, there is a pre-pyloric and the duodenal ulcer. So type 2 is both pre-pyloric as well as the duodenal. So that is what is the type 2 one. Okay, so yeah, this is the most common peptic ulcer. Now, then there is a pre-pyloric. So third one is the pre-pyloric, just proximal to the pylorus. Type 4 is along the lesser curvature, and the type 5 it at the greater curvature. Okay, so this is what you need to understand. These are the 5 whatever the types of the peptic ulcer. Very, very important. They keep on asking you, especially the type 2 one, because it involves the pre-pyloric as well as the first part of the duodenum. Very, very important. Johansson's classification of the peptic ulcer. Now coming to the complications of the peptic ulcer. So okay, two things what you need to understand. So this is your duodenum. Now the peptic ulcer can be present on the anterior wall or in the posterior wall. Now if I ask you, if at all the peptic ulcer is present on the posterior wall and that particular peptic ulcer ruptures, what is going to happen? What is the complication which you're going to face? You are going to face a bleeding. Why? Because just posterior to this particular part of the duodenum, what goes is a gastroduodenal artery. And if at all that particular peptic ulcer ruptures, that might injure this particular gastroduodenal artery, and because of that, there's going to be a torrential bleeding. So I hope you're able to understand. If at all there is a duodenal ulcer, and if at all posteriorly it is basically getting kind of perforated, the patient is going to have a bleeding from the gastroduodenal artery. Very, very important MCQ. Do not forget about this. Okay, anterior kind of perforation, it is going to be the similar as a stomach peptic ulcer getting perforated. The patient is going to have a perforation. Now I do not have the image of this, I'm sorry, but I hope you understand that if at all there is a gas under diaphragm, a very, very common X-ray, but a very, very important X-ray. A gas under diaphragm, that basically indicates a pneumoperitoneum, which indicates that there is some kind of a perforation in the intestine. Please do understand this. Very, very important. Very simple MCQ. Do not do it wrong. Okay. Now, okay. So most common kind of complication of the gastric ulcer is basically perforation. That's fine. it can also lead to a gastric outlet obstruction. How? If at all there is a duodenal ulcer which is happening, then healing, then again happening, and then healing, over a period of time, that first part of the duodenum can get stenosed, and because of that, there can be gastric outlet obstruction. The most common cause of gastric outlet obstruction is not that, okay? But yeah, it can lead to a gastric outlet obstruction. Okay, most common cause of a gastric outlet obstruction is a carcinoma. Okay, I hope you have understood this particular point. Now coming to the classification systems, I won't go into the details of these, but there are three named classification which you should remember over here. There's a Stewart classification, which is for the GE junction tumors. Then there's a Japanese classification, which is for the early gastric cancer, very important. And then there is a Borman's classification. We will cover this Borman's classification, which is for the late gastric cancer. At least remember the names of this. Borman you have to remember in detail as well, because they ask you this. Linitis plastica is which type of the Borman's classification? So that is a type 4 of the Borman's classification. So what is the Borman's classification? Type 1 is polypoidal, type 2 is ulcerative, ulceroproliferative, and linitis plastica. Simple, right? So polypoidal, ulcerative, ulceroproliferative, and the linitis plastica. Type 4 is linitis plastica. Very important MCQ. Now coming to the associations of the gastric carcinoma. Okay. Okay. So what are the associations of the gastric carcinoma? What is the Trousier's sign and what is the Trousseau sign? Okay. By the time I talk about this, please put that in the comment box. What is the Trousier's sign and what is the Trousier's sign and what is the Trousseau sign? Okay, so Trousier's sign is basically the Virchow nodes. What is the Virchow nodes? So that is a left supraclavicular lymph node enlargement. That is what is a Trousier's sign. What is a Trousseau sign? That is a migratory thrombophlebitis, which is basically seen in, let's say, the pancreatic cancer and the different cancers. Yeah, that is what is the migratory thrombophlebitis. Okay, now what are the associations of the gastric cancer? There can be Sister-Mary-Joseph nodules. So they might give you that, you know what, the patient is having a lymph node enlargement near the umbilicus. So Sister-Mary-Joseph nodule is a lymph node enlargement at the umbilicus. Okay, so that is what is your Sister-Mary-Joseph nodule. Very, very important. Then they can give you Krukenberg's tumor. What is this Krukenberg's tumor? Very, very important for the MCQ as well. So premenopausal, let's say bilateral tumors of the ovaries, and there is no tumor inside the ovary. It is a tumor above the ovaries. Okay, so that is what is the distinguishing feature, because ovary can have a primary tumor as well, right? So the characteristics of the Krukenberg's tumor is that there is a bilateral kind of tumors in the premenopausal age group, superficial tumors, no tumor inside the ovary. So this basically indicates the transcoelomic kind of spread. Okay, that is what you need to understand. Sister-Mary-Joseph nodule, lymphatic spread, and Virchow of nodes left supraclavicular. That is again a Trousier's sign, which is again a lymphatic spread. Okay, right. Okay. Now, okay. Now let's talk about the investigation of choice. The investigation of choice in order to diagnose the gastric cancer is endoscopy with biopsy. Okay, endoscopy with biopsy. Investigation of choice to like for the T and N staging is again endoscopic ultrasound. So that is what you need to understand over here. Okay, right? So understood? So investigation of choice to diagnose the gastric cancer is endoscopy with biopsy, and investigation of choice for the T and N staging is kind of endoscopic ultrasound, EUS. Okay, right. Okay, now I'll answer this particular question, guys. Will actually all the topics be covered over here? I will answer that. Just give me 1 minute. After completing this gastric cancer, I'll answer that particular question. Okay, so for the surgery, what you need to understand is that this is like surgery is tumor, gastrectomy, that's fine. For the lymph node dissection, you can do either a D1, D2, D3. Let's not get into it. So there are 16 lymph node stations over here. Usually we do till D2, that's fine, but forget about it. Let's not kind of get into it. Gastrectomy is something which is basically performed. So types of gastrectomy can be either a type 1 Billroth and type 2 Billroth. What is a type 1 Billroth? Type 1 Billroth is gastroduodenostomy. So here what you're basically doing is you're doing a partial gastrectomy and you are attaching the duodenum to that particular stomach. So that is a gastroduodenostomy, type 1 Billroth procedure. In the type 2 Billroth, what you're basically doing is it is a loop gastrojejunostomy. So over here, the loop of the jejunum is basically attached to the stomach. They might show you this image and they might ask you whether it is a type 1 Billroth or a type 2 Billroth. Okay, right. Okay, now After this particular Billroth procedure, after the gastrectomy procedure, what you basically find is a dumping syndrome. Very, very, very important clinical scenario, guys. So please understand this point, okay? So there is a dumping syndrome, there is an early dumping syndrome, and there is a late dumping syndrome. Usually they frame a question on the late dumping syndrome, so we will be talking about it. What is the early dumping syndrome? Early dumping syndrome means, okay, so what happens is that, let's say if at all you eat 2 chapatis, right? All the 2 chapatis do not go into the duodenum right away. So that, but basically food kind of stays inside the stomach. Over a period of time, there is a formation of a chyle, and that particular chyme is basically pushed into the duodenum slowly and gradually. But if at all you perform this particular gastrectomy, the pylorus is kind of gone, and whatever the food you're going to eat, that particular food is going to go inside the intestine right away. Okay, so that is what is the cause of all this particular dumping syndrome. So in the early dumping syndrome, this usually happens within 30 minutes when you eat food. So when you eat food, if at all this high osmotic food, it has an osmotic characteristic, right? So if at all that high osmotic food enters into the intestine, what is going to happen? It is going to take the blood from the whatever the capillaries and everything, like fluid from the capillaries and everything inside the lumen of the intestine. And if at all there is a lot of fluid inside the lumen of the intestine, there's going to be an increased peristalsis and the patient is going to suffer from an osmotic diarrhea. Okay, so because this high osmotic food is basically entering into the intestine, the patient is suffering from an osmotic diarrhea. Understood? Now, how will the patient come to you? The patient is going to have severe diarrhea and the patient is going to have dehydration. So that is a presentation of a early dumping syndrome. Now, what is the late dumping syndrome? In the late dumping syndrome, what happens is that when the intestine senses that, you know what, such a high amount of the osmotic food is basically entering into the intestine or our body thinks that, you know what, everything will get absorbed. And our body basically creates a lot of or secretes a lot of insulin. And as it secretes a lot of insulin, that is secreted, but this particular food is not getting absorbed. It is basically lost as a osmotic diarrhea. So there is an excess of the insulin in the body, relative excess of the insulin in the body, and because of this, what happens? The patient lands up into hypoglycemia. So late dumping syndrome, the clinical scenario would be post-gastrectomy patient presenting 2 to 3 hours after having meal, and now the patient is basically having hypoglycemia. Are you understanding my point? This is because of the relatively excess of the insulin. And early dumping syndrome presenting within 30 minutes, that is because of the osmotic diarrhea and the presentation would be dehydration. So this covers the important topics of your stomach. Now coming back to the 2 queries which I have. Okay, will this actually cover all the important topics? No, not really, because what we are doing, we are trying to cover most of the important topics from general part, general surgery part, GIT, hepatobiliary system and urology. I will not be able to touch all the sections in this. I am actually going to take around 4 hours. I don't know how much I will be able to cover, but let's see. I'll try to cover the maximum. So yeah, it is going to cover good amount of surgery, but not the entire surgery. Obviously, it is not possible. First thing. Second thing, yes, I mean, Trousseau sign is this carpopedial spasm. I meant Trousseau syndrome. So there is Trousseau syndrome that is basically migrated thrombophlebitis, which is basically present in the pancreatic cancer. Okay, I hope you have understood this particular point. Right, now coming to this, okay, let's start with the duodenum. Okay. I told you congenital hypertrophic pyloric stenosis, one of the most important 20 topics, right? Duodenal atresia, another one of the most important 20 topics in your surgery. Now what happens is that they will show you this particular image. What is this? Double bubble appearance, and whenever you see this particular image, you will jump and you will mark the answer as duodenal atresia. Do not jump, because this double bubble appearance is also present in one more condition. Can you please tell me in the comment box where else do you see this double bubble appearance? So double bubble appearance is also seen in annular pancreas. Okay, now what is the basic difference between annular pancreas and the kind of duodenal atresia? So the basic part is, okay, what is the duodenal atresia? That is, there is an atresia of the second part of the duodenum. That's fine. Now the child comes to you with the bilious vomiting. Okay, so in the duodenal atresia, the child is coming to you with the bilious vomiting. Understood? On the day 1 of life. That's fine. But in the annular pancreas, the child is going to have a non-bilious vomiting. In most of the cases, it is going to have a non-bilious vomiting. Are you understanding? So whenever you get this particular question, do read the entire question completely. Whether the patient, whether the question is asking you, the child double bubble appearance with the bilious vomiting or a non-bilious vomiting. Bilious vomiting, duodenal atresia, non-bilious vomiting, annular pancreas. Understood? Right, so double bubble appearance over here. This is a double bubble appearance. Okay. Now coming to the treatment of choice. So how do you manage this particular double bubble or like duodenal atresia? You have to perform a duodenostomy. Okay. So yeah, you basically attach the first and the second part of the duodenum, first and the third part of the obviously not the second. So first and the second part or third part of the duodenum is basically attached. That is a duodenostomy. Okay. Now. Right. Now what you need to understand over here, duodenojejunectomy. What is a duodenojejunectomy? Yeah, you are attaching duodenum to the jejunum if at all the duodenum is not that mobile. Okay, understood this, guys? Right. Now let's talk about the Meckel's diverticulum. Should I save the video? Yeah, I mean the video will be available on this particular YouTube channel, I think for a long period of time. So I think, yeah, you can access it later on as well. Okay, coming to the Meckel's diverticulum. What is the Meckel's diverticulum? Meckel's diverticulum is a true diverticulum. So what is the basic difference between the true and the false diverticulum? In the true diverticulum, all the layer of the intestine is kind of there. Okay, so yeah, mucosa, submucosa, serosa, all the things are there, muscle layer, everything is kind of there. That is a true diverticulum. In the false diverticulum, only the mucosa basically bulges out. So what is the Meckel's diverticulum? First of all, it is a true diverticulum. All the layers of the intestine are basically protruding out. Why it is there? So it is basically a congenital deformity. Again, Meckel's diverticulum is a very, very important topic. So yeah, please pay attention. So what is the cause? Cause is persistence of the vitellointestinal duct, which is basically present in the embryonic life. Over a period of time, it basically disappears. But if at all it persists, that is basically leading to a Meckel's diverticulum. So it is the most common congenital true diverticulum. That is what you need to understand over here. Now, let's talk about the clinical features. Okay, so what is a clinical feature? So they might ask you overall, what is the most common kind of clinical feature of the Meckel's diverticulum? That is bleeding. In the children, it is bleeding. In the adults, it is usually associated with a fibrotic band, and in the adults, it basically presents as an intestinal obstruction. Okay, but in the children or overall, the most common presenting feature is your bleeding. Understood? Okay. Now, why does bleeding occurs? So bleeding occurs because of an ectopic rest. So what happens is that inside this particular Meckel's diverticulum, there is an ectopic rest of a gastric tissue. Most commonly, it is an ectopic rest of a gastric tissue. And what is the kind of feature of a gastric tissue? Gastric tissue is going to produce HCl. Okay, acid is going to be produced, and whatever the acid is produced by this particular gastric tissue, that is going to act on this particular intestinal part, and it is going to cause bleeding from the part which is just in front of that particular diverticulum. Are you understanding my point? So that is the reason why the patients come to you with the bleeding, because there is an ectopic rest. The most common ectopic rest is a gastric tissue. Now, if you want to diagnose this particular condition, what you basically perform is a 99 labeled, technician labeled 99 blah 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 RBC scan. So this technician scan is something which is there, but this usually helps when there is an acute bleeding. Acute bleeding, yes, you can perform this technician scan and you will be able to diagnose this kind of Meckel's diverticulum. Now, for the treatment part, what you need to understand is that if at all there is a wide mouth and a very, very short Meckel's diverticulum without any ectopic rest, you can leave it there, not an issue at all. Incidentally detected Meckel's diverticulum, if at all you have, and if at all it is a wide mouth, they might give you, okay, so let's say the surgery was being performed and there was an incidentally detected Meckel's diverticulum, what will you do? If at all there is an ectopic rest, or you suspect that there is some kind of tissue or at the base of the Meckel's diverticulum or something, yeah, definitely resect it. If not, if at all it is a wide mouth and short kind of length, you can leave it there. If at all it is thin mouth and it is kind of long, you kind of resect it out. Now, how do you kind of do that? If at all the base of that Meckel's diverticulum is not involved, then you can simply perform the diverticulectomy. But if at all the base is involved, then you have to perform the resection and anastomosis. Are you understanding my point? So yeah, that is how you manage the patients of this Meckel's diverticulum. Okay, now looking at this particular X-ray, guys, can you please tell me what is it? What you're basically seeing is a air fluid sign. So this is basically trying to tell you that, you know what, the patient is having a intestinal obstruction. What is this? This is what is a step ladder pattern. So this is again like a again one of the features of your intestinal obstruction. But most commonly what they are going to show you is this. This is what is in air fluid levels, and that is what is going to help you in diagnosing the patients of an intestinal obstruction. Now, intestinal obstruction I will not be covering in detail, but yeah, there can be a dynamic and there is an adynamic intestinal obstruction. Paralytic ileus is very, very important. So paralytic ileus, why does it happen? So after the anesthesia is given, it takes time for the peristalsis to come. And if at all there is a prolongation for the peristalsis to come, then what is going to happen? The patients will have abdominal distension, and yeah, all those particular stuff is going to happen. It is going to present exactly like an intestinal obstruction, but there's no physical obstruction. It is an adynamic obstruction. It means that it is a functional obstruction because of the electrolyte abnormality and all those particular stuff. Important is how do you manage paralytic ileus. So management of the paralytic ileus is you have to put a nasogastric tube and you have to give fluid resuscitation. Please understand. And you have to obviously correct the electrolytes. So three things: nasogastric tube, fluid resuscitation, and correcting the electrolytes. So these are the three things which you have to do in the paralytic ileus management. Very, very important. Do not forget this. Important MCQ. They might give you a clinical scenario and they might ask you that. Okay. What is this, guys? What are you basically seeing on the image? A very, very important question. So I hope you're able to appreciate that this is a claw sign. What is this? This is a claw sign. Now, where do you see this claw sign? So claw sign is basically seen in intussusception. Okay, so what is this? It is intussusception. What is an intussusception? Intussusception is a condition where a part of the intestine is basically telescoping into the other, like in the distal part of the intestine, right? So one part of the intestine is basically telescoping into the other one. So that is what is an intussusception, and this is what the this is how the barium enema mein, this is how the intussusception looks like. Claw sign, very, very important. Okay, now. What is intussusception? As I told you, telescoping of one part of the intestine into the other. What is the most common type? In the children, it is ileo-ileal. In the adults, it is ileocolic. But that's fine. Ileo-ileal is the one common, and then yeah, in ileocolic in the adults, that's fine. What are the clinical features? So patients will come to you with intestinal obstruction. So clinical features, signs suggestive of intestinal obstruction. There's going to be the severe intermittent pain. Okay, so yeah, like there's going to be, the child is going to say that, there is a colicky type of pain, and then there is a period of relaxation, then there is again pain, and there is a period of relaxation. And another thing which they might give you in the clinical scenario is red currant jelly stool. Okay, so red currant jelly stool, very important. Okay, so all these are the things which they might give in the clinical scenario. Do not have time. I'm not trying to frame the MCQs over there at this point of time, but please understand, they will give you. The patient is going to have pain, bout of pain, then relaxation, bout of pain, then relaxation, and then the patient has come to you with a red currant jelly stool. They might show you the image of that, or they might show you the image of this barium enema, and they might ask you what is the diagnosis of this particular patient. The answer is intussusception. Are you understanding my point? So yeah, severe intermittent pain, empty right iliac fossa, dance sign. That is what is called as a dance sign, because the right iliac fossa is kind of getting empty because ileum has kind of gone into the colon. Are you understanding? Right. So on the X-ray, what you're basically seeing, air crescent sign. Okay, simple plain X-ray, air crescent sign. On the ultrasound, what you basically see is a target sign or a donut sign or a pseudokidney sign. All these signs are important. Target sign, I hope you understand, this is a target sign because one part of the intestine has gone into the other. Target sign, target, donut, or a pseudokidney sign. Okay, on the barium enema, what you basically say is a claw sign or a coiled spring appearance. So claw sign is something which they might kind of show you. All these things they can show you. Very, very important topic. Okay, I hope you have understood this point. Now, how do you manage it? Okay, so how do you manage the patients of intussusception? So you can try to reduce it with the help of an air enema. So air enema can be kind of given, reduce this intussusception. But if at all the peritonitis has already kind of set in, then you'll have to operate, and then you have to kind of maybe go ahead with the kind of resection anastomosis or something like that. And if at all the air enema doesn't help, okay, air enema doesn't help, no signs of peritonitis, then you can operate and you can milk that particular intestinal loop out. Okay, so all these things can be shown. Okay, so the image of the surgery can be shown where they are trying to kind of milk the part of the intestine out. You don't have to pull, you have to milk that particular intestine out. And if at all the peritonitis is there, then you go ahead with a resection anastomosis. Okay, understood, guys? Now, coming to this. Okay, so what is this particular image, guys? What are you basically seeing on this particular image? On this particular image, what is it? Diverticulitis or diverticulosis? The answer is, this is diverticulosis. What are you basically seeing is a sawtooth appearance. Okay, what is this? This is a sawtooth appearance which you're basically seeing, and this is what is a diverticulosis. Okay, now where does it occur? Colonic diverticulum. So that is what is a diverticulosis. Is it a true diverticulum or a false diverticulum? The answer is it is a false diverticulum. Okay, so it is the most common kind of sigmoid colon. That's fine. Okay, so this diverticulosis, diverticulitis, blah blah blah, it all occurs in the sigmoid colon because there the stool is kind of very hard and you have to apply a lot of pressure and all those particular stuff. Okay, that's fine. It is most common sigmoid colon. It is a false diverticulum. All the layers of the intestine are not protruding out. What is protruding out is the mucosa of the intestine is basically protruding out. It is a pulsion diverticulum. What do you understand by pulsion diverticulum? So if at all there is a lumen and you have applied a lot of pressure and the part of the mucosa is basically popping out, this is what is referred to as a pulsion diverticulum. So this is a pulsion diverticulum. It is a false diverticulum. Why does it pop out? So from wherever the blood vessels has entered into the intestine, those particular parts have potential weakness, and when the pressure inside the kind of lumen is going to increase, the mucosa might kind of pop out from those particular potential weakened site, and that is what is a pulsion diverticulum. That is what you need to understand over here. Okay, now there is something which is, this is a diverticulosis. I just showed you the image. So this is a sawtooth appearance, this is a diverticulosis. Now there is a basic difference, right? So there is something which is called the diverticulosis and diverticulitis. Diverticulosis, it's just the presence of a diverticulum, no infection within them. But if at all these diverticula, they end up getting infected, then we basically say it as it is a diverticulitis. Okay, so infection, peritonitis, diverticulitis, just the presence of a diverticula, chronic constipation. Okay, so in the clinical scenario, they will give you chronic constipation, XYZ, and yeah, now the patient is coming to you with a barium enema with the sawtooth appearance, diverticulosis. For the diverticulosis, the investigation of choice is barium enema. For the diverticulitis, the investigation of choice is the contrast enhanced CT scan. Please remember, CECT is the investigation of choice for the diverticulitis. Okay, now there's something which is called as a Hinch's classification. Okay, so Hinch's classification is basically there for diverticulitis. It is not for diverticulosis, it is for diverticulitis. It basically depends on how severe the diverticulitis is there. So if at all there is just a pericolic abscess, that is a grade 1. If at all there is a pelvic abscess, there is a grade 2. In the grade 3, there is a purulent peritonitis, and the grade 4 there is a feculent peritonitis. Okay, so these are the grades of your diverticulitis which you need to understand. Important, at least the name you should remember. You should actually remember the classification as well. It's important. So Hinch's classification: diverticulitis, pericolic abscess, pelvic abscess, purulent peritonitis, feculent peritonitis. Understood? Now, complications. It can lead to bleeding. So diverticulosis, it leads to the bleeding. Okay, diverticulitis, it will lead to whatever the infection and the peritonitis and all those particular stuff. Very, very important. It can lead to the fistula formation. How fistula formation? It can lead to the colovesical fistula. That is one of the most common complication of diverticulitis. Okay, so what happens is that because of the inflammation, that particular intestine gets adhered to the kind of like wall of the bladder, and once the healing process takes place, there is a fistulous communication between the bladder and the wall of the colon. So that is what is a that is how the colovesical fistula is getting formed in the diverticulitis. May lead to the lower kind of GI bleeding. Chance of the bleeding are more in the right side as compared to the left side. That's fine. So even though the site of the diverticulosis is more on the left side, sigmoid colon, but if at all the diverticulosis happens on the right side, the chance of bleeding is a bit more. Understood? And what about the treatment? Treatment will depend on the stage, whether it is a stage 1 Hinch's or it is a grade 4 Hinch's. It will basically vary, obviously. And the condition of the patient, whether the patient is kind of young, active, healthy, good performance status, you can go ahead and operate. If at all the patient is very, very ill and will not be able to sustain the surgery, then you can go ahead with a conservative management or something like that. Okay, I hope you have understood this point. So it will depend on various things. Let's not get into it. Now, what is this? Again, a very, very important image, guys. Can you please tell me on the comment box what exactly is this particular image trying to show you? So this is what is your sigmoid volvulus. Okay, so this is what is the sigmoid volvulus. What you're basically seeing over here, this is a coffee bean sign. Okay, so this is a coffee bean sign which you're basically seeing over here, and this is what is the sigmoid volvulus. Okay, so what happens is that you have a sigmoid colon, which if at all, let's say there is a chronic constipation or due to some reason the stool has not been passed, something like that. Okay, so colon is basically over distended, or maybe the mesentery of the colon is basically a bit longer, which rather than usual, it is a bit more longer than usual. So what can happen? This overloaded colon can basically rotate on its own axis, and then the patients might land up into sigmoid volvulus. Are you understanding my point? So the sigmoid rotates on its own axis. That is how the sigmoid volvulus is getting formed. When we talk about the clinical features of that, okay, so the signs of the intestinal, so the patient is going to present exactly like intestinal obstruction. So signs of the intestinal obstruction, that is what is going to be seen in the sigmoid volvulus. Predisposing factor, as I told you, chronic constipation or the broad mesentery of the sigmoid, which can be from the birth, that's fine. X-ray will show a coffee bean appearance, or yeah, it is also called as an inner bent tube sign. So that is something which you need to understand over here. Very, very important image can be asked to you: inner bent tube sign or a coffee bean appearance, sigmoid volvulus. How do you kind of manage it? You can try to reduce it with the air enema, or you can pass a flatus tube. That is what you can kind of do that. Okay, no. So this particular slide is not over here. Okay, so this is basically the management of the intussusception, guys. So please, the slides have been kind of a bit kind of pushed kind of further. We have already discussed this. Okay, so air enema, and if at all the peritonitis is present, you go ahead with the surgery. This we have already discussed in the intussusception. For the sigmoid volvulus, how do you kind of do that? So sigmoidoscopic derotation can be tried. You can also try something which is putting a flatus tube in order to remove the flatus, or a sigmoidoscopic derotation can be tried, and if not, then you go ahead and do the surgery of that. Okay, I hope you have understood this particular point. Okay, right. Now, let's come towards the colonic cancer. Okay, so this is one of the last topics of a GIT. After like completing this particular topic, so we'll be talking about FAP syndrome, HNPC syndrome, colon cancer, and after that, we will take a short break of around 10 minutes. Okay, so just stay with me. Okay, so FAP syndrome. What is the FAP syndrome? That is a familial adenomatous polyposis. A very, very extremely important topic for you guys. So please pay attention over here. So here, the defect is in the APC gene, adenomatous polyposis colon APC gene, which is basically present on chromosome 5q21. Okay, so what happens is that if at all there is a FAP, like if at all there is an APC gene mutation, what happens? The patients are going to develop adenomatous polyps. So there are different types of polyps: adenomatous polyps, villus polyps, juvenile polyps, all those particular stuff. Over here, they are going to have an adenomatous polyps, which tend to be more pre-malignant, and the polyps, they start by the age of 15 years, and by the age of 40 years, most of these particular patients are going to have a polyps. 100% of these particular patients are going to have polyps in their intestine. Now, it basically constitutes to 1% of all the colorectal malignancies. What does it mean? It means that if at all you have 100 patients with the colon cancer, out of the 100 patients, one patient will be a patient of this familial adenomatous polyposis. Okay, right. So it is only 1% of all the colon cancers. But if at all, let's say somebody has this familial adenomatous polyposis or APC gene mutation, there is nearly 100% chance that that particular patient is going to have a colon cancer. 95 to 96% chance that the patient is going to have a colon cancer. So in these particular patients, you advise a prophylactic surgery, because if at all the patient has the APC gene mutation, he or she is definitely going to land up into a kind of malignancy, and at that point of time, maybe it is not going to be manageable, and that is why you basically offer these particular patients a total proctocolectomy with IPAA. What is this IPAA? Ileal pouch anal anastomosis. Okay, so you remove the entire colon, you remove the entire colon, sigmoid colon, rectum, kind of rectum also you remove. What you do is you create a pouch of the ileum, and then you anastomose it to the anal canal. So ileal pouch anal anastomosis, IPAA, that is what you basically perform over here. Okay, now the another terminology is HNPCC. What is this HNPCC? This is hereditary non-polyposis colon cancer. So this is basically because of the mismatch repair gene mutation. It constitutes the 5% of all the colorectal cancers. In other words, if at all you have 100 patients with the colon cancer, out of 100, 5 patients might be having this HNPCC gene mutation. Are you understanding my point? But if at all, let's say I have this particular HNPCC kind of syndrome, the chances that I will land up into a colonic malignancy is only 80%. So in these particular patients, prophylactic surgery is not done. Are you understanding my point? In the FAP syndrome, prophylactic surgery is advised by you. But in HNPCC syndrome, prophylactic surgery is not advised. Are you understanding? Very, very important. So how do you manage this? Okay, so let's kind of first talk about the basic things, then we'll talk about the management of HNPCC. So there are two criteria. One is modified Amsterdam criteria. This is basically used to diagnose the HNPCC, and there is a revised Bethesda classification that detects the mismatch instability response to the chemotherapy. Forget about it. Not very important. Just remember these particular names. Amsterdam criteria, Bethesda criteria is for the HNPCC. Okay, that's fine. This is important. Lynch syndrome. So HNPCC is nothing. It is basically a Lynch syndrome. So you have Lynch 1 and the Lynch 2. In the Lynch 1, there is only risk of the colorectal cancers. In the Lynch 2, along with the colorectal cancer, there can also be a risk of your endometrial and the ovarian cancer as well. Are you understanding my point? So there is a Lynch 1 and the Lynch 2. In the Lynch 1, only colorectal cancer. In the Lynch 2, colorectal. Along with that, there is an extra intestinal cancers as well, endometrial and ovarian. Okay, now talking about the surveillance. Okay, so how do you manage a patient of a HNPCC? So you have to put these particular patients on surveillance. What do you understand by the surveillance? That you have to perform a colonoscopy in them repeatedly. Why? Because you are basically trying to see whether there is any development of the polyp or not. Because if at all I have a HNPCC gene mutation, only 80% is the chance that I might land up into a colorectal cancer, right? So you try to detect a polyp. If at all polyp is detected, you perform a polypectomy. And after you perform the polypectomy, you send it for the histopathological examination. The pathologist tells us the Haggett's grade. Do not confuse, okay? So that was the Hinchey's classification for the diverticulitis. Over here, what you have is a Haggett staging. So if at all there is Haggett's 4, it means that the malignancy has kind of started to develop. And if at all there is a Haggett's 4, then you basically perform a total colectomy with ileorectal anastomosis. In the FAP syndrome, we performed a ileal pouch anal anastomosis, IPAA. Over here, you perform a total colectomy with the ileorectal anastomosis. So even after you do the surgery, this particular proctoscopy is still kind of needed because the rectal mucosa can still develop the cancer. Are you understanding my point? So this is how you manage the patients of an HNPCC. Now just a couple of words about the colon cancer. So most common site of the colon cancer is the sigmoid. That's fine. Risk factors are basic, like the smoking, all those particular things. Adenomatous polyps is something which is important. And if at all there is a sessile polyp. So polyps can be of two types. They can be either pedunculated or they can be sessile. So the sessile polyp, the risk of the malignancy is much more as compared to that of the pedunculated polyps. Okay. Now coming to how do we screen the population? So there are only few cancers in which the universal screening is kind of needed. So yes, colon cancer is one of them. So you basically screen with the fecal occult blood and flexible sigmoidoscopy. So this is how you basically screen the cancer, and colonoscopy every 10 years. So this basically starts after 50 years of age. So colonoscopy every 10 years. This is ideally which should be done. We usually don't do it, but yeah, it is ideally which should be done. This particular slide is a bit important in the colon cancer. So there are, like, the colon cancer can occur either from the right side or the left side. Okay. So if at all the source of the origin of the colon cancer is on the right side, okay, it means that so they tend to be more fungating, the cancer can be either fungating, right? So it can kind of come out of that particular lumen, or it can be ulcerative. Okay. So the right side colon cancers, they tend to be a bit more fungating. The chance of the bleeding is more on the right side colon cancer, and yeah, because there is a bleeding, there's a risk of anemia. Okay. And that is why you're basically looking for that like occult blood, right, in the fecal matter, right? So right side, fungating kind of growth, bleeding can happen, and there can be anemia. That's fine. What about the left side? On the left side, it is more of an ulceroproliferative growth. It is a more of an ulceroproliferative growth, and yeah, so bowel kind of disturbance can happen. So if at all there is an ulceroproliferative growth, there can be stricture formation, and because of the stricture formation, the left side colon cancers, they usually present as an obstruction. So the bottom line is that on the right side, because of the bleeding, the patients can present to you as anemia, and on the left side, the patients usually present to you as an obstruction. Investigation of choice is colonoscopy with biopsy, obviously no doubt about it. The staging is by the CECT. And when we talk about the management, so on the the right side, you cannot do anything. You have to perform a total colectomy. On the left side, you can perform a segmental resection of that. Management is a bit complex. Let's not get into it, but yeah, please do remember these basic stuff. So I've tried to cover most of the important topics of your GIT, guys. I hope you gained something out of it. We will just take a short break of around, let's say, 10 to 15 minutes. Let's meet back at, let's say, 6:20, and then we will be covering about the hepatobiliary system and the urology. That's what we are going to cover. Okay, now I just want to interact with you a couple of minutes, guys. Is this particular session being helpful to you, or do you want me to change the pattern in the next 2 words or something? We will be starting at, let's start at 6:30, and then we will wind up by, let's say, 8:30. Will that be okay with you guys? Right? Okay. So, yeah, please interact with me. आपका fan सोनू शर्मा, वेंकट और सोनू शर्मा, yeah, that's fine. Lakshmi Devi, any of you guys are still here? Please tell me if at all I need to kind of change the pattern or it's fine. So in the post-break session, we are going to cover the hepatobiliary system and we are going to cover the urology. So that's what we are going to cover. So yeah, I think there's a bit of lag, but I'm waiting for your responses, guys. So please put it on the comment box. Right? So all okay? Okay. So it's fine, sir. It's good. Okay. That's great. Okay. If you have any kind of suggestions, just put it on the comment box and let's meet back at, let's say, 6:30, 20 minutes break. You have your tea, whatever. I'll also have my tea and we'll meet back after at 6:30 and then we'll continue till around 8:30. I'll wrap it up. In the post-break session, what we are going to cover is the hepatobiliary system and the urology. That's what we are going to cover. Okay? Yep. Thank you, guys. So, hi guys. Yeah. So, we will be starting with the session in some time. Okay. But I just wish to interact with you. Okay. Okay. Um, well, yeah. So, guys, what I wish to convey to you is very, very important for your tomorrow's exam. So, I guess you guys are going to give the exam tomorrow, right? So we'll be starting with the session in a bit. We will be just doing it. But before that, I wish to convey something to you, which is, I think, is much more important than whatever the session which I'm going to conduct. So that is something which is called as you have to deliver what you know. Okay, so this is just a bit of a pep talk. I won't waste a lot of time, but this is something which I feel that it's important for you to hear before you basically go for the exam. And what happens is, I understand, right? It's life, right? I mean, nobody's perfect. I'm not perfect. I don't think so. Anybody in this world is perfect. So I'm pretty sure that you would have done some of the other things which were not so accurate in your studies. Maybe you wasted some amount of time, or maybe things did not go as you planned, or maybe some personal or professional, some or the issue happened, or something like that. Many things happen, right? It's at the end of the day, it's a life. So let's assume that you okay. So here, obviously, marks. I don't think so. That matters a lot. Yes, you have to pass. You don't have to pass. So let's kind of take in this particular manner. If at all your preparation is very low, and let's say if at all some or the other reason has happened, and maybe you are not, let's say you are at the border whether you will be passing or not, or something like that. Maybe a couple of questions up and down you might pass, or you might not pass, or something like that. What I'm trying to convey over here is that if you deserve to pass, you have to make sure that you pass. And how are you going to make sure that you pass? By delivering what you actually whatever know, right? Now, how this is going to happen? This is going to happen when you keep your cool. Keep your cool during the exam. Now, I'm pretty sure that each one of you would have said at least a couple of times, and I'm sure that you would have heard everybody in this world, whoever has given any competitive exam, after they come out of it, everybody says that, you know what, damn, I did a silly mistake, right? So each one of you have heard about these people, right? And what about the people who get the highest marks? So let's say who come first in the NEP or something like that. Okay, so do they commit a silly mistake? The answer is yes. Even they do commit a silly mistakes, but their silly mistakes are very limited, like 3 to 4 or 5 or something like that. That is human, right? I mean, every human will commit some of the other silly mistake. But if at all you end up committing, let's say 20, 25, 30 silly mistakes, that is what is going to change your entire game. So if you don't know a question and you're not able to answer it, obviously it is justifiable, it is understandable. But if you know something and then you end up marking it wrong, that is absolutely not justifiable. That is absolutely not acceptable. It is actually a crime. You're not being just to yourself, and that is absolutely not done. So just try to make sure that you deliver what you know. What you don't know, you don't know. That's fine. Obviously, you're not going to do it right. Maybe by luck, you might kind of mark some correct option or something like that. But if you know something, do not skip things. Do not skip the except towards the last of the question. Do not um, let your knee-jerk response set in so that you end up marking a wrong option or something like that. Don't let your mind getting fatigued and all those particular stuff. Now, how you can actually do that? By keeping cool, by not over judging yourself, by not over criticizing yourself. It's fine. Whatever has happened, that's in the past. Today's a new day, today's a new time. Let's go to the exam with a positive attitude and do what you basically know. Just deliver that. That is one thing. Another thing is, uh, you never know, right, what questions are going to come. So let's say the first 4 questions are of anatomy, biochem, and all XYZ, which are very, very bouncers and you do not understand at all. And let's say the fifth question is of duodenal atresia. Okay, fifth question is simple, right? But when you're solving that particular question, don't think that, you know what, last 4 questions I was not able to answer anything. Okay, don't do that. Because what you need to understand is that yeah, there's an analogy which basically Harsha Bogli also says, and many people kind of say the crux of that is take one day at a time, or let's say take one question at a time, or let's say take one ball at a time. Harsha Bogli says that, you know, it's not about the number of fours or number of like the entire match or something like that. every ball is a new game. So in the similar manner, every question is a new exam. In other words, you have to give your 100% to every question. And if you are able to give your 100% to every question, you will end up giving your 100% to the entire paper. It really doesn't matter, like last 4 questions, you were not able to kind of solve anything, everything went wrong. It's fine. That's like the different. This is a new question, give your 100% to that. That is something which is very, very important. These two things, just try to keep in your mind, might help you in reducing the number of silly mistakes to a bit lesser amount. You will never be able to completely eliminate the silly mistakes. You might be able to reduce the silly mistakes to a lower amount. Okay, so that's all you. I have to kind of share with you guys. So where's the patho video? That was the first video. So if you kind of rewind everything to the start, the patho video will be there. Then was the medicine video. Then was the OBG one. This is the surgery video. Okay, guys. So shall we start? Everybody's okay with this? Okay, let's start. Okay, so now what we are going to do, we are going to read about the hepatobiliary system. Yeah, that's what we are going to cover. Okay, so liver. We will be starting with liver, and in the liver also there are three very, very important topics. The first one is the kind of pyogenic liver abscess, then the amoebic liver abscess, and the hydrate disease. These three are very, very important topics. Okay, so let's talk about the pyogenic liver abscess. What does a pyogenic means? Pyogenic means pus. Pyogenic liver abscess basically means that there is a pus in the liver. That is pyogenic liver abscess. Understood? Understandable? Okay, so pyogenic liver abscess, there is a pus in the liver. Pyogenic liver abscess. Now, a very, very important question which they ask is, what is the most common route of spread? It has been asked a couple of times. It can be asked tomorrow as well. So please do remember, the most common way of spread of the or most common cause of the pyogenic liver abscess is the ascending infection from the biliary tract. So what happens? The stone is basically obstructing the common bile duct or something like that. There is an ascending cholangitis, and that ascending cholangitis, the infection basically goes up to the liver, and you end up having a pyogenic liver abscess. So ascending infection from the biliary tree, that is the most common kind of thing. You might end up marking blood spread. No, that's not the correct answer. Ascending infection is the correct answer. Now, if at all the patient is having a pyogenic liver abscess, how will the patient present to you? So patient obviously is going to have all these particular symptoms: fever and chills, pain in the right hypochondrium, all those particular things are going to happen. Obstructive jaundice. Now, can you please tell me why obstructive jaundice? We just discussed that the stone is going to come, obstruct the common bile duct. Because of that ascending cholangitis, and because of that the pyogenic liver abscess might form. Anorexia, fatigue, yeah, everybody has it. That's fine, not a very big deal. Now, when you talk about the labs, like the laboratory investigations, here you might have an raised alkaline ALP. Okay, so this raised ALP is again an indirect indicator that, you know what, there's some kind of an obstruction to the biliary tree. Okay, so obstructive jaundice, raised ALP, these are the things which might kind of prompt you towards pyogenic liver abscess. And yeah, that's what you need to understand over here. What about the kind of diagnosis? How do you kind of diagnose it? So on the ultrasound, what you're going to see is basically a space occupying lesion, and yeah, it will help you a bit in order to diagnose. See, amoebic liver abscess, pyogenic liver abscess, both are going to show you as a space occupying lesion inside the liver. Unless you kind of puncture it or you try to kind of look at it microbiologically, you will not be able to tell whether it is a pyogenic or a amoebic liver abscess, but that's fine. CT scan can definitely help, and aspiration and culture is the most diagnostic thing, because CT scan and ultrasound are just going to tell you that there is some amount of collection inside the liver, but they will not be able to accurately diagnose it. So investigation of choices, needle aspiration and culture of that pyogenic liver abscess. And what about the management? Pus anywhere in the body, you have to kind of drain it. So percutaneous drainage by a pigtail or a Foley, like a pigtail catheter or a Malacot catheter, and along with that you have to give an antibiotic. Usually use a pigtail catheter in order to drain the pyogenic liver abscess. And the most common organism, this is again a very, very important MCQ, the most common organism responsible for the pyogenic liver abscess is the E. coli, but due to some reasons, if at all they mention an Asian country, then the answer is Klebsiella. Do you understand this particular point, guys? Okay, so liver, pyogenic liver abscess, a very, very small topic, but an important topic. I hope you have understood this particular point. Now, before I move on to the amoebic liver abscess, medicine video was from 12 to 2. So after the patho video, you would find the medicine video. Okay, Aapka fine. I hope you got that. Okay, now coming and having a look at the amoebic liver abscess. What about this amoebic liver abscess, guys? Okay, so amoebic liver abscess is basically Entamoeba histolytica. So the causative organism for the amoebic liver abscess is Entamoeba histolytica. Pyogenic liver abscess, what was the most common organism? E. coli. ascending route of infection. What about this amoebic liver abscess? It is a fecal-oral route of infection. That means that some contamination has happened in the food, and that has basically led to this amoebic liver abscess. So there is a quadrinucleate cyst. That is basically an infective stage when it basically reaches. Okay, so they might ask you that. What is an infective stage? Quadrinucleate cyst. Once it enters into the inside of a kind of intestine, it gives rise to the trophozoites. These trophozoites cause something which is called as a flask-shaped ulcers. Okay, what they form is a flask-shaped ulcers in the ascending colon. The location is also important. They basically form a flask-shaped ulcers in the ascending colon. Very, very important. Do not forget this. Okay, right. Now, after that, what happens that from this, the trophozoites can enter into the bloodstream and then they can go into the liver. And inside the liver, they lead to an enzymatic degeneration of the liver parenchyma, which leads to the abscess. And that abscess basically looks like an anchovy sauce pus. So all these particular things which I'm highlighting, these are the MCQs, guys. Anchovy sauce pus, flask-shaped ulcers in the ascending colon, quadrinucleate cyst, trophozoites, all those particular things, very, very important MCQs. Do not forget about these. Clinical features. Again, the same thing. Patient is going to have abdominal pain, pain in the right hypochondrium, all those particular stuff. It is going to happen. What about the fever and chills? No. If at all there is a secondary bacterial infection, then yes, the patients are going to have the fever and chills. But per se, amoebic liver abscess is not the cause of the fever and chills and all those particular stuff. What about the raised ALP? May occur, but very, very less. I mean, it is much more common in the pyogenic liver abscess. In other words, if at all in the question the raised ALP is given, obstructive jaundice is given, they want you to mark it as a amoebic liver abscess. Pyogenic liver abscess. I'm really sorry. They want you to mark it as a pyogenic liver abscess. Now, what did I tell you? What is an investigation of choice for the pyogenic liver abscess? Can you please tell me? I hope you remember that it was a aspiration and culture of that particular, whatever the sample, right? What about the amoebic liver abscess? What is the management, investigation of choice for the amoebic liver abscess? The investigation of choice for the amoebic liver abscess is serology. You have to look for the antibodies. Okay, so serology is the investigation of choice for the amoebic liver abscess. You aspirate the amoebic liver abscess only in few conditions. We will talk about when do you do that. But yeah, usually you do not end up aspirating the amoebic liver abscess. It is managed medically. So if at all there is an entamoeba infection to you, amoebiasis, what is the treatment for amoebiasis? It is metronidazole, right? So that is what you basically give over here as well. Metronidazole is the treatment drug of choice. You give 750 milligrams for 10 to 14 days, 3 times a day. That's what you basically give. And the metronidazole, that is going to help you in tackling the amoebic liver abscess. But what about the recurrence? The recurrence might still happen because the intestinal trophozoites are still there. So in order to prevent the recurrence, what you need is the luminal agents, those agents which will be able to kill the trophozoites inside the lumen. So they are this parabomycin, hydroquinolone, loxamide, fumarate. These are the luminal agents which you basically use in order to kill the the trophozoites inside the intestine. And what are the complications? So rupture into the peritoneum. So if you talk about the complication of the amoebic liver abscess or the pyogenic liver abscess, they basically rupture usually into the peritoneum. So sometimes they give you a kind of misleading options. They might tell you that the rupture is either into the diaphragm, like into the thoracic cavity, or the peritoneal cavity. The rupture into the peritoneal cavity is more common as compared to that of the thoracic cavity. I hope you have understood this particular point, guys. Okay, so I'll quickly revise these two because these two are very, very important topic. Okay, pyogenic liver abscess, amoebic liver abscess. Pyogenic liver abscess, ascending route of infection, fever, chills, all those particular stuff. Raised ALP, obstructive jaundice, and diagnosis is by the aspiration and culture. Treatment is by the percutaneous drainage and giving the antibiotics. And most common organism is the E. coli. The second most common organism is like the Klebsiella, if at all you are talking about the Asian countries. What about the amoebic liver abscess? It is entamoeba histolytica, quadrinucleate cyst entering into the colon, trophozoites leading to the flask-shaped ulcers in the ascending colon, trophozoites reaching to the liver, causing enzymatic degeneration, leading to the formation of an amoebic liver abscess, which looks as an anchovy sauce pus. Investigation of choice. Okay, so fever, chills is not going to happen. Pain might happen because of the distension of the capsule. And the investigation of choice is serology. It is not the aspiration and culture. And the treatment is metronidazole. You can also give the luminal agents, as we just saw, we have to give in order to prevent the recurrence. And the rupture can happen in both pyogenic as well as the amoebic, into the peritoneal cavity. Now coming to the hydrated cyst. Now you obviously would have heard about these hydrated cysts in your microbiology. So this can also affect the liver. So here the definitive host is the dog and the intermediate host is the sheep. That's fine. Man is an accidental host or a dead end host. That's fine. Now again the spread is by the fecal route, and here we have a hexacanth release into the intestine. So there was a trophozoite. Over here we have a hexacanth larva which is basically released into the intestine. Now the most common organ involved is the liver. With the hydrated cyst, the most common organ involved. That's fine. What about the clinical picture? It is usually asymptomatic. Why asymptomatic? Why there is no pain? Because the increase in the size of the hydrated cyst is very, very slow. So usually there is, like in the history, they will give you the farmer who is basically dealing with the sheeps and all those particular stuff, and yeah, that is what they might give you in your kind of clinical scenario. The patient is asymptomatic. The patient is coming to you with a lump in the right hypochondrium. Why? Because there is a gradual distension of the capsule, so no pain. That's fine. Very, very important. Actually, the MCQ which is they are going to ask you is, what is the investigation of choice? The investigation of choice is ELISA. In the ELISA, what you're basically going to see is ARC5. Okay, ARC5. So this type of arc which is going to come in the ELISA, that is what is a investigation of choice for your serology. So obviously it is not like this type of arc, but there is one kind of a arc which comes, which is called as ARC5, and that is basically diagnostic for your hydrated cyst of the liver. Okay, that's fine. Now what you need to understand over here, that there is Cassoni test as well, but it is obviously not done in today's time because the sensitivity is very poor, 70% sensitivity, and can lead to the anaphylactic reaction. I'm pretty sure what is a Cassoni test. I hope you know that. So you basically take this particular cyst fluid, you take it because that is immunogenic. You basically put it in the intradermally, and that basically causes the flare. But it is not kind of advisable in today's time because it might go deeper, it might lead to the systemic kind of anaphylaxis, and that is why it is not used in today's time. Now, very, very important, how do you manage the patients of hydrated cyst? So that is with the help of PAIR. PAIR technique is used to manage hydrated cyst. Now, what is this PAIR? PAIR is puncture, aspiration of the content, injection of the scolicidal agent, and re-aspiration. So you kind of puncture that particular cyst, you aspirate whatever the content is there. Okay, and then what you do, you inject. What do you inject? You inject the scolicidal agent. What is the scolicidal agent? Because inside the hydrated cyst, what are you going to find? You're going to find this daughter cyst and the scolex cyst. They are going to be present over here. So you inject the scolicidal agent and then you again re-aspirate that particular content. Now this is PAIR technique. Definitely they might ask you what are the scolicidal agents which can be used. So the scolicidal agents which can be used are, here this hypertonic saline, very, very important. Hypertonic saline, 20% hypertonic saline. Then citramide, absolute alcohol, all those particular things are 10% povidone, iodine, all these particular things are there. But the one which we commonly use is a hypertonic saline. Okay, I hope you're able to understand this particular point. Now, the contraindications of the PAIR, like when will you not perform any PAIR? So let's say if at all there is an inaccessible cyst. It means that the cyst is very, very deep seated, or there is a periphery located cyst. Why periphery located cyst? Because if you puncture it and you aspirate it and then you again inject it and all those particular stuff, that particular cyst can rupture into the peritoneal cavity. And as I told you, the scolicidal fluid, like whatever the cyst fluid, that is immunogenic. So it can lead to an anaphylactic reaction, and the patient can, it can be life-threatening to the patient. So periphery located cyst also you avoid to do a PAIR kind of procedure. Multiloculated cyst, because even if you puncture one cyst, the other cyst is still there. So how many punctures you're going to make? So it is not kind of feasible. Cystobiliary communication. If at all the cyst is communicating with the bile duct, you are putting a scolicidal agent, that scolicidal agent will enter into the common bile duct, it will go to the liver, it will lead to ascending cholangitis. Not kind of good. Cyst in the lungs and the brain. Why? Because there is no pericyst. We will talk about this pericyst, because if at all there is no pericyst, if you puncture, if you put scolicidal agent, the whole kind of this hydrated fluid is going to come out. And calcified cyst, because it is not an active cyst. Even if you leave a calcified cyst, it is not going to cause any problem. So important, guys. Okay, so don't try to mug it up. If you understand these, I know it's not time to understand, tomorrow you have an exam, but these are the contraindications for PAIR. Okay, I hope you have understood. I hope it helped you revise that. Now, most common complication. What was the most common complication of your amoebic liver abscess and the pyogenic liver abscess? It was rupture into the peritoneal cavity. The most common complication of this hydrated cyst is rupture into the biliary tree. It can lead to obstructive jaundice and all those particular stuff. ERCP can be done and forget about it. That's a bit more detail. Now this is, obviously you would have seen this particular image in your microbiology and all. So we have 3 layers of that. One, we have a pericyst, which is basically a cellular layer that is basically from the fibrotic reaction and all those particular stuff. This is an ectocyst that is also an acellular layer, that is an hyaline layer. And then we have an endocyst. Endocyst is something which is a cellular layer. It basically leads to the formation of a daughter cyst. So that is how the structure of the hydrated cyst is there. 3 layers are there. Okay, we know that, right? So pericyst is, it's not present in the brain and the lungs, and that is why per is contraindicated in the brain and the lungs. Okay, now what is this? Very, very important image. Very, very important image. So this is what is a water lily sign. Okay, water lily sign. Water lily sign when this endocyst is basically separating from the ectocyst. Okay, so when the endocyst getting separates from the ectocyst, it basically forms an undulating membrane, and that is what is a water lily sign. Now there is another sign which is called as a drooping water lily sign. These two are not the same. So can anybody tell me in the comment box what is a drooping water lily sign? I will move on. It is nothing related to hepatobiliary system. Just put it on the comment box. What is the drooping water lily sign? Okay, but I hope you have understood about the hydrated cyst. It's again a very, very important topic. These 3 topics are very important. I'm pretty sure at least one MCQ will going to come tomorrow out of this. Okay, do remember me at that point of time. Now coming to the liver tumors, guys. Okay, so liver tumors, they can be the benign or they can be malignant. In the benign variety, what is the most common benign tumor of the kind of liver? It is hemangioma. Okay, so the most common benign tumor of the liver is hemangioma. Then we have a focal nodular hyperplasia. Then we have a hepatic adenoma. Again, these 3 are very, very important. MCQs, clinical based scenarios can be asked on the focal nodular hyperplasia and the hepatic adenoma. We will be talking about it. Then in the malignant, we have the secondaries, metastasis, that is fine. Then we have a hepatocellular carcinoma and the hepatoblastoma. Hepatoblastoma is more common in the children. That's fine. That's okay. But hemangioma, focal nodular hyperplasia, hepatic adenoma, these 3 we definitely have to look into detail. Okay. Now, what is hemangioma? It is basically the malformation of the blood vessels. That's fine. But if at all that happens inside the liver, that is what is your what you call it as a hemangioma. Okay. So hemangioma, most common. That's fine. Now. Okay, it's a benign condition. It has no scope of malignancy and it is usually asymptomatic. So usually hemangioma is there. That's fine. Not that big a deal. You do a CT scan or an MRI in order to diagnose this. Okay, so that is how you basically do that. You do a CT scan or an MRI, you diagnose it. This is an image. Okay, what are you basically seeing in this particular image? Can anybody tell me? So this is what is a characteristic light bulb sign. So this light bulb sign is something which is basically present on the MRI. MRI in the patients of hemangioma. Okay, so yeah, light bulb size is basically present in the hemangioma on the MRI. Very, very important. Characteristic image can be asked to you. Very, very important, guys. Okay, do not forget this. Okay, now, yeah, that is why CT scan, MRI, that is what is the investigation of choice. What about the biopsy, guys? Will you do a biopsy in the hemangioma? Obviously, no, right? If you do a biopsy, that is going to cause a catastrophic bleeding. So please understand that FNAC and biopsy are contraindicated in the patients of hemangioma. Now, what about the kind of management? So management of the hemangioma is enucleation. Okay, enucleation, no liver resection, nothing. It is enucleation of the hemangioma. And what you basically do is Kasabach-Merritt syndrome. What is a Kasabach-Merritt syndrome? So if at all there is a very giant hemangioma, so this is basically present in giant hemangioma. Okay, so if at all you have a giant hemangioma, what is going to happen? It is going to lead to consumptive coagulopathy. Are you understanding my point? So this is going to lead to a consumptive coagulopathy. So that is what is a Kasabach-Merritt syndrome. Just remember, Kasabach-Merritt syndrome is something which is present in the giant hemangioma. That's fine. Let's not go into the details of it. There is an explanation, but let's not go. It's not that relevant. Out of the hemangioma, enucleation treatment of choice, very important. This light bulb appearance on an MRI, absolutely important. Most common benign tumor of the liver, absolutely important. Biopsy, FNAC, absolutely contraindicated. These 4 points are very, very important. What about the focal nodular hyperplasia? So this is the second kind of, okay, before I talk about the focal nodular hyperplasia, yes, Alpha Acharya, you're right, it is duplication of ureter. We will talk about it. So upper moiety when it becomes non-functioning, lower moiety when it becomes non-functioning, upper moiety becomes non-functioning and then pushes the lower moiety down, and that basically leads to the drooping motility sign. We'll talk about that in urology, but yes, good, you answered it correctly. Now let's move on to the focal nodal hyperplasia. What about this focal nodal hyperplasia? What you need to understand, it is the second most common benign kind of condition of the liver. That's fine. It is associated with the oral contraceptive pill. So yes, I mean, in the clinical scenario, they will give you a young female who is basically taking a let's say, oral contraceptive pill, and the patient has come to you with, let's say, some kind of discomfort. You got an ultrasound done. An ultrasound is basically showing a lesion inside the liver. So yeah, that is how the clinical scenario can be kind of placed. So yeah, benign, no malignant potential, absolutely no malignant potential in the focal nodal hyperplasia. But there is another thing which is called as like adenoma. We will talk about that. That has the malignant potential. So that is a basic difference. Both are associated with the oral contraceptive pill. So that is why you need to make a difference out of it. In the contrast enhanced CT scan, you find a central stellate scar, a very, very important MCQ, guys. Okay, so what do you basically find over here? It is a central stellate scar. Okay, central stellate scar is basically seen on the contrast enhanced CT scan in these particular patients. On the angiography, what you basically find is a spoke wheel appearance or a cart wheel appearance. So these are the two characteristic imaging findings which you need to understand. So yeah, and this central stellate scar, it also lights up in the sulfur colloid scan. Okay, so all these are the important MCQs out of focal nodal hyperplasia. Sulfur colloid scan pe, this particular central stellate scar, it basically lights up. Then you have a spoke wheel appearance and cartwheel appearance on the kind of angiography. And what about the treatment of focal nodal hyperplasia? That is just simple observation. Okay, now one thing if you want to know, when you take the biopsy of this focal nodal hyperplasia, the hepatic architecture is maintained. So that is the basic thing about the focal nodal hyperplasia. Now coming to the hepatic adenoma. Okay, so this is again basically present in the females who are basically having the oral contraceptive pill use. Okay, so they are basically present in, this is basically same between the focal nodal hyperplasia and the hepatic adenoma. Very, very important clinical scenario for the hepatic adenoma. So a young female, 35-40 years of age, working in her office or something like that, suddenly she collapses, and once she collapses, she is basically brought to the hospital. The medical records show that she's on oral contraceptive pills, and the ultrasound, or let's say the CT scan which was done, let's say 1 month back, 2 months back, 3 months back, shows that there is a hepatic kind of a lesion. Okay, now the answer over here is obviously hepatic adenoma. That's why I'm trying to tell you. But why this is not a focal nodal hyperplasia? Because very, very important. That is why you have to resect this kind of hepatic adenoma. It has a risk of a spontaneous rupture. So what happens is the hepatic adenoma can spontaneously rupture. This happens in around 30 to 50% of the patients, and this can lead to a catastrophic bleeding. And that is why the patient collapsed, right? In your clinical scenario, very, very important clinical scenario. At the same time, as we said that follicular nodal hyperplasia, it had zero risk of malignancy. But this hepatic adenoma, it has a risk of malignancy. Okay, it does have a risk of malignancy. And hepatic kind of architecture is not maintained in the hepatic adenoma. But in the follicular nodal hyperplasia, the hepatic architecture was maintained. So these are the three differences between the follicular nodal hyperplasia and the hepatic adenoma. Okay, so in the follicular nodal hyperplasia, I told you that we will go ahead with the observation. But here in the hepatic adenoma, we have to go ahead with an excision. We have to kind of resect that out. Are you understanding my point? Okay. Now, before I move on, this alpha acharya, enucleation basically means that, let's say if at all this is one particular lesion. Okay, so let's say if at all there is one particular lesion, what I'm doing, if I want to do a surgery, I can do something which is called as a wide local excision. That means that I can resect with the margin. Okay, so that is what is called the wide local excision, which we usually do in the malignant tumors or something like that, where we suspect a kind of malignancy. In the enucleation, what we do is we just kind of resect that particular kind of a tumor. We do not take any particular margin. Okay, so that is what is called as an enucleation. We are just enucleating it out of that particular parenchyma. Are you understanding my point? So that is what the enucleation means. Okay. Okay. So that is the important topics about the liver. Hepatocellular carcinoma, well, it is important, but it is not that important. So because of the lack of time, I'm just skipping that. But the topics which we have covered, they are very, very important. At least expect a couple of MCQs tomorrow out of the liver. Okay. Now coming to this biliary system, right? So we will talk about the biliary system now. So the basic, sometimes the confusion is between the cystic triangle and the cholecystohepatic triangle. What is a cystic triangle? Cystic triangle, the boundaries of the cystic triangle are common bile duct, gallbladder, and the cystic artery. What is this? This is what is a cystic artery. So these are the boundaries of a cystic triangle. And then there is something which is called as a cholecystohepatic triangle. There again, like the common bile duct is fine, gallbladder is fine, but it is formed by the base of the liver. So this is what is a cholecystohepatic triangle. Okay. Now what we are going to cover like in this is, okay, so what happens is that in the gallbladder, what can happen? In the gallbladder, you can have a gallstone, and then there can be an acute cholecystitis. There can be choledocholithiasis. Okay, we will talk about all these particular terms. Okay, so if at all there is a stone which is present in the gallbladder, okay, okay, so if at all, let's say there is a gallstone inside the gallbladder, what does it mean? It means that it is a cholelithiasis. Cholelithiasis means that the stone inside the gallbladder. What about the acute cholecystitis? Acute cholecystitis basically means that there's a stone which is obstructing the cystic duct. Okay, the cystic duct, it is basically getting obstructed, and there's an infection of the gallbladder. So that is what is an acute cholecystitis. So if at all the stone is kind of obstructing over here, it will lead to acute cholecystitis. And if at all the stone is present in the common bile duct, that is what is a choledocholithiasis. Okay, so these are the three terminologies: cholelithiasis, acute cholecystitis, choledocholithiasis. Okay, now what is this? Very, very important image. So this is, let's say, one of the most important images which can be shown to you tomorrow. So this is what is a gallstone. What are you basically seeing over here? Seeing over here is, this is a post-acoustic shadow. Okay, so this is what you are basically seeing over here. Posterior acoustic shadowing. That is what you are basically seeing. So clinical features will be colicky pain. Why colicky pain? So whatever the gallstone is there, if at all, it basically comes and it basically obstructs the cystic duct. So the gallbladder will keep on contracting in order to push the bile out, and there's going to be the colicky type of pain. There's going to be the pain, and there's going to be relaxation, and then there's going to be the pain and relaxation. So this cyclic nature of the colicky pain is going to be the presenting feature, along with the dyspepsia and all those particular stuff. Yeah, that's going to be there. What about the diagnosis? Investigation of choices. No CT, no MR, it is ultrasound, guys. Please remember this, okay? For diagnosing the gallbladder stone, the investigation of choice is an ultrasound. This is an image which you have to remember. Posterior acoustic shadowing, very characteristic of gallbladder stone, okay? For the treatment, obviously, you have to remove the gallbladder out. That is a cholecystectomy. That is how you manage the patients of the gallstone, if at all it is kind of symptomatic, or if at all it has an associated polyp along with it or something like that, okay? Right. Now, okay. If I ask you, important, right? If I ask you that if at all there is a stone inside the gallbladder, okay? If at all there is a stone inside the gallbladder, can it lead to the obstructive jaundice? Usually no, right? Obviously, for a stone to lead to the obstructive jaundice, the stone has to come into the common bile duct, right? But if at all the stone is still inside the gallbladder and the patient is developing obstructive jaundice, that is what we refer to as a Mersey syndrome. So usually the stone is impacted either in the cystic duct and there is a lot of inflammation around it, or the stone is basically like in the Hartmann's pouch. So there's something which is called the Hartmann's pouch, and the stone is basically impacting in the Hartmann's pouch, and it is basically pressing on this common bile duct, and that is how kind of the obstructive jaundice usually takes place. Are you understanding my point? So all you need to understand is Mersey syndrome is a condition where the stone is in the gallbladder, but the patient is presenting with obstructive jaundice. That is because the stone is impacted either in the Hartmann's pouch or the cystic duct, and there is a surrounding inflammation and fibrosis a lot. Okay, now coming to this, one of the most important 20 topics, like the top 20 topics for FMG, one of the most important one is this gallstone ileus. A very, very characteristic history which you might have in this particular scenario is that the patient had a long-standing, let's say, gallstone, and now the patient is coming to you with vomiting, and the patient is not able to pass stool, and yeah, the patient is coming to you with the signs and features of your intestinal obstruction. When you investigated this particular patient, you found that there is air inside the gallbladder, and yeah, that's how the kind of scenario would be there. So this is what is a gallstone ileus. Gallstone ileus. What happens over here? If at all there is a large gallstone, over a period of time it can erode through the gallbladder. It can erode through the gallbladder and it can enter into the intestine. Now, once it enters into the intestine, what happens? It basically travels down the intestine. Now, if I ask you, what is the narrowest part of the intestine? The narrowest part of the intestine is just proximal to the ileocecal junction, terminal part of the ileum. So, this particular stone can go and it can obstruct at that terminal part of the ileum, and this can lead to the intestinal obstruction. This leads to the intestinal obstruction. Now here, the one of the most important triads which you basically find is a Wriggler's triad. Now what are the components of the Wriggler's triad? Pneumobilia. Pneumobilia means air inside the gallbladder. What does this pneumobilia means? Air inside the gallbladder. How does it come? So the air is present inside the intestine, right? And if at all the gallstone has eroded into the intestine, the air can enter into the gallbladder. That is one. Radiolucent gallstone. So yes, I mean the radiolucent gallstone you will be finding in the terminal part of the ileum, and there is a small bowel obstruction because the intestine has been obstructed at the terminal part of the ileum. Are you understanding my point? So this is what is a gallstone ileus, a very, very characteristic and can be asked, and this is important. What about the management part of it? So in the management part of it, what you need to understand is that if at all you can milk it out. Okay, so you can milk this particular gallstone into the once it basically crosses the ileocecal junction, then it's not going to stop. So you can just milk it out and you can just try to push it into the kind of ascending colon. That is one way. Or if at all, let's say already the signs of peritonitis have taken place, then no other way. You have to kind of go ahead with the resection and anastomosis. So that is what you need to perform over here. Or if at all it is too large and if you are not able to kind of milk it out, then enterotomy can also be performed. So that is about the gallstone ileus, which you need to understand. Now let's talk about the choledochal cyst. Now what do you understand by the choledochal cyst? It is a congenital condition. Okay, it is a congenital condition where there is dilatation of the bile ducts. Okay, so it is a congenital dilatation of the bile ducts. That is what is a choledochal cyst. Now why does it occur? It happens because of the abnormal biliary pancreatic junction. Okay, so what happens usually, the pancreatic juice cannot enter into the bile duct, but if at all there is an abnormal pancreatic or biliary junction, the pancreatic juice might have entered into the common bile duct, and this might have led to the dilatation of these particular tracts and all those particular stuff. But it's a congenital condition. To like just to understand this, it is a congenital condition. Now they might ask you, what is the presentation? So in the children's, they usually present as a jaundice. In the adults, it presents as pain and mass. Okay, so pain and mass is presentation in the adults. In the children, they usually present as jaundice. Now coming to the classification of the choledochal cyst. So there is a Todani classification, Todani-Alenzo classification for the choledochal cyst. Most important is this class 5, that is the Caroli's disease. We will talk about this multiple intrahepatic kind of choledochal cyst. We will talk about this. I'll show you the image. Image is very, very important. So fusiform dilatation is the kind of class 1. Diverticular dilatation is the class 2. That's fine. And then choledococele. Choledococele means that where this particular bile, the common bile duct is coming and entering into the intestine, at this particular point, if at all there is a dilatation, that is what is a choledococele. Okay, so this is what is a choledococele. Then in the type 4, there is intra plus extra plus kind of extra. That's fine. Forget about it. Not that important. The ones which are important is type 3 and type 5. Type 3 is choledococele. Type 5 is Caroli's disease. And for the Caroli's disease, they are going to show you this. Now, can anybody tell me what sign is basically visible over here? So this arrow is basically showing what sign? This is basically the central dot sign. Okay, so this is a characteristic central dot sign which you basically see in the patients of the Caroli's disease. Okay, now the complications can be obviously cholangitis, stone, cancer. So yeah, cholangiocarcinoma. Choledochal cyst is one of the risk factors for development of a cholangiocarcinoma. Okay, I hope you have understood this point. Now, coming to the treatment. So, if at all, let's say there is a type 1, type 2 or type 4, then you can perform an excision with the hepaticojejunostomy. You can do that. But if at all it is a type 3, then the treatment is sphincteroplasty. So, they might ask you, what is the treatment for the type 3 choledochal cyst? No, not resection, no kind of hepaticojejunostomy, no, not like nothing like that. Sphincteroplasty, because where the kind of bile duct is coming and entering into the intestine, there it is basically the dilatation. So yeah, sphincteroplasty is kind of done over there in the type 5 because it is kind of spreading all across, right? Okay, all across, like overall the entire kind of liver is filled with this particular dilatations. So this is what is a Caroli's disease, and over here the treatment is basically your liver transplantation. Okay, so for the Caroli's disease, what is the treatment? For the Caroli's disease, the kind of treatment is liver transplantation. Okay, now let's talk about the gallbladder cancer. What is this particular image, guys? Can anybody tell me what is this particular image? So this is what is your porcelain gallbladder. Are you able to see the calcified gallbladder? So this is what is your porcelain gallbladder, and that is what is a risk factor for the gallbladder carcinoma, one of the risk factors. Now, if at all, let's say there is a gallbladder polyp more than 1 centimeter, well, yes, that is a risk factor for the gallbladder carcinoma. Then primary sclerosing cholangitis, salmonella typhi, that is one of the risk factors. Gallstones more than 2.5 centimeters, and choledochal cyst. Okay, all these are the risk factors for the gallbladder carcinoma. Okay, now let's talk about the clinical features, right? Let's talk about the clinical features. So in the clinical features, what you need to understand over here that, okay, how the patient is going to present to you. So patient is going to come to you with a mass in the right hypochondrium. So patient is going to have a gallbladder mass. There's going to be the jaundice, that is usually the late presentation. So if at all there is a cholangiocarcinoma, the patient is going to have a obstructive jaundice. But if at all there is a gallbladder mass, usually the jaundice is going to be very, very late. So the first investigation over here is an ultrasound, and the investigation of choice over here is CECT, contrast enhanced CT scan of the abdomen and pelvis. Metastasis can happen to the liver, and management, if at all it is a grade 1, then it's just a cholecystectomy. If at all it is, let's say, 2A and 2B, extended cholecystectomy is usually kind of needed. And if at all it is metastatic, then yes, it's just a palliative kind of treatment. That is all about the gallbladder, guys, which I wish to cover with you. Now let us kind of move on and let's talk about the pancreas. Okay, so all good, guys? Can I have a couple of thumbs up? All good? Can we move ahead? Okay, now I understand it's grilling, but I hope that it is kind of helping you guys as well. I'll try to wrap up as soon as possible, but yeah, let's see. Okay, so let's start with pancreas. So first is basically pancreatic divism, not that important, but yeah, let's kind of have a look at it. Pancreatic divism, what is it? It is the most common congenital anomaly of the pancreas. That is first thing. What happens over here? Normally what happens, the majority of the drainage of the pancreas, okay, so majority of the part of the pancreas is drained into this major papilla, and only the minor part of the pancreas is basically draining into the minor papilla. Okay, but if at all due to the embryological kind of problems, the majority of the drainage is happening into this minor papilla, and only the small part is draining into this ventral duct of Wirsing. That is what is called as a this is what is called as your pancreatic divism. Now, what is the problem which might occur if at all there is a pancreatic divism? So there is a very, very small papilla. It means that the opening is very small and a lot of pancreatic juices kind of coming. So there can be stagnation of the pancreatic juices, and that is why there is an increased risk of pancreatitis. Okay, that is all you need to understand. For the treatment, you have to go ahead and do a sphincteroplasty. That's it, nothing much. Understood? That is what is a pancreatic divism. Nothing great about it, but yeah, that is a small thing. I'll just answer one query. Rajeshwari is asking, sir, how is gallstone managed usually? Please tell. Oh, it's obviously managed by cholecystectomy. You have to take a decision. If at all it is more than 2.5 centimeters, definitely you have to go ahead with a cholecystectomy. If at all there are multiple small stones, then it is a shared decision making. It might lead to choledochal ichthyosis in the future, so you have to go ahead with a cholecystectomy. For your kind of exam purposes, a solitary gallstone more than 2.5 centimeters, cholecystectomy. Symptomatic gallstones, cholecystectomy. Asymptomatic solitary gallstone can be left. Asymptomatic multiple gallstones, preferred to do a cholecystectomy. Understood? I hope you got it. Okay, moving ahead. This is very, very important. So our kind of person had come. So again, the double bubble appearance, we saw it in the duodenal atresia. Now it is a annular pancreas. What is the basic difference? Duodenal atresia, there was bilious vomiting. Over here, there is a non-bilious vomiting in 80% of the cases. But yeah, for your all practical purposes, if they have given both the options, duodenal atresia and annular pancreas, then you have to look for this bilious vomiting or the non-bilious vomiting. X-ray is the same double bubble appearance. Investigation of choice is an ERCP. Treatment is duodenostomy or a duodenojejunectomy usually is kind of done in this particular scenario. What is an annular pancreas? So here again, it's an embryological defect where the part of the pancreas or the rim of the pancreas is surrounding the second part of the duodenum. So pancreatic ring is around the second part of the duodenum. That is what is an annular pancreas. Non-bilious vomiting, double bubble appearance, these two things. Treatment is duodenojejunectomy or duodenostemy. Now, coming to the acute pancreatitis, very, very important. Okay, so what is an acute pancreatitis? Okay, now pancreatic enzymes, proteases, lipases, all those particular stuff, they get activated, but they are activated inside the intestine. So they are basically secreted as a proenzymes. Once they reach the intestine, they are activated. But if at all there is a premature activation of these particular enzymes, this can happen due to n number of reasons. But if at all there is a premature activation of these particular enzymes, that is what is referred to as an acute pancreatitis. Did you understand this particular point? Now, what are the causes of this acute pancreatitis? It can be because of gallstone, that is one of the reasons. Then alcohol, ERCP, trauma, increased calcium, hypertriglyceridemia, and drugs. The few of the important ones which you definitely need to remember: gallstone, most common. Alcohol is not the most common. Gallstone is the most common cause of the acute pancreatitis. How? Because there's a common pathway of the common bile duct and the pancreatic duct, and in that common pathway, if at all the stone comes and gets stuck, the bile duct can, or stagnation of the pancreatic juices can occur, and that can lead to the activation of the pancreatic enzymes. Alcohol, second most common, that's fine. ERCP, 5% risk of acute pancreatitis. So it is a kind of a iatrogenically, like you have induced the pancreatitis by doing an ERCP. Trauma, increased calcium, hypertriglyceridemia, that's fine. Understood. Okay. Now, coming to the clinical features, how will the patient present to you? So obviously, the patient is going to present to you with an epigastric pain, and the epigastric pain is going to be radiating to the back. Okay, epigastric pain radiating in the back, that is what is an acute pancreatitis. A very, very important MCQ. So I remember 4 years back, they had asked a question where they had given the image of a patient, and they had the patient was basically lying or like sitting on the whatever the bed or something with in the knee chest position, and then they said that the patient is having a condition which the pain gets relieved when the patient sits in this particular condition. What is the diagnosis? The answer to that was acute pancreatitis. Okay, so patient feels better in the knee chest position. Very, very important. Many students marked it wrong, so do not mark it wrong. Pain gets slightly better in the knee chest position. Now, okay, so pancreatitis is a very, very complex thing. Okay, so there can be a lot of toxins which can be secreted and all, and there can be a localized effect. So sentinel loop sign and all we will be talking about, but the patients may develop paralytic ileus, and because of that, the patients are going to have this nausea, vomiting, abdominal kind of distension. All these particular things occur in the patients with the paralytic ileus. These images, absolutely important. Fox sign, well, you know, you don't know, it's absolutely fine. But Cullen sign and the Great Turner sign, you cannot afford not to know. What is a Cullen sign? So it is a kind of a peri-umbilical ecchymosis. Okay, so this is a peri-umbilical ecchymosis. That is what is a Cullen sign. Great Turner sign is basically ecchymosis in the flanks. So this is basically the hemorrhage. So this occurs in the hemorrhagic pancreatitis. Okay, along the facial planes, the blood basically trickles down and it gets kind of accumulated in the peri-umbilical region and the kind of flank region. So that is what is your Cullen sign and the Great Turner sign. Fox sign, if the similar thing happens in the inguinal region, that is what is a Fox sign. But do remember Cullen sign and the Great Turner sign. Now, for the diagnosis, labs, you can get a amylase and you can get the lipase. Lipase is obviously much more specific for diagnosing the patients of acute pancreatitis. Nothing major about it. So, what about the investigations? Okay, radiological investigations. Yes, contrast enhanced CT scan. Investigation of choice to diagnose the acute pancreatitis. But when are you going to do it? Okay, so yeah, that's fine. Like lipase is the laboratory. Okay, if at all somebody asks you what is a radiological investigation of choice, then you answer it as a CT scan. Okay, contrast enhanced CT scan. Now, when will you do a contrast enhanced CT scan? The patient has come to you, the pain has started, let's say, a few years back. Will you order a contrast enhanced CT scan at this point of time? The answer is no. You will order a contrast enhanced CT scan after 48 hours, 48 to 72 hours. Why so? Because what you need to understand is that why do we want to get a CT scan done? We already have diagnosed the patients with acute pancreatitis based on the lipase levels, right? We have already done that. Now we want to know the severity of the disease, and for that, what we want is the necrosis. We want whether it is converting into the necrotizing pancreatitis or not. And once the pancreatitis starts, it basically peaks and then it comes down, and you have to wait for the necrosis to completely set in. Because if you do a CT scan a bit prior, it will give you a falsified result. Maybe the necrosis is still underway. After doing the CT scan, the necrosis will continue to happen. But you have done a CT scan a bit earlier, and that is why you do not have a complete picture. So that is why what you need to understand, the CT scan is done 48 to 72 hours after you have after the onset of the symptoms and all those particular stuff. On the X-ray, what are you able to see is a colon cutoff sign and the sentinel loop sign. I do not have an image of that, but yes, these images are also, they can be asked. Sentinel loop sign is just a part of the jejunum. You will find an air in the part of the jejunum. Just Google it up, that's fine. So colon cutoff sign, the air will be present till the transverse colon, till the spleen, and after that there is going to be the no air at all. Colon cutoff sign, jejunal sign is a sentinel loop sign where this like a part of the jejunum is going to have a small pocket of the air, and yeah, that's it. So these are indirectly telling you that the patient is in the paralytic ileus. Okay, now coming to the complications, I'll not go into the depth of it, but all you need to understand is, obviously you know that pancreatitis is not a localized condition, it's a systemic condition. So it is going to cause all those particular stuff, the cardiovascular shock, arrhythmia, AIDs. Again, let's kind of skip this because it's going to be a waste of time, because no particular MCQ is going to be asked from. Yeah, that's fine. Now, we have diagnosed the patients as acute pancreatitis, right? Now what we want to know the severity. Now, why do we have all these particular scoring systems? Because we don't know which is the best one, and that is why we have all these particular stuff, right? So after we have diagnosed the acute pancreatitis, now we want to know the severity of the acute pancreatitis, which we can know that with the help of a Ranson score, or let's say a modified Glasgow score, or a kind of bicep scoring system, or Apache 2 scoring system, or C-reactive protein, CT severity index. All these are the ways in which we can get to know the severity of the acute pancreatitis. For you should remember the Ranson scoring system and the bicep scoring system. No, not in kind of detail, but you just need to know what other things are included in this particular scoring system. So in the Ranson scoring system, what do we have? At admission, what we order is WBC, obviously that we'll get on the blood tests, age of the patient, glucose, AST and LDH. So these are the points which we consider at the time of admission, and 48 hours after the admission, what we basically need is, oh sorry, just give me a minute. Okay, sorry. Okay, so 48 hours after the admission, what you basically need is, we need hematocrit, BUN, and serum calcium, arterial PO2, base deficit, and the fluid need. So this is again a fluid deficit, more than 6 liters. That is kind of not good. Do not try to mug it up. If you know already, it's fine, but at least remember what are the parts which are included in the Ranson scoring system. If the score is less than 3, that is kind of mild. 3 to 5 is kind of considered as moderate. More than 6 is considered as severe acute pancreatitis. And then there is a bicep scoring system. So what is a bicep scoring system? B is for BUN, I is for impaired mental status, SIRS, age, and pleural effusion. So this is a bicep scoring system. I won't go into the details of the others. Just remember this, if you want CRP more than 130 is kind of bad, that's fine. But yeah, at least remember this Ranson's and bicep, these are something which are important. Now, this particular flowchart is going to summarize your entire acute pancreatitis. Now, what is this? Okay, so whenever the patient comes to you with the symptoms and everything, obviously you take the history and then you diagnose the patient as an acute pancreatitis based on the amylase and the lipase level and all those particular stuff. After the diagnosis, you want to know the severity. So all these particular Apache 2, Ranson, Glasgow, all those particular things you do, and you basically divide the patients into a mild acute pancreatitis or a severe acute pancreatitis. If at all it is a severe acute pancreatitis, you will resuscitate the patients inside the ICU. You are going to give the fluids because there is a fluid deficit. You will have to put a nasogastric tube because the patients might be in the paralytic ileus, so that the aspiration doesn't take place and the vomiting doesn't continue and all those particular stuff. If at all patients are not able to kind of eat in a good manner, then you will have to start the patients on the total parenteral nutrition. And CT scan, as I just told you, that you have to do it only after 72 hours. After 72 hours, you basically get a CT scan done. Why do you want to get a CT scan done? In order to see whether there is any pancreatic necrosis there or not. If at all there is a pancreatic necrosis, you might do a FNA in order to see whether it's an infected pancreatic necrosis or not. Okay, so let's not go into the lot of depth of it. Please do remember CT scan is to be done after 72 hours to know the necrosis is present or not. I hope you have understood this point. Okay, now if at all the necrosis is present, then you perform a pancreatic necroserectomy. And even if it is a sterile pancreatic necrosis, you have to start carbapenems, meropenem or something like that. You have to start in order to prevent the secondary infection happening into that particular necrosis. I cannot cover everything at this point, but yeah, these are just the gist of how do you manage a patient of an pancreatitis, acute pancreatitis. Okay. Now, one of the important complications of acute pancreatitis is something which is called as a kind of acute fluid collection. Okay, so peripancreatic fluid collection, that basically can happen after the acute pancreatitis. Okay, if at all there is a peripancreatic fluid collection, what is the management of that? Conservative management. You wait for around 4 weeks, usually it gets resolved. But if it doesn't get resolved and it forms a whatever granulation tissue, please understand, granulation tissue around it. Okay, so if at all, just understand, there is a pancreatitis. Because of the pancreatitis, what you have a acute peripancreatic fluid collection. Most of the cases it resolves. It's an important MCQ, guys. Okay, so acute peripancreatic fluid collection. What is the management? Management is conservative. You do not drain it. You do not do anything with that. But if it doesn't get resolved on itself, then what happens? Over a period of time, a granulation tissue can form around it after 4 weeks. Usually takes 4 weeks. Why granulation tissue? Because it is not having any epithelium, right? And that is why this is what is called as a pseudocyst. In other words, acute peripancreatic fluid collection can get converted into pseudocyst after 4 weeks if at all it doesn't resolve, it doesn't get resolved by itself. Okay, are you understanding my point? Right. So yeah, that's what you need to understand. Okay, so what is this particular CT scan? This particular CT scan, what you're basically seeing over here, this is what is a pseudocyst of pancreas. Okay, so this is a pseudocyst of pancreas. I hope you have understood this particular point, guys. Okay, right. Okay, now what will be the clinical features? If at all there is a patient with a pseudocyst of pancreas, what will be the clinical features of that? The clinical features is going to be early satiety. Why early satiety? Because the most common location of the pseudocyst of pancreas is in the lesser sac. Now just look at this particular size of this particular pseudocyst. What will it do? It is going to push, or it is going to apply the pressure on the stomach. And if at all it applies the pressure on the stomach, what is going to happen? As soon as the patient eats some amount of food, the patient is going to feel full. So that is why the patient has an early satiety. Along with that, other things can definitely happen. Pain can happen, bleeding can happen, infection can happen, all those particular things can happen. But because it is pressing on the stomach, early satiety and this pressure symptom, these are the important ones, right? What about the management? So again, for the pseudocyst of pancreas, the management is usually conservative. Okay, it is a conservative management. You wait for around 6 weeks. If at all the pseudocyst resolves, that's great. If not, then you go ahead with the surgery. What kind of surgery? You have to go ahead with the drainage procedure. Okay, now what is the indication of surgery? So one is size. If at all it is more than 6 centimeters, more than 6 centimeters, or if at all it has already been 6 weeks from the formation of the pseudocyst, or the patient is symptomatic. If the patient is symptomatic, it doesn't matter how long it is, it doesn't matter what the size is, you have to operate on these particular patients. What you have to perform is a drainage procedure. Very simple. Stomach is just right in front of it. You just drain it into the stomach, or you can drain it into the jejunum. So cystogastrostomy or cystojejunectomy, that can be performed, or if at all it is an infected kind of pseudocyst of pancreas, then you can drain it outside. Forget about it, let's not go into the depth of it. Drainage procedure is something which is performed for the pseudocyst of pancreas. Understood? So this is what is a cystogastrostomy which is being performed over here. Okay, right. Now I will be moving on to the chronic pancreatitis, but before that, Sai Mahana. Okay, hi Sai Mahana. Yeah, so I'm Dr. Pawan actually. So I used to teach for NEET PG and all those particular stuff. Then I went for my super specialization training. I was a faculty for the NEET SS at different platforms. And yeah, now I have kind of come to teach you guys. And I hope you are okay with whatever the things are there. I hope this particular session is helping you guys. Okay, now let's continue. If at all there is any feedback, you kind of put it up in the chat box. I'll be more than happy to kind of take it. Yep. Moving on. So we have completed the acute pancreatitis. Now I'll be talking about the chronic pancreatitis. I'm really sorry, guys. I know that I'm going very, very fast, but I've tried to cover most of the topics within 4 years, and that's what I'm trying to do. Sorry if at all you're feeling that I'm going very fast or I'm skipping something or something like that. Okay, now coming to the chronic pancreatitis. What is a chronic pancreatitis? So if at all, let's say there is an acute pancreatitis, and if at all there are repeated attacks of an acute pancreatitis, what can happen? So the pancreatic duct, it can become fibrosed. Okay, it can become fibrosed and strictured at different places, and there can be formation of stones inside it. Okay, so as you can see over here, this is a dilated pancreatic duct and atrophic pancreas. So pancreas become atrophic, and there's a dilated pancreatic duct with strictures in between, and there is a stones which are basically present between that. Are you understanding my point? So this is what is a chronic pancreatitis. Now in the acute pancreatitis, we talked about all sort of things: shock, ARDS, systemic kind of sepsis, SIRS, and all those particular stuff. In the chronic pancreatitis, you're not going to find all those particular things. There are 2 major features of a chronic pancreatitis. One is pain, severe pain, very, very severe pain. In the acute pancreatitis also there was pain. In the chronic pancreatitis, the pain is extremely high. Another thing is endocrine problems, because pancreas doesn't only produce your pancreatic juice, it also produces like the islet cells of Langerhans and all, they basically produce insulin, glucagon, all those particular stuff. So you are going to have an endocrine parts of the kind of pancreas will start functioning. The deranged functioning will be there. So there will be diabetes, all those particular stuff will be there. Okay. Now, important image for you guys. Okay, so they might show you this. They might show you that the patient has a severe pain of the abdomen. X-ray was done, and this was basically seen. What is this? This is a calcified pancreatic tissue. This is an indirect indication that there is a atrophic pancreatic parenchyma, and this is what is a calcified kind of pancreatic parenchyma. Are you able to understand this particular point? So this is the pancreatic calcification which you need to understand. Okay. Now, what is this? Okay, so let's talk about the investigation, guys. Okay, so there are various investigations which you can do for the chronic pancreatitis. One is obviously your X-ray, which you just saw. Contrast enhanced CT scan is there to diagnose the. It is an investigation of choice to diagnose the chronic pancreatitis, and then you can perform an ERCP, and you can perform a MRCP. So. Okay, what you need to understand over here, ERCP will help in diagnosis as well as sometimes therapeutic, because you might perform a sphincterotomy or something that will help you to drain that particular pancreatic juice. That's one thing. MRCP will tell you about the strictures. Okay, it will tell you about where the kind of pancreatic duct is dilated and where there is a stricture formation and all those particular things. So secretin stimulated MRCP, that is something which is used to look at the stricture. So what you need to understand is the answer will change as per the language of the question. If they say what is the investigation of choice to diagnose the chronic pancreatitis, it is going to be the contrast enhanced CT scan. What is the diagnostic as well as therapeutic investigation for this ERCP, for this chronic pancreatitis? It is ERCP. What is the investigation which you might do in order to look at the strictures and the dilated pancreatic duct? Then it's going to be your MRCP. Understood? Right. Now, okay, now it's a bit complex, this particular flowchart, but what you need to understand is that whenever you have a chronic pancreatitis, I told you that the major issue with the chronic pancreatitis is what? It is pain. It's pain, right? So what you do? So you try to manage it. So, okay, first of all, let's spend 1 minute to understand why the pain occurs. So pain happens because of the nerve and like the chronic changes in the pancreatic parenchyma. That is one thing which is not under our control. We cannot manage it conservatively. Another reason why the pain might happen is because there is a strictures in the pancreatic duct. And it doesn't mean that the chronic pancreatitis, the pancreatic juice secretion is absolutely zero. It is drastically reduced, but some amount of the pancreatic juice can still be secreted, right? And if at all there is a dense stricture, that juice will not be allowed to kind of go out. So what is going to be happening? There is going to be the increase in the pressure. So that is what is called as a increased pressure inside the pancreatic kind of ducts. So you can basically divide the chronic pancreatitis patients into ductal hypertension, that is a large duct disease, and like the areas of the chronic inflammation, that is a parenchymal disease. So you can basically broadly divide them into these two. Okay. Now ductal hypertension, that is a large duct disease. Okay, if at all there is a large duct disease, then what you can do? You can perform a ERCP guided kind of sphincterotomy, sphincteroplasty. You can perform that so that the distal pressure is kind of relieved and the pancreatic juices can basically enter into the intestine. That is one thing. Or, okay, so as you can see over here, I'm not going to the details of it because that is not very, very important for your FMG. So I'll not go into the lot of details of it, but that is what you need to understand over here. So endoscopic procedures and all those particular sphincteroplasty, stricture dilatation, all those particular things can be performed. If it fails, then you can perform something which is called as a drainage procedure. So have you ever heard of this Pusto's procedure? Longitudinal pancreatico-jejunostomy. So all those particular things. So drainage procedures can be performed. Dual procedure where there is a distal pancreatectomy with the pancreatico-jejunal anastomosis. So drainage procedures can be helpful for the large duct disease. And on the other hand, if at all there is a small duct disease, then you can give this analgesics, painkillers, and all those particular things. But if at all it fails, then you have to perform a resection procedure. So resection procedure is, just remember that Beggar's procedure, that is duodenum preserving pancreatic head resection, DPPHR. Okay, Beggar's procedure. Let's not go into the details of it. Probably it is not going to be asked to you, but these are the surgeries which you perform for the chronic pancreatitis. All you need to understand is Pusto's procedure, longitudinal pancreatico-jejunostomy, distal pancreatectomy with the jejunum anastomosis over that. That is what is the dual procedure, and duodenum preserving pancreatic head resection. That is what is your Beggar's procedure. Now, what you need to understand over here. Okay, what you need to understand over here is okay, like let's kind of put it in the practical sense. So if at all, let's say they give you a question scenario of the chronic pancreatitis and they tell you that the pancreatitis is involving the distal part of the pancreas, how will you manage this particular patient? What would you answer? I hope you're answering distal pancreatectomy. That's it. So if at all they have a pancreatitis limited to the distal tail of the pancreas, just perform a distal pancreatectomy. Forget about it. If at all they have a what you they in the scenario they basically gave that there is a dilated grossly or markedly dilated pancreatic ducts and all those particular stuff, then you can perform a sphincteroplasty in order to release the pressure over the pancreatic ducts, okay? Or you can perform a Pasteur's procedure, that is a drainage procedure, all those particular things. Are you understanding my point? But before you go to the surgical options, always give a trial of the analgesics. That is again very, very important. So I'm just rushing through it, but depending on what is the wordings of the kind of question, this particular flowchart will help you in understand or in marking the correct option for you guys. Okay, so that's all about the hepatobiliary pancreatic system, guys. Now we will be starting with urology. Okay, now this is going to be quite an interesting session. So yeah, all okay? Should we start? Okay, so it is 7:23. I'll try to wrap up by, let's say, 8:23, 8:30. I'll wrap up. Okay, so yeah, guys, understood? Like, should we start? Done? Just give me a thumbs up. Just show me some, that you are here. Okay, now coming to the urology, let's start with the first thing, that is a kidney, that is a stone and all those particular stuff. The first thing which we are going to cover is the calcium oxalate stone. So what is the calcium oxalate stone? This is basically the most common type of stone. This is the radio opaque stone. Okay, so this is a radio opaque, most common type of stone. Yeah, calcium is there obviously, so that is why it is going to be the calcium like radio opaque stone. One of the MCQs which was asked was ethylene glycol toxicity. This is was asked in your FMGE long back, 7-8 years back. So ethylene glycol toxicity, that is associated with your calcium oxalate stone. Now, can anybody tell me what is this particular diagnosis? What are you basically seeing in this particular image? So this is what you're basically seeing is a staghorn calculi. What is the staghorn calculus? So the stone is basically going into all the pelvic calyceal system. So that is the characteristics of a staghorn calculus, and this is one of the very, very important images which you basically need to understand with the staghorn calculus. Are you understanding my point? So yeah, let's talk about the staghorn calculus. So what happens is that okay, the questions which will be asked you over here: what is the most common organism associated with the staghorn calculus? It is Proteus. So staghorn calculus is usually formed in the kind of background of a urinary tract infection. Okay, so in the background of the urinary tract infection, most common organism is the Proteus. Why Proteus? Because Proteus basically produces an enzyme which is called as a urease. Okay, urease enzyme. What does this urease do? Urease enzyme basically converts the urea into ammonia. Okay, it converts the urea into ammonia, and this ammonia basically goes and it forms combination with the magnesium and calcium, and all these particular things form bond with the phosphate, and that is how we form a triple phosphate stone. So staghorn calculus is also referred to as a triple phosphate stone. I hope you're able to understand this particular point. This particular part is okay. Most important thing is, what is the most common organism? That is a Proteus, found in the background of a UTI, definitely. Triple phosphate stone, staghorn calculus is one and the same thing. Image is absolutely important. This is a staghorn calculus. Please do understand this. This is not a IVP. This is a plain X-ray KUB. This is what is a staghorn calculus. Understood? Now, moving on to the 3 one-liners which can be asked to you. Just remember, these are the simple numerics if you want. Radiolucent stones. What are the radiolucent stones? Extreme UTI, that is a xanthine stone, uric acid stone, triamtine stone, and indinavir stone. Triamtine, indinavir, drug-induced stones, uric acid, and xanthine. These are the radiolucent stones. Acidic, like what are the stones which are formed in the acidic urine? So the stones which are formed in the acidic urine are cysteine, calcium oxalate, and the uric acid stone. Then hard stones. Which of these are hard stones? Hydroxyapatite, cysteine, calcium oxalate monohydrate, and the brucite. These 4 are the hard stones which we have. Okay. Now very, very important. Whenever there is a patient with a stone, how will the patient present to you with the stone? So patient is going to have difficulty in urination, dysuria. Patient is going to have fever, burning micturition, all those particular stuff. So what are the investigations which you're going to order? I'll just quickly kind of browse through it. So we have urine. In the urine, we have a routine, and then you have a urine culture. So urine culture will tell you what is any urinary tract infection is there or not. In the routine, what you're basically trying to see is the crystals. Okay, crystals. Now, they might ask you an MCQ with this. So if at all you have a dumbbell-shaped crystal, what you have is a calcium oxalate monohydrate. If you have a bipyramidal crystal, that is what is your calcium oxalate dihydrate. This is also called as an envelope-shaped crystal. Envelope-shaped or a bipyramidal, that is what is a calcium oxalate dihydrate. Then if you have a, this is okay, forget about it. Rosette-shaped crystals is uric acid, not that important. Amorphous calcium phosphate, not important. This is very, very important. Coffin-shaped crystals are basically seen in the Staghorn calculus. Needle-shaped is also okay. Hexagonal crystals are seen in the cystine stone. So these four you have to remember. Dumbbell-shaped calcium oxalate monohydrate, envelope-shaped or tetrahedral, these are bipyramidal. These are basically seen in the calcium oxalate kind of dihydrate. Then coffin-led crystals, they are basically seen in the Staghorn calculus, and then the hexagonal crystals are basically seen in the cystine stones. Absolutely important, very, very important. Okay. Now, coming to the X-ray, they basically are able to detect around 80% of your whatever the stones are there. Not a very, very accurate investigation. You was done as a first line of investigation, no more done. It's fine. Like somebody can do it, but we do not plan our management based on an X-ray. So if I ask you, what is an investigation of choice to diagnose the stone? Now, what you need to understand, it is not an ultrasound. It is a non-contrast CT scan. Non-contrast CT scan. So you do remember the investigation of choice for head injury was non-contrast CT scan. In the similar manner, the investigation of choice to diagnose the renal stone, kidney, ureteric stone is non-contrast CT scan. Okay. Then intravenous pyelography, well, it was performed earlier. It tells you about two things. It tells us about, okay, it might help you in the diagnosis, that's fine. It tells us about the functioning of the kidney, whether the kidney is functioning or not. It basically tells us that. CT scan, as I told you, non-contrast CT scan is used for diagnosis. Contrast enhanced CT scan will tell us about the functioning of the kidney, but if at all the question is straightforward, investigation of choice for the diagnosis of the kidney stone, the answer is non-contrast CT scan. And then we have the renal scans. Now, what are the types of the renal scans which we have? The renal scans are DMSA scan, and we have a DTPA scan. So DTPA scan basically tells us about the functioning of the kidney. DMSA scan tells us about the scarring of the kidney. Okay, so this is just the basics. I won't go into the details of it, but it's okay. This is just how you investigate the patients of a kidney stone. Now let's talk about the management. So we have a conservative management. What is a conservative management? This is also called as a medical expulsive therapy, MET. What is a MET? It is basically you ask the patients to drink a lot of water, you give the patients alpha blocker, you give the patients painkiller. If I ask you what is the treatment of choice to reduce the pain in the colic, okay, because if at all the stone is kind of stuck in the ureter, the patient is going to have a very, very severe colicky pain. So in order to reduce the pain, the treatment, like the drug of choice is diclofenac. Diclofenac is the drug of choice for reducing the pain. Okay, that's fine. For management, the medical management or whatever the conservative management, what do you have? You give an alpha blocker, you give a lot of fluids, 3.5 liters of water every day, and then you ask the patients for painkillers. So Droten you give, or you give diclofenac or something like that. That is a conservative management. What about the kind of surgical management? You have ESWL, PCNL, URS, open and lap surgery. So important ones are ESWL, PCNL, URS. From there the questions usually come. So let's kind of quickly talk about this. What is an ESWL? ESWS, as the name says, extracorporeal shockwave lithotripsy. Extra means outside. Corporeal means corpus, body, outside the body. Shockwave. Shockwaves are basically given from outside the body. They're coming, they are acting on the stone, they're breaking the stone into smaller parts, and that's what it's the ESWL. Understood? Extra corporeal shockwave lithotripsy. Shockwaves coming, breaking the stone. Understood? Now, what happens is that what are the complications of that? Okay, so obviously, pain is one of the major complications of the extracorporeal shockwave lithotripsy. Hematuria. Why hematuria? Because these shock waves, when they are coming and they are basically damaging the stone, they might also damage the blood vessels of the kidney, and that is why the bleeding usually happens. Then there's something which is called as Steinstrass. What is the Steinstrass? Can you please tell me what is the Steinstrass? So let's say if at all there is a fragment. Okay, so let's say there's a stone. It is basically broken into smaller parts, but there is one big stone which is basically there. Okay, so this basically acts as a lead fragment. This acts as a lead fragment. So this is, let's say, your ureter. This is the urinary bladder, this lead fragment can come and it can get stuck at the vesicoureteric junction, and all the smaller fragments can get stuck above it. So this is what is called as a Steenstrasse, that is a street of stones. Okay, so this is what is a Steenstrasse or the street of stones, one of the complications. Arrhythmia can occur, sepsis can occur, that's fine. But the most common complication is pain and the hematuria. Pain would be the most common, that's fine. But both are very, very common. And then there is a strange choice. What about the contraindications? Will you be able to do it in pregnancy? Absolutely no. It is not done in pregnancy. What about the bleeding disorder? Hematuria is there, right? So if at all the patient is having some kind of factor deficiency, platelet disorder, you will not be able to perform this ESWL. These are the ones which I have kind of put in the bracket. These are the absolute contraindications. Then hard stones. Let's say we talked about the hard stones, right? So the hard stones might not break completely. So this is a relative contraindication. If it is a distal obstruction is there, okay, that is a relative contraindication. If at all the size of the stone is too big, the shock waves a lot of shock waves will be needed. The complete job might not be done. Obese patient, shock waves might not be able to reach to the stone. So these are the relative contraindications, but these two are the absolute contraindications. Very, very important. Okay, so I hope you have understood the concept of ESWL, Steenstrasse, pain, hematuria, and the complications, absolute ones are pregnancy and the bleeding disorder. All okay? Right. Now coming to the PCNL. What does PCNL means? PCNL means percutaneous nephrolithotomy. It means that you are basically going from the skin, you are basically going, making a tract, you are entering into the kidney, and then you are breaking the stone. And whatever the stones are broken down, you are catching them, you are taking it out. So this is what is called as a PCNL, percutaneous nephrolithotomy. Understood? Now, okay, so what are the complications of this particular percutaneous nephrolithotomy? Yes, hematuria, hematoma can occur. Around the kidney, the hematoma can form, or organ injury can occur. With organ injury, colon. Colon can get injured. So because sometimes there is a retrorenal colon and the colon can get injured, but it's a bit more depth, that's fine. Forget about it. Understood the concept of a PCNL? Now, coming to the okay, so what are the indications of doing a PCNL? So all these like things which we talked about, the relative contraindications of ESWL, now will become the indications of PCNL. Obese patients, PCNL can be done. Size more than 2 centimeters, yeah, you can go in, you can break the stones, you can take it out. Distal obstruction, yeah, you can take it, the stones out from above itself. Forget about the distal obstruction. Hard stones, we are using laser or something. Now the stones can be taken out, not a problem at all. But if at all the patient is pregnant, you will not be able to do it. Why? Because in the pregnancy, you will not be able to use the fluoroscopy. In order to visualize the stone, in order to do the puncture, you have to use the continuous fluoroscopy. Contraindicated. Pregnancy, absolute contraindication for PCNL. Bleeding disorders. How? You are basically puncturing through the kidney. There's going to be definitely bleeding. So bleeding disorder, absolute contraindication. So the absolute contraindications which were there for ESWL are same for the PCNL as well. Are you understanding my point? So bleeding disorders and the pregnancy, these are the absolute contraindications of PCNL. Now, what are you basically seeing on your image, like on this particular screen? So this is what is a URS, ureteroscopic retrieval of stone. So here what you basically can do is, like, you take a rigid kind of ureteroscope, you go in, forget about how do you do it. There's an instrument which helps you go into the ureter and reach to the stone, and then you can basically break the stone and take it out. Or if at all the stone is not very big, it's like relatively smaller, 6 millimeter, 7 millimeter or something like that, then you can use something which is called as a Dormia basket. So what you're basically seeing over here, this is what is a Dormia basket. Okay, so what is this? This is a Dormia basket. You close the basket, you go beyond the stone, you open the basket, and then you take the basket out. So while coming out, it basically takes the stone along with that. So this is what is a Dormia basket, which you are able to see over here. Understood, guys? Now, what about the management of the renal and the ureteric stone? So how do you kind of manage it? So, okay, if at all the stone size is, if at all we are talking about the kidney stone, the stone size is more than 2 centimeters, you go ahead with the PCNL. And if at all it is the size is less than 2 centimeters, you go ahead with the ESWL. So we are talking about the kidney stone first. More than 2 centimeters PCNL, less than 2 centimeters, you go ahead with the ESWL. Management has changed a lot. In today's time, we do something which is called the RIRS and all those particular stuff. But for all practical purposes, for your MCQ purposes, just remember that. Okay. Now, what about the ureteric stones? In the ureteric stones, you basically divide it into the upper, middle, and the lower one. Why so? Because let's say if at all there is a lower ureteric stone, your ESWL is not going to work. Why it's not going to work? Because the lower ureter is basically bounded by the bony cage. So your shock waves will not be able to reach to the lower ureter. So in the lower ureter, no matter what the size is, you have to go ahead with the URS, ureteroscopic retrieval of the stone. But if at all there is a upper or the middle ureteric stone, and if at all the size is less than 1 centimeters, you can go ahead with the ESWL. But if at all it is more than 1 centimeters, then you have to go ahead with the ureteroscopic retrieval of the stone. I hope you have understood. I hope I have not made it more complex for you. I hope you have understood this particular point. So this was one of the dry areas. Now let's talk about the simple, definitive, small topics that is going to help you out. So very, very important image. What are you basically seeing on this particular screen? Can you please put it on the comment box? What are you basically seeing over here? I hope you're able to appreciate the gas shadow over here. Is it usually present inside the kidney? The answer is absolutely no. So you do not have a gas shadow usually on the kidney. So this is what is an emphysematous pyelonephritis. What are you basically seeing over here? Emphysematous pyelonephritis. Okay, emphysematous pyelonephritis. Understood? Right. Now, emphysematous pyelonephritis, renal infection with air around it, that's fine. Most common organism for the emphysematous pyelonephritis, what is it? What is the most common organism for the emphysematous pyelonephritis? It is E. coli. E. coli. Okay. See, whenever there is a emphysematous pyelonephritis, what you need to understand, it is usually happening in diabetics, uncontrolled diabetics. In uncontrolled diabetics, you have this infection with the E. coli. It basically leads to the kind of gas formation, and that is what is an emphysematous pyelonephritis. The patient is going to come to you with the pain, fever, frequency. That's fine. Going to be present in any urinary tract infection. But the characteristic thing, if at all they want you to mark it as a emphysematous pyelonephritis, is going to be the pneumaturia. What do you understand by the pneumaturia? That while passing urine, you are basically passing some amount of gas along with it. That is what is a pneumaturia. Are you understanding? For the diagnosis, obviously, you're going to do a CT scan, a pancreatic drainage, and the nephrectomy. So this is a very, very kind of serious condition. Okay, so the mortality is quite high. So you have to kind of bit more aggressive. If at all the patient is not getting improved, you have to do a nephrectomy early in this particular patients. Important. Image is absolutely important. Do not forget about that. Just remember the name of it. Let's not go into the details of it. There's something which is called as a Young and TENS classification. So this is what is a Young classification is for the emphysematous pyelonephritis. So what is it? I'll just quickly cover it. So if at all the gas is retained inside the collecting system only, that is a class 1. If at all it is involving the parenchyma only, that is a class 2. If at all it extends in the perinephric space, that is a class 3A. If at all it goes into the paranephric space, is it a class 3B? And if at all both the kidneys are involved, or if at all the patient has only a single kidney, solitary kidney, then it is a class 4. Are you understanding? So first and second are fine, collecting system and the parenchyma. 3A, 3B means perinephric and paranephric. And if at all both the kidneys are involved or the solitary kidney is there, that is what is a class 4. Understood? Important. Once they had asked you this, I don't know, but it's a bit more depth question, but they had asked you this. Okay. Now let's talk about this. What is the diagnosis of this particular patient? What are you basically seeing over here? Are you able to see something? So this is what is the investigation? The investigation is intravenous pyelography. And what is this? This is what is your horseshoe kidney. Okay. So this is what is your horseshoe kidney. I hope you're able to appreciate that this is a kidney, this is a horseshoe kidney. Now what you need to understand over here is that how are the kidneys formed? The kidneys are basically formed in the pelvic cavity. And once the kidneys kind of form, they gradually basically come up and then they come to lie in the retroperitoneum. So the origin is basically in the pelvis and then they gradually ascend into the abdominal cavity. The opposite is true for the testes, right? So testes basically form in the retroperitoneum and then it gradually goes down into the scrotum. So these both go a bit kind of opposite way, right? Okay, what is the problem with the horseshoe kidney? The problem with the horseshoe kidney is when it is basically coming up, when it is ascending up, this particular isthmus, there is an isthmus, obviously, because in the horseshoe kidney there is a isthmus which is there. This isthmus will be kind of restricted by the inferior mesenteric artery. Are you able to appreciate this? So this is important. They ask you that the ascent of the kidney is basically stopped by inferior mesenteric artery. That is important. And the isthmus usually lies at the level of L2, L3. Okay, so both these things are very, very important. Okay, so two important MCQs. Inferior mesenteric artery and the isthmus is lying at the level of the L2, L3. Okay, now what you need to understand is there, no, not L1, it's L2, L3. Okay, so origin of the inferior mesenteric artery is at the level of L2, but The isthmus is at the level of L2, L3. Please do remember this because they give you the options very, very close. So do remember this, guys. Okay? Okay, right. Now, how will the patient present to you? Like, what will be the clinical presentation of these particular patients of the horseshoe kidney? Most of these patients are going to be asymptomatic. Asymptomatic. So they went in to do an ultrasound for some or the other reason, and then they kind of found that, you know what, now they have a horseshoe kidney. Few of the patients can come to you with a urinary tract infection. Few of the patients can come to you with the pain. Few of the patients can come to you with the hydronephrosis. Yes, they can be there, but most of the patients, they basically come asymptomatic. Routine ultrasound found that there's an horseshoe kidney. What about the management? So if at all there is an asymptomatic patient, nothing to be done, that's fine. But if at all you have to kind of treat it because of some symptoms or something like that, then you obviously cannot cut the aorta. So what you basically do is you basically kind of cut the isthmus. Okay, so you try to do that. Not that kind of simple, but many times it is kind of vascular isthmus. But if at all you have to kind of do it, you have to kind of do that. Okay, are you understanding my point? Sometimes it is a fibrotic band, sometimes it is vascular, and even the blood supply is kind of common between the lower poles. So that's fine. Now, all you need to understand on the intravenous pyelography, you have it's a very traditional MCQ. Nobody asks it nowadays, but what you basically find is a shake hand sign. So on the ultrasound, it is a shake hand sign or a flower vase appearance. Okay, so flower vase appearance is not like Sunny. So yeah, I understand that some of the MCQ books have written that never cut the isthmus or something like that, but it's not like that. You can cut the isthmus. It's not that big a thing. You can cut that, but you have to kind of suture it up. So if you go to YouTube, don't go today, but after your exams, if you go to YouTube and if you see the operations of the horseshoe kidney, you basically can apply a stapler over there, or you can cut the isthmus and then you'll have to suture the kidney parenchyma. There is definitely a risk of loss of the lower pole of the kidney. I think this is a bit higher level discussion, not relevant for tomorrow's exam, but yeah, this is a misconception that you never cut the isthmus. You can definitely cut the isthmus, absolutely no doubt about it. Okay. I'm a urologist. I'm trying to tell you that yes, we can cut the isthmus. That's not that big a thing. If at all it is a symptomatic patient, if you really, really need to operate on that particular patient, then you can cut the isthmus. It's not that big a deal. Okay, so yeah, you can do that, but you avoid to do that because obviously it's not that a simple surgery. But if you have to kind of operate, let's say if at all this particular kidney develops a tumor or something like that, obviously you will have to cut the isthmus. You'll have to kind of remove this particular kidney or something like that. Are you understanding my point? But we are diverting. Like this is not relevant for the MCQs in tomorrow's exam. So, but yes, after you are done with your kind of exam, you can go on YouTube. You can have a look at a couple of MCQ like videos where the isthmus can actually be cut. Okay. Yep. Now coming to the next topic. So what is this? What is this, guys? This is what is your duplication of ureter, right? So this is a duplication of ureter, and this is again a very, very important topic. This is what is a Wiegert-Mayer. So what happens in the duplication of the ureter? Normally one kidney has one ureter, but if at all one kidney has two ureters, that is what is called as a duplication of ureter. There can be a partial duplication, or there can be a kind of complete duplication of ureter. So in the complete duplication of ureter, what happens is that one ureter basically drains the upper pole and the another ureter basically drains the lower pole. The Wiegert-Mayer rule, this is very, very important. Many things are kind of based on this. Okay, what is a kind of Wiegert-Mayer rules? This basically says that the ureter which is draining the upper pole of the kidney, that basically lands up distally. Okay, it lands up medially, and this tends to be stenotic. Please do remember this. Okay, so the ureter which is draining the upper pole of the kidney, that tends to be kind of distal, that tends to be medial, and that tends to be stenotic. Understood? What about the ureter which is draining the lower pole of the kidney? That tends to be cranial, that tends to be lateral, and that has a refluxing kind of a thing. Are you understanding my point? So as you can see over here, the ureter which is draining the upper pole of the kidney, that is basically entering distally, and that tends to be stenotic. So what is going to happen? There is going to be the hydronephrosis, and if at all there is a hydronephrosis, what is going to happen? The upper pole kidney over a period of time is going to become non-functioning or poorly functioning. Are you able to understand this particular point? So repeat with me. Upper pole ureter draining distally, draining medially, and stenotic. The lower pole ureter is draining cranially, it is draining laterally, and it is basically refluxing. Are you understanding my point? Right. Okay, now this is a simple Wiegert-Mayer rule. Now, over a period of time, okay, now how will the patients present to you? So that will depend on what is the most common site of the opening of these particular ureters, right? So there is a difference between males and the females. If you just want to remember as one liner and don't want to understand it, just remember that males present with urinary tract infections, the females present with incontinence. The characteristic history the female is going to give you is that she has continuous incontinence, but along with that, patient is also able to void normally. How come this is possible? Let's spend 2 minutes to understand this particular concept. So we have two kidneys, right? And let's go back. So let's assume that this is a female, right? So this cannot be female because here there is a prostate, but yeah, let's understand if at all there is a female. The ureter which is draining the upper pole, that is basically entering distally. It goes beyond the bladder neck, it goes beyond the sphincter and it enters into the ureter. So whatever the urine is produced by the upper pole, that is kind of continuously dribbling. But at the same time, the normally functioning kidney is able to produce urine which is coming and accumulating inside the bladder. And once this particular bladder gets full, it has the feeling and then the patient goes and voids. So the history which the patient is going to give you, I keep on kind of having a small bits of urine, but after 2 years, 2.5 years, 3 years or something like that, I go to the washroom and I pass around 250, 300 ml of the urine as well. So this is a characteristic history the patient is going to give you. Are you understanding my point? Okay. In the males, what happens? In the males, whatever the upper pole ureter is, it is always opening proximal to the external sphincter. Okay, it is always opening proximal to the external sphincter. So how is the kind of a anatomy? This is a urinary bladder. This is a kind of prostatic urethra. This is the membranous urethra. This is the bulbar urethra. This is the penile urethra. Over here, what we have is a urogenital diaphragm. Now, if I ask you, where are the sphincters present in the males? So we have an internal sphincter at the bladder neck and we have an external sphincter at the membranous urethra. So in the males, what happens? Always the ectopic ureter is above this external urethral sphincter. So in other words, in males incontinence never happens. So males present with urinary tract infection, females present with incontinence. And the characteristic history the females are going to give you is that I have a continuous incontinence and I also go and pass urine every 2.5, 3 years or something like that. I pass 200-300 ml of the urine. Are you understanding my point? Right. So that is the presentation. I hope you have understood this particular point. The whole concept goes that the opening of the ureter, the ectopic ureter, proximal to the kind of sphincter or distal to the sphincter. I hope you have understood this point. Okay. Now, what about the so somebody had answered, right? I forgot name, but they had answered it correctly. Drooping water lily sign is basically seen in the duplication of the ureter. As I told you, that the upper pole moiety over a period of time is going to become kind of non-functioning, hydronephrotic non-functioning. So first of all, it has become non-functioning, and now because it has become big, the lower pole is basically pushed down. And now when you perform an intravenous pyelography in these particular patients, how it is looking, this is a pelvic vessel system, so it is looking like a drooping water lily. It is looking like that, so this is the drooping water lily sign. But the water lily sign is basically seen in the kind of hydrated cyst where the endocyst has separated from the ectocyst. Are you understanding my point? Drooping water lily sign, duplication of the ureter. I hope you have understood this particular point, right? Okay, so duplex ureter and duplication of ureter are more or less the same. That's fine. What about the management? They are same. Duplication of ureter, duplex ureter, one and the same. There's a partial duplication, there's a complete duplication, and the complete duplication is called the duplex ureter. That's fine. Okay, coming back to this home management. So if at all there is a non-functioning upper pole which is causing a lot of problem, infection and everything, you can go ahead with the resection of the upper pole. That's what you can do. Forget about it. Not that important. Not that relevant. Drooping water lily sign is important. The clinical scenario based on this, incontinence and infection, that is very, very important. Wiegert-Mayer rule is very, very important. Image is very, very important. Understood? Now, coming to this. What is this? This is what is a ureterocele. What is this? This is a ureter. I hope you're able to appreciate this, guys. Okay, I don't know whether the image quality is fine or not. Okay, here as you can see, this is a ureter, and the terminal part of the ureter is basically dilated over here. So this is what is a ureterocele. What is a ureterocele? The terminal part of the ureter where it is opening into the urinary bladder, that is basically dilated. So that is what is a ureterocele. Understood? Now, what you need to understand is what is a like image, or what is the sign which you basically see on the IVP? You see an adder head or a cobra head appearance. Okay, adder head or a cobra head appearance, that is what you basically see in the kind of ureterocele. This particular ureter also tends to be sometimes stenotic, and that is why there is a back pressure changes and there is a hydronephrosis can happen. And if at all there is a obstructive features, then you have to manage it. And how do you kind of manage it? By like putting a smiley incision on this particular urethrocoel. Not relevant, that's fine. For tomorrow's exam, just look at this particular image and this can be asked to you. Adder head appearance, cobra head appearance, urethrocoel. Okay, coming to the renal cell carcinoma. Okay, so renal cell carcinoma, again, a very lot of details are there. I'll just quickly cover about the histological subtypes of the renal cell carcinoma. So we have a clear cell carcinoma, we have a papillary cell carcinoma, chromophobe, Peyronie duct, and the medullary cell carcinoma. What is the most common of all these particular types? So it is a clear cell carcinoma. It is a hypervascular. Okay, it is a hypervascular kind of cancer. That's fine. It is the most common. It is associated with VHL gene mutation, which is present on chromosome 3p. Very, very important. VHL, von Hippel-Lindau gene mutation, present on chromosome 3p, associated with the clear cell carcinoma. Very, very important. Do not forget about this. What about the papillary cell carcinoma? This is associated with MET gene. Okay, MET gene mutation. Are you understanding my point? MET gene mutation. So, yeah, that's fine. MET gene is this. That's fine. Now, trisomy 7. That is the familial cases, but there are others like aneuploidy and all those particular stuff can also occur, not that relevant. Trisomy 7 is associated with papillary cell carcinoma, MET gene is associated with papillary cell carcinoma. Very, very important MCQ. If they give you a scenario that, you know what, the patient is there, 50-year-old patient, he has been on dialysis for like last 10 years, and now the patient is developing a kidney cancer. What is the most common type of the kidney cancer? It is a papillary cell carcinoma. So acquired renal cystic disease in patients on dialysis, that is one of the important risk factors for development of a papillary cell carcinoma. Very, very important. This clinical scenario can be asked to you. And I'm pretty sure that you know the other places where the soma bodies occur, like, you know, serous adenoma of the ovary, papillary cell carcinoma of the thyroid, papillary cell carcinoma of the kidney, meningioma. Okay, so these are the places where the soma bodies occur. So yeah, that is one of these, right? Chromophobe cell carcinoma. All you need to understand is it has a plant-like appearance. It is arising. Okay, so clear cell carcinoma, papillary cell carcinoma, they arise from the proximal convoluted tubule. Chromophobe carcinoma, it arises from the distal convoluted tubule. It has got a decent prognosis. Okay, that's fine. Clear cell carcinoma, it has got an okay prognosis. Like again, a fair prognosis, not bad, not good. That's fine. Bilinear carcinoma, it has got a worse prognosis. DCD, that's fine. Medullary cell carcinoma, that is what you need to understand. Again, it has a very, very poor prognosis. It is only MCQ which they might ask you from this medullary cell carcinoma is sickle cell trait patient. So if at all the patient is a sickle cell trait, not sickle cell disease, sickle cell trait patients are at an increased risk of suffering from this medullary cell carcinoma. Okay, so not possible to cover each and everything from the renal cell carcinoma, just trying to cover the histological subtypes of that. Okay, now what is this? What are you basically seeing in this particular image? I hope you are able to answer that this is a cannon ball appearance. It is a characteristic thing which basically occurs if at all there is a multiple kind of metastasis from the kidney. Okay, so kidney metastasis basically goes to the lungs, and that is what is a cannonball appearance, which basically comes over here. Understood, guys? Right. Now, important thing about the kidney RCC is paraneoplastic syndrome. Now, what do you understand by the paraneoplastic syndrome? Okay, so paraneoplastic syndrome basically means that, okay, let's say if at all there is some cancer, okay, and that particular cancer has to produce a kind of systemic symptoms. For that, what you need to understand is that the cancer has to metastasize at other place, right? Obviously. But if at all the cancer is able to produce the systemic symptoms without metastasizing, that is what is called as the paraneoplastic syndrome. It basically secretes certain kind of substances which cause a distal effect. That is what is a paraneoplastic syndrome. So what is the most common? It is a raised ESR. That is the most common paraneoplastic syndrome which can occur. Hypertension, anemia, polycythemia, these are the other. Hypercalcemia can occur. This is because of the increase in the parathyroid related peptide, okay? And the treatment for that is bisphosphonate. So this can be tackled by the medical management as well. But the important one which you need to understand is the Stoffer's syndrome. So what happens is that if at all you have a renal cell carcinoma, it can produce interleukin 6, okay? It can produce interleukin 6, and this interleukin 6 basically goes and acts on the liver, and it causes deranged LFT, liver function test. It causes deranged LFT. So this is what is the Stoffer syndrome. And if you want to manage this, how do you manage this? This is managed by nephrectomy. Okay, this is managed by nephrectomy. Are you understanding my point? So what is the management of this particular Stoffer syndrome? That is a nephrectomy. So once you remove this particular tumor, whatever the interleukin 6 production is kind of going to go down and the patient is going to feel better. Okay, so that is what is the paraneoplastic syndrome. This is a TNM staging. T1A is basically T1 less than 4 centimeters, T1B is 4 to 7 centimeters, then it is 7 to 10 centimeters, more than 10 centimeters, but here the tumor is still in the kidney. Okay, T1A, T1B, T2A, T2B. Less than 4, 4 to 7, 7 to 10, more than 10. But tumor is still in the kidney. The important one is over here, T3. In the T3, what happens? The tumor has entered into the like renal vein and the infravena cava. One of the important characteristics of the renal cell carcinoma is it produces something which is called as a tumor thrombus. Okay, it produces tumor thrombus. So if at all this particular tumor thrombus has reached to the like renal vein, that is T1A, if at all it has entered into the infravena cava, that is a T2B, below the diaphragm. If at all it has gone above the diaphragm, that is the T3C. Are you understanding my point? And what about the T4? It is basically into the Gerota's fascia and all those particular stuff. Or there is a contiguous spread to the adrenal. Now this is something which you should remember. Okay, so let's say if at all this is a kidney, and over here what you have is a kind of an adrenal gland. Now if at all there is a tumor of the upper pole of the kidney and there is a direct spread of the adrenal like this is what is a T4. But if at all there is a lesion in the lower pole of the kidney and there is a simultaneous lesion in the adrenal, it means that it has spread via the hematogenous route, and this basically becomes a metastasis. Are you understanding my point? Contiguous spread into the adrenals, that is a T4, but hematogenous spread into the adrenals, that is what is the metastasis. I hope you have understood this particular point, guys. Okay, now that is done with the kidney. Now let's have it like this particular image. What is this, guys? What is this? What is this? Cystogram? No, this is what is your bladder calculi. What is this? This is what is a bladder calculi. A very, like, not very, very important, but a decently important topic. So let's kind of talk about this. Okay. So bladder calculi can be of two types. It can be either a primary bladder calculi or a secondary bladder calculi. There's a lot of confusion. This is basically based from 11 Billy. So please try to understand this. Okay. What is the primary bladder calculi? Primary bladder calculi means a calculi which is basically present inside the bladder in the absence of any distal obstruction. That is what is the primary bladder calculi. Okay, there is no distal obstruction present. But if at all there is some kind of a distal obstruction present, for example, the patient is having a urethral stricture, the patient is having a benign prostatic hyperplasia. So if at all there is some kind of a distal obstruction, and then there is a kind of a bladder calculi, that is what is a secondary bladder calculi. Are you understanding my point? Now, let's talk about the primary bladder calculi. So here, it is more common in the children. Okay, it is common in children less than 10 years of age, and this is basically associated with the nutrition. Okay, so especially in the places where the nutrition is kind of not good for the kind of children, the incidence of the primary bladder calculi is high, and that is why this is also called as an endemic. Because obviously, if at all there is a problem with the nutrition in one particular area, there will be all the children will face similar kind of a problem. Are you understanding my point? So endemic bladder calculi or bladder calculi associated with the nutrition in the absence of any distal kind of obstruction, more common in the children less than 10 years. That is what is a primary bladder calculi. Okay, most common type is ammonium urate. That's fine. Management, okay, we'll talk about it. But the important thing is the chances of recurrence are very less over here. Why? Because obviously the cause was nutrition. After 10, 12 years of age, if at all the patient is able to, or the child is able to survive, probably his nutrition is going to improve and he'll be out of it. Are you understanding? That is basically because of the cause, and that is what is about the primary bladder calculi. Now coming to the secondary bladder calculi. As I told you, there is some kind of a distal obstruction, stricture, bladder neck obstruction, BPH, something like that. And it is obviously going to occur more in the elderly population because the prostate problems and all are more in the elderly population. So yeah, that's fine. Uric acid, steroid can happen, that's fine. Recurrence is common because sometimes what happens is that you will end up treating the bladder calculi, but you will not address the distal obstruction. And if you do not address the distal obstruction and you just manage the bladder calculi, that is not going to help at all because the chance of recurrence will be much high. Now, how do you manage this? Like, how do you kind of manage the bladder calculi? Not very important. What is this? A lithotrite. Lithotrite. What do you understand by lithotrite? So this is what is called as a stone crushing kind of stone crushing force or something like that. So what you basically do is that with the help of this particular instrument, you go inside the bladder, you catch hold of the stone, and then you kind of pull it so that stone gets crushed into smaller pieces, and then you can kind of take it out. Are you understanding? Or if at all the stone is very, very big, so usually if at all the stone size is less than 2 centimeters, you can use that. Or if at all the stone size is very, very big, you can open the bladder and you can kind of remove that particular stone. This is what is called as an open cystolithotomy. Open means open, cysto means bladder, litho means, you're kind of removing the stone, and lithotomy. That's fine. Are you understanding my point? I hope you are. Okay, now just the diagnosis. What is this particular image? Like, what is this particular patient suffering from? I hope you're answering that this particular patient is suffering from extrophy of bladder. What is this? This is what is an extrophy of bladder. So what happens over here? There is a defect in the formation of the anterior abdominal wall that is basically formed, like not formed. So what happens is that the anterior wall of bladder is also not formed. So what you're basically seeing over here is the posterior wall of the bladder. You can actually sometimes, like most of the times, you can see the ureteric orifice and the urine is basically coming out of that. So let's not go into the details of it. It's kind of very, very kind of complex topic, but just understand this is what is an extrophy of bladder. And yeah, here, what is the problem? Defect in the anterior abdominal wall as well as the defect in the anterior wall of the bladder, and the posterior wall of the bladder is basically protruding out, the mucosa over that. Okay, so you have to close it and everything. That's a different story. Let's not go into the details of it. Now, just one thing which you need to understand is, have you ever heard of this Michaelis-Guttman body? Asked many times. Okay, so Michaelis-Guttman bodies are seen in, anybody? Can you put it in the comment box? It is seen in malakoplakia. So what is this? What is malakoplakia? So I'll just quickly tell you. What is malakoplakia? Malakoplakia is a condition where there is a plaque formation. Okay, it's not an infective condition. It is a immunological condition, or like inflammatory condition. It is not an infective condition, it's an inflammatory condition. Here what happens, that the bladder mucosa and all basically react to the whatever the organism, and it leads to a formation of a plaque. And inside this particular plaque, what you basically have is, you have a large histiocytes. These are called as a von Hansen cells. So what are von Hansen cells? These are the large histiocytes. Inside that you have inclusion bodies, which is basically a Michaelis-Guttman bodies. And all this thing is basically happening because of E. coli infection. E. coli is something like you can put anywhere in the urology, that's fine. So E. coli infection leads to all these particular things, but it is not an infective condition, it is an immunological condition. As somebody is saying that polysomal fusion defect, that's fine. So all these particular immunological things are keeping happening over that. Okay, now coming to this particular endoscopic image. So this is an endoscopic image, what you're basically seeing. What is this? This is what is a bladder tumor. What is this? This is a bladder tumor. Are you understanding my point? So this is what is a bladder tumor, which you're basically seeing over here. Now, how many types of the bladder cancer are there? Bladder tumor, bladder cancer, how many types are there? So you have a transitional cell carcinoma, you have a squamous cell carcinoma, and you have a adenocarcinoma. Which is the most common type of a bladder cancer? The most common type of the bladder cancer is transitional cell carcinoma. Are you understanding my point? Most common type is transitional cell carcinoma. Then you have a squamous cell, then you have a adenocarcinoma. Understood? Now, what are the important, very, very important, okay? So, the general dictum basically says that if at all there is a patient who is more than 50 years of age and the patient is coming to you, male or female, whatever, coming to you with hematuria, until proven otherwise, you are basically dealing with a bladder cancer. Okay, that is the general dictum which basically says. Now, what are the risk factors for the transitional cell carcinoma? Smoking, a most important risk factor for the transitional cell carcinoma. Others are aniline dye exposure, cyclophosphamide. What is a cyclophosphamide? It is a chemotherapeutic drug, okay, and like it is basically used to treat certain malignancies. But this cyclophosphamide, it leads to the hemorrhagic cystitis. It leads to the hemorrhagic cystitis, and this hemorrhagic cystitis is basically leading to the bladder cancer. Are you understanding my point? So this hemorrhagic cystitis is leading to the bladder cancer. Are you understanding? So yeah, smoking, aniline dye exposure, cyclophosphamide, then we have a textile dye, rubber, petrol workers, all those particular stuff, analgesic abuse, phenacetin, schistosomiasis. All these are the risk factors for the transitional cell carcinoma. Schistosomiasis, I'm really brushing through, guys. I'm going a bit fast. Schistosomiasis is also responsible for squamous cell carcinoma. Okay, so if at all say ask you that if at all there is a patient with a schistosomiasis, what is more likely, whether the patient will suffer from squamous cell carcinoma or the transitional cell carcinoma? The answer is squamous cell carcinoma. But overall, what is a more common cancer? It is a transitional cell carcinoma. Most important risk factor for the transitional cell carcinoma is smoking. Okay. Now, what about the squamous cell carcinoma? So let's say if at all there is a long-standing Foley's catheter, or let's say there is a long-standing stone which has caused a chronic irritation of the mucosa of the urinary bladder, this will lead to the formation of a squamous cell carcinoma. Adenocarcinoma, any kind of congenital defect. So urachal anomaly. So if at all there is a urachal anomaly, we just saw the extrophy of bladder. So extrophy of bladder patients have a risk of development of a adenocarcinoma in the future. Okay, forget about all these particular stuff. We have a bladder tumor. Whenever the patient comes to us with a hematuria, what are we going to do? We are going to do some radiological investigations. Ultrasound can be done. If at all the size is decently big, it will be picked up by the ultrasound. We will also be doing a contrast enhanced CT scan, CECT, we will be doing in these particular patients. And CECT is going to tell us about a couple of things. First, whether that particular tumor is, okay, so let's say if at all this tumor was very, very big, and if at all it is kind of obstructing the ureteric orifice, then what is going to happen? It is going to cause the back pressure changes over the kidney. So CECT will basically help us know the exact location of this particular tumor, exact size of this particular tumor, whether the ureteric orifice is involved or not, whether there is an upstream hydronephrosis or not. So all those particular information we are going to get from the contrast CT scan. Okay, understood? So yeah, so gross hematuria is one of the presenting feature. We talked about it. Okay. So investigation, as I told you, we are going to do ultrasound. Obviously, we will do that. Okay. There's something which is called as a cytology. Okay, urinary cytology. Have you ever heard of urinary cytology in any other pathology? The answer is no. So why do we do a urinary cytology in these particular patients? This is basically because of the cohesiveness. Okay, so the bladder tumors are not very well bound with each other. In this fancy language, what we call is they are less cohesive with each other. Because they are less cohesive with each other, what happens? These cells can be shed off, and when you collect the urine, you will be able to detect these particular cells inside the urine. Are you understanding my point? So that is why malignant cell cytology is something which is done in this. What is the sensitivity of the malignant cell cytology, of the urine cytology? It is very less, but the specificity is very high. If at all, the urine sample is able to detect the malignant cells, the specificity is obviously very, very high. Are you understanding my point? So yes. CT scan is used for the overall staging. Yes, that's what we do. MRI is basically used to evaluate the nodes and the muscle invasion. Okay. And as I have told you that any tumor in the body, before we start the chemotherapy or before we do the definitive management, what we need is a biopsy. So whenever we have a bladder mass or a bladder kind of a suspicious malignancy, we cannot just go in and take a biopsy of that. What we need to perform is a TURBT. What is a TURBT? Transurethral resection of the bladder tumor. That is what we need to perform over here. So once we perform a TURBT, what are we going to have? We are going to have a histopathological diagnosis, whether it is a transitional cell carcinoma or the squamous cell carcinoma, or is it like the adenocarcinoma. We are going to have that. Okay. Then we are going to have whether it is muscle invasive or not, because the further management of the bladder cancer is dependent on whether the underlying muscle is involved or not. In other words, when we get the histopathological report from the kind of pathologist, what we see is whether it is a muscle invasive bladder cancer or muscle non-invasive bladder cancer. Okay, so that is the distinction which we need to have. Based on that, we can have a non-muscle invasive. So CI is also comes under the category of non-muscle invasive only, and then we have a muscle invasive bladder cancer. Okay, now a couple of words about the CIS. CIS means a carcinoma in situ. Now, one of the important presentations of the carcinoma in situ is cystitis. So patients can come to you with irritative symptoms like dysuria and increased frequency and all those particular things. Just one line, if you can remember, just remember that. Can give you the clinical scenario. Very rarely, but yeah, they can give you. Okay, now coming to the non-muscle invasive bladder cancer. How do you manage a non-muscle invasive bladder cancer? This is basically managed by intravesical agents. What do you understand by intravesical agents? So you basically put something inside the bladder. So there's a medication and you basically put it inside the bladder. So it is going to act locally on the wall of that particular bladder. So what we can put? We can either put a chemotherapeutic agent or we can put an immunotherapeutic agent. So please understand, they might ask you, this is an important MCQ, they will tell you that which of the following is not a intravesical chemotherapeutic agent, and they will give you the options of mitomycin C, thiotepa, adriamycin and BCG. The answer is BCG, because BCG is a immunotherapeutic agent. It is not a chemotherapeutic agent. Are you understanding my point? So this is an immunotherapeutic agent. Mitomycin C, thiazidopyriamycin, these are the chemotherapeutic agents. Okay. So that's about the management of the bladder cancer. Okay, so let's not go into the details of this. Forget about it. If at all there is a muscle invasive bladder cancer, you have to perform a radical cystectomy. That is, you have to remove the entire bladder along with the seminal vesicles and all those particular stuff. Forget about it. Lot of detail, not needed for you guys. Just remember this. Immunotherapeutic agent is BCG. Chemotherapeutic agent is this mitomycin C, thiazidopyriamycin. One which was used very, very commonly is mitomycin C. Okay, understood. Okay, now let's talk about the BPH. I have not kind of put a lot of things over here, but let's kind of talk about the prostate. Because of lack of time, I had to kind of omit a lot of things. But yeah, let's talk about the prostate. So I'll not cover the presentation and whatever the investigations of the BPH and all those particular stuff. I'll cover the important thing, that is the management part of it. So we have, what are the medications which you use if at all the patient has a benign prostatic hyperplasia? There are two medications. One is alpha blockers. Why alpha blockers? Because we have alpha receptors on the bladder neck, and once we give the alpha blockers, the bladder neck relaxes and the patient is able to pass urine in a better manner. Another thing is something which is called as a 5-alpha reductase inhibitor. So 5-alpha reductase inhibitor, what they do? They basically reduce the testosterone level, and once the testosterone level is less, the size of the prostate gland slowly and gradually reduces down. So what you need to understand is the tamsulosin, there are various others, tamsulosin, alphazosin, psilocybin, all those particular things are there. These are all the alpha blockers. Okay, what they do? They relax the bladder neck. Okay, so how is going to be their onset of action? They act within days. In 2 to 3 days, their kind of action comes. What about the side effect of that? The side effect of that is retrograde ejaculation, because the bladder neck is relaxed now. So what is going to happen? Whatever the ejaculation is there, that can come back into the bladder. So retrograde ejaculation is an important side effect of this alpha blockers. Okay, now coming to the 5-alpha reductase inhibitor. So what do we have? We have finasteride, dutasteride, all those particular things we have. We usually use dutasteride. Finasteride is not that kind of commonly used. So yeah, we have a 5-alpha reductase inhibitor. Now, how is going to be the onset of action? It's going to be slow. So the action starts by 3 months. The maximum effect, it comes around 6 months. That's fine. And what is going to be the side effect of that? So impotence or loss of libido, that is kind, because the testosterone level is basically going to come down. Not usually the kind of impotence. No, it is a loss of libido. That is one of the important side effects of this finasteride or dutasteride, whatever. Are you understanding my point? This is a medical management. But we also perform a surgery, which is TURP. I hope you understand the difference between TURBT and TURP. So if at all you're going through an endoscope and you're cutting the tumor, that is a TURBT, bladder tumor. TUR, transurethral dissection of prostate, that is a TURP. Okay, so if at all, okay, so this is very, very important. This slide is very, very important. What is an absolute indication of surgery? Okay, so you have started the patient with the BPH on the medical management, and now the patient is asking, by when are you going to continue this medical management? When will you perform a surgery or something like that? So if at all the patient has bilateral hydronephrosis, if at all the patient has bladder calculi, if at all the patient has bladder diverticulum, or if at all the patient is having recurrent urinary tract infections, or let's say there is a refractory urinary retention, the patient is not able to pass urine at all even after taking drugs, or if at all there is a bleeding, all these are the indications, absolute indications of surgery. So in other words, when the medical management is not able to kind of help this particular patient, then you perform a surgery in these particular patients. What is the surgery? It is transurethral dissection of the prostate. Okay, very important thing. Okay, so let's talk about this. Okay, so when we perform a transurethral dissection of the prostate, we have to use an irrigation fluid. All you need to understand is that for your MCQ purposes, which irrigation fluid cannot be used? So saline cannot be used. Which irrigation fluid is most commonly used is glycine. But that is not true for the real life. We also have something which is called as a bipolar TURP. In the bipolar TURP, all we use is this normal saline. We do not use glycine for that. Glycine is basically used for monopolar TURP. Okay. Now, there are a lot of complications which can occur. The two things which we are going to talk about, bleeding, it's fine, not a very big thing. Incontinence. How can incontinence occur? I hope you remember that I have drawn a figure where there was a bladder, there was a prostatic urethra, there was a membranous urethra, there was a bulbar urethra, there was a penile urethra, right? And here was the urogenital diaphragm. Okay, then I told you that, okay, where is the kind of sphincter? So internal sphincter is basically present in the bladder neck, the external sphincter is near the membranous urethra. When we do a TURP, this internal sphincter is basically destroyed. Our aim is to prevent the destruction of the external sphincter. How will you do that? There's no placard, right? There's no kind of signboard when you're doing a TURP. There's absolutely nothing over there. So how will you kind of prevent the injury to this external sphincter? Okay, if you injure this external sphincter, the patient is going to be incontinent, and then you are going to be in the court as a criminal kind of offense or something like that, right? What you need to understand, how will you kind of prevent that? For that, this is an important MCQ, guys. I'm not just trying to tell you a story. So you would have had a look at this particular MCQ. What is a distal extent of resection? That is, what is a verum montanum? So this verum montanum, this is basically present in the prostatic urethra. Okay, and your whatever the sphincter is basically present in the membranous urethra over here. Are you understanding my point? So if at all you resect only till over here, obviously you are going to protect the sphincter, right? And that is the reason why the distal extent of the resection of the TURP is your till the verum montanum. You do not go distal to the verum montanum. Are you understanding this particular point, guys? Yeah? Right. I hope you have understood this point. The another important thing which you need, retrograde ejaculation is going to happen in everybody. So you are cutting the bladder neck, obviously retrograde ejaculation is going to happen. Another important thing is the TUR syndrome. This is more common with monopolar TURP because you use glycine, and if at all the surgery is prolonged for a prolonged period of time, there is going to be something which is called as a dilutional hyponatremia, because whatever the irrigation is there, that is going to get absorbed into the blood, and that is going to get into your intravascular volume, and that is going to cause you dilutional hyponatremia. Understood this particular point, guys? I hope you have done. Okay, now coming to a very, very important topic. Now, the two topics which are absolutely important in your urology is undescended testes and testicular torsion. So please pay a very, very important attention over this. Undescended testes is very, very important. Okay, so as I told you that the kidneys, they basically develop in the pelvic cavity and then they ascend up into the abdominal cavity. So in the similar manner, this testes, they basically form in the retroperitoneum and then they descend into the scrotum, right? That is how the normally kind of thing taking place. But what can happen? The one scenario is that while coming down, these particular testes get arrested at one particular point of time. Okay, so this is what is called as an undescended testes. So there is a while coming down, these particular testes get stuck at one particular point of time. That is what is an undescended testes. What about an ectopic testes? In the ectopic testes, what is happening? This particular testes is deviating from its normal path and it is basically going to some other place. So that is what is called as an ectopic testes. So there's a basic difference between undescended testes and an ectopic testes. Undescended testes not reaching till the scrotum. Ectopic testes is basically deviating from its normal path and going here and there. Are you understanding my point? So these are the two basic things. What is the most common site of an undescended testes? The most common site of an undescended testes is inguinal canal. What is the most common site of an ectopic testes? That is superficial perineal pouch. Okay, so most common site of an ectopic testes is superficial perineal pouch. The most common site of an undescended testes is an inguinal canal. Two important MCQs, guys. Very, very important. It's a very important topic. Please kind of listen to it. High chance at least one question will come tomorrow. Okay. Now, how will the obviously child will not come, the child will be brought to you by the parents, right? So how will the child be brought to you by the patient? The mother will bring the child and say that, you know what, my child has an empty scrotum, that I was bathing my child and I noticed that the scrotum is kind of empty. That's fine. So that is how the presentation is there. A very, very important question. What is an investigation of choice? Okay, can anybody write in the comment box the most common wrong answer? Which, okay, can you please write what is a investigation of choice for undescended testes? The most common wrong answer which we usually get is an MRI. MRI is absolutely wrong. Not an investigation of choice. So the investigation of choice for this particular stuff is diagnostic laparoscopy. So investigation of choice for a non-palpable undescended testes is diagnostic laparoscopy. So let's kind of have a look at the algorithm. How do you manage a patient of a kind of a undescended testes? So you have, like, the patient has come to you. You try to palpate. The mother tried to palpate. The mother did not find any kind of testes. You try to palpate. If at all you are able to palpate, probably it will be in the inguinal canal. And then you explore and you kind of bring the testes down and you kind of stick it over there. Okay, but if at all you are not able to palpate, you're not able to palpate, then what you do? Then you perform a diagnostic laparoscopy. Now, after you perform a diagnostic laparoscopy, what are you going to do? You are basically going to follow. Like how will you reach to the testes, right? In order to reach to the testes, you will have to follow something. So what are you going to follow? You are going to follow the testicular artery. That is more important a landmark as compared to that of a vas deferens. Okay, so you either follow the gonadal vessels or the vas deferens. Gonadal vessels is a more important landmark. Okay, so you follow the gonadal vessels, and that is going to help you reach to the testes. So there are three scenarios which can happen. Either the gonadal vessels will take you the testes, and now you have localized the testes. That's great. Then you kind of plan your surgery, maybe 1 stage, 2 stage, whatever you want to do. If at all you find that the gonadal vessels are entering into the inguinal, like the deep inguinal ring. It means that the testes has crossed the deep inguinal ring and it has entered into the inguinal canal. Now it's your fault. You were not able to palpate it. Now you basically do the inguinal exploration, take the testes down and put it to the scrotum. But if at all you find a blind-ended vessel, it means that intrauterine, the testes had undergone torsion or some kind of an insult, and that particular testes is gone now. So there is no more testes. It means that the testes has become atrophied. That's, forget about it. Are you understanding my point? So this is how the diagnostic laparoscopy is going to help you. If at all you are able to localize the testes, you can plan it accordingly to the age and everything. But if at all it has entered into the deep inguinal ring, you have to do the inguinal exploration. Okay. Now the mother will say that, you know what, okay, the child is having an undescended testes, but what's that big a deal? Like what I should be worried about? So these are the possible complications which can happen. More risk of trauma to the particular testes, more risk of epididymoarthritis, that's fine. Sterility. Okay. Not usually with one particular undescended testes because other testes are still there. But if at all there is a bilateral undescended testes, definitely the risk of sterility is there. Okay, then torsion, yes, definitely. Indirect inguinal hernia usually is associated with that, and testicular tumors like seminoma can occur. Now let's talk about the sterility, guys. Okay, so what we need to understand is, go to the basics of your physiology. We have testes, we have your Sertoli cells, and we have a Leydig cells, right? So Sertoli cells, they basically produce your, they're the nurse cells for the kind of sperms, and the Leydig cells, they basically produce your testosterone. So these Sertoli cells are the one which are kind of responsible for sperm maturation, and at the same time this Sertoli cells are the ones which are more sensitive to the temperature. So what is the basic difference, right? In human, like in the males, the testes is basically present in the scrotum. Why? Why the God has made like this? Because our core body temperature is a bit higher, a couple of degrees higher than the external atmosphere, and that is why the testes prefer to be in a cooler atmosphere. That's fine. Now what you need to understand over here, the Sertoli cells are the ones which are more sensitive to the damage if at all the temperature is higher. And that is why the sperm maturation will be kind of an issue. But the Leydig cells will still function in a good manner, and that is why the testosterone levels will be normal, and that is the reason why the secondary sexual characters in these particular patients are going to be absolutely normal. Am I making some sense to you guys? So yes, I did not say that, you know, the patient will not have any male pattern voice or male pattern hair or something like that. The secondary sexual characters will be absolutely normal. What is the problem? The problem is with the kind of sperm maturation. I hope you have understood this point. Now let's talk about the management. So how do you manage this? So you have to perform a orchidopexy. Now what you need to understand, what is an ideal age of performing an orchidopexy? Can anybody write it in the comment box? So the answer is 6 months to 1 year. Earlier it was, let's say, 1 to 18 months, or like 12 months to 18 months or something, but the ideal answer is 6 months to 1 year. But let's say if at all the child comes to you at 3 years of age, 4 years of age, will you do an orchidopexy? The answer is yes. You will still do it. The chances of preserving the sperm kind of production is very, very less, but yes, you will still do an orchidopexy. What about if at all the child comes after 14 years, 15 years of age? You will still do an orchidopexy. You will not do an orchidectomy. Why? Because the child still needs testosterone, right? Maybe, yeah, the sperm is not going to be produced by that particular testes, but the testosterone will still be produced. But if at all the kind of patient comes at the age of, let's say, 40, 50 or something like that, probably you can just leave it like that. You don't need to do anything. Are you understanding my point? But yeah, if at all the patient comes to you with a testicular mass at, let's say, 40, 50, that can happen. Again, it will need 5 minutes of a discussion, so I'm not going to do it. All you need to understand is the ideal age of doing an orchidopexy is 6 months to 12 years. Even if 4 years, you will do an orchidopexy. Slight chance of preserving the fertility, do an orchidopexy. 14, 15, 16 years of, you will not be able to kind of prevent the sperm, but you have to kind of keep the testes inside the body because you are in need of testosterone. And why not leave it in the inguinal canal only? Testosterone is being produced because at the same time there was a risk of seminoma also, right? So if at all the testes is in the scrotum, it will be easier for the patient to palpate that particular testes. Okay. Now I'll just quickly go through this particular topic, which is a very, very important topic. Okay. So undescended testes, you have understood it. The most common site of an undescended testes is an inguinal canal. The investigation of choice is not MRI, it is diagnostic laparoscopy. What you do a diagnostic laparoscopy, you follow the testicular vessels, and depending on whether the testicular vessels are, you take your decision. These are all the complications which can happen. Secondary sexual characters are maintained because testosterone is maintained. Ideal time to do the orchidopexy is 6 months to 1 year. And yeah, that's pretty much it. Okay, right. Now let's come to the testicular torsion. Now what you need to understand is the patient is going to come to you with an acute scrotum. What do you understand by acute scrotum? Acute painful scrotum. The patient is going to come and say that, you know what, I have a pain in my like scrotum. You will examine. What are you going to find? You're going to find a enlarged scrotum. Okay, there are obviously going to be the pain in the scrotum. Now there are other conditions also. There is something which is called the torsion of the hydrated of Morgagni, but let's not go over there. There are two main conditions which can present in this particular manner. One is epididymoarchitis, another is testicular torsion. How do you distinguish between them? So there is something which is called as a French sign. What is this French sign? French sign basically says that if you lift the testes up and if at all the pain goes down, it is telling you that the patient is having an epididymoarchitis. But if at all you lift the testes up and if at all the pain increases, then the patient is having a testicular torsion. Are you understanding my point? So what is a French sign? French sign basically is trying to tell you that, you know what, if you lift the testes up and if at all the pain goes down, epididymoarchitis. If you lift the testes up and if at all the pain increases, that is a testicular torsion. Are you understanding my point? Very, very important. French sign, do not forget. Might come. Okay, so please do not forget it. Okay, so how do you diagnose this particular testicular torsion? It is clinical based. You can do a Doppler. Doppler is not mandatory. You can take support of a Doppler, but it is mainly a clinical diagnosis. Okay. Now, if at all there is a testicular torsion, obviously you have to perform testicular torsion is an emergency. You have to operate. I'll tell you within how much time you have to operate, but you have to operate, no doubt about it. Okay, so here you will kind of explore and you do I'll tell you what you basically do with the testicular torsion. This is surgery. For now, let's kind of say that, okay, all you are basically going to do is a surgery. Okay, just give me a minute. So I'll just keep on saying. My pen is getting charged a bit. I'll just keep on saying. So testicular torsion, what you basically do, you are going to do a surgery. What about epididymoarchitis? In the epididymoarchitis, what you're going to do, you are going to give this particular scrotal support and everything. You will give the analgesics, you will give the antibiotics. Okay, so that is how you're going to manage the epididymoarchitis. Okay. Now, if at all it's equivocal, like you are not able to distinguish on the clinical examination whether the patient is having epididymoarchitis or the patient is having testicular torsion, then what you're going to do, you can do a Doppler, that's fine. But even if the Doppler is equivocal, then you can explore. Okay, even if you have doubt, you can explore. Even if it is epididymoarchitis, that is still fine. But you cannot just ignore this particular testicular torsion. Okay, now what you do basically in the surgery, you basically derotate the testes. So the testes has, what is a torsion? Torsion means that the testes has twisted on its own axis, like the sigmoid volvulus. In the similar manner, the spermatic cord ke upar, the testes has basically rotated. So what you do, you detort it. Okay, you derotate it, and then you look for the viability of the testes. If at all the testes is viable, then it's great. What you perform is, you perform an orchidopexy. So this I'm talking about the testes which is affected at this point of time, right? But if at all it is not viable, if the testes has kind of become gangrenous, necrotic, whatever, then you basically perform an orchidectomy. So this is again I'm talking about the testes which is basically has undergone a torsion. What about the contralateral testes? Will you do anything to the contralateral testes? The answer is yes, because why does this testicular torsion occur? It happened probably because there was some kind of a congenital anomaly, maybe Bell-Clapper anomaly or something like that, inversion of testes or something like that. So there is a chance that the next time the testes can get tort, like a torsion can occur, and maybe the patient might not be able to reach the hospital, right? So no matter what you do with this particular testes, the contralateral testes has to be fixed. Orchidopexy has to be done. Are you understanding my point? So when you do a surgery, you will detort the testes. If at all the testes is viable, bilateral orchidopexy. If at all you detort the testes, but the testes is not viable, orchidectomy of this side and the orchidopexy of the opposite side. This has to be done. Are you understanding my point? I hope you are understanding, right? Right. So that is all about the testicular torsion. Ideally, it has to be operated within 6 years. You can preserve the testes till 24 hours, but ideally it has to be done within 6 hours. Okay, right, 6 hours is the golden period. Now, what is this? This is what is a hydrocele. We will not talk about the practical aspects of it, like the MS matter, that's fine. All you need to understand is, if at all there is a congenital hydrocele, what is the treatment for that? The congenital hydrocele, the treatment is not Jabuli's eversion or Lord's placation. It is herniatomy. Okay, it is herniatomy. Okay, please understand this particular point. It is like, it's always a herniatomy. Okay, so that is what you need to understand over here. What is this? This is what is a Fournier's gangrene. Okay, so what is this? This is what is a Fournier's gangrene. This is necrotizing fasciitis of the scrotum and whatever the soft tissue over there or something like that. Okay, so over here you have to do a debridement. Okay, so you have to do a debridement. All you can remember is that everything you basically cut out, but the testes are still viable. Why the testes are viable? So such a bad, right? Everything, soft tissue, off tissues, everything is kind of gangrenous, necrotic. Why the testes are viable? Remember the origin, the embryology of the testes. They start from the retroperitoneum. So the testicular artery is arising from the aorta. So the blood supply is basically coming from up, and that is why the testes are viable. Are you understanding my point? Okay. So yeah, that is what is a Fournier's gangrene. Just understand this. Polymicrobial. Okay, this is aerobic, anaerobic. Both are basically contributing to this. That's fine. Okay. Then we have a varicocele. This is a varicocele. All you need to understand, if at all they say that there's a dragging pain in the scrotum and there is a bag of worm feel when you are examining this particular scrotum, that is what is your varicocele. They are basically trying to talk to you about the varicocele. For the diagnosis, you are going to perform a Doppler, and on the Doppler, what are you basically going to look for is a retrograde flow of blood in the testicular veins. Okay, in the testicular veins. Okay, so yeah, the retrograde flow of the blood in the testicular veins. So that is what is a varicocele. Okay, dilated, tortuous, pampiniform plexus of veins. That is what is a varicocele. Okay, now what is this? Important images, guys. I have put it in the last, but these are very, very important. So this is what is your phimosis. This is what is a phimosis. This is what is a paraphimosis. What happens in the phimosis? In the phimosis, you're not able to retract. Kind of the prepuce. Okay, you're not able to retract the prepuce over the glans. What about the paraphimosis? In the paraphimosis, you are not, like, you have retracted the prepuce, but you're not able to reposition that particular prepuce back. Okay, so that is the basic difference between phimosis and paraphimosis. I hope you're able to understand this point. Okay, phimosis can occur because of a number of reasons. It can be congenital, it can be acquired. In the adults, it is basically because of the BXO, balanitis xerotica obliterans. If at all it is because of the BXO, always circumcision is needed. If at all it is a congenital phimosis, you can wait. If at all the opening is visible, if the meatus opening is visible, and if at all the patient is able to pass urine, even though there is a phimosis, you can wait till the age of 16 years. After that, you're able to kind of operate. What surgery? Obviously, circumcision. You are going to do a circumcision. So I'll just break this down. Phimosis, small kind of opening. If at all the meatus is visible, if at all the patient is able to pass urine, do nothing, wait till 16 years. Most of the cases it is going to resolve. If it doesn't resolve, operate at the age of 16 years. If at all phimosis, congenital phimosis, very, very dense fibrosis, like the patient is not able to pass urine and all those particular stuff, do a circumcision, neonatal circumcision, not a problem. Adults may, if at all the phimosis occurs, usually it is because of the BXO or something like that, definitely surgery is needed. Paraphimosis, again, why does paraphimosis occur? Interns and like the junior doctors are usually responsible for this. They put in a catheter, they retract the prepuce, they forget to bring the prepuce back. So what happens? The the prepuce that basically kind of swells up. There is edematous, and sometimes it can become very, very serious. It can even lead to the gangrene of the glands. It can actually lead to that. Okay, so it's very, very severe paraphimosis can actually lead to the gangrene of the glands. Okay, so are you understanding my point? So here, what you're basically doing is that over here in the paraphimosis, the treatment is dorsal slit, surgical treatment, or you can basically do the pinpoint and you can reduce that particular prepuce. Forget about it. Dorsal slit is the surgery, or phimosis, what you basically perform is a circumcision. Okay, here you basically perform circumcision. Okay, right. Now, what is this? This is what is your hypospadias. What is this hypospadias? Okay. In the hypospadias, there is a opening of the urethra on the ventral aspect. On the ventral aspect. So there are three things of the in the hypospadias. One is basically the ventral opening of the kind of urethra. Okay. Then we have the dorsal hooded prepuce, and then we have the penile curvature. Okay, so these are the three things which you basically have in the hypospadias. Okay, so that is what you need to understand. At least you have to recognize if at all the image is kind of shown to you or something. Now, this is again very, very important. What you are basically seeing over here, very important image, very, very important image. Okay, so this is what is an MCUG. What is this? This is a antenatal USG. Over here, what you are basically seeing is a keyhole sign. Okay, here what you're seeing is a dilated posterior urethra. And what is the diagnosis? Can you write it in the comment box? So we are dealing with posterior urethral valve, PUV. Okay, this is a PUV case. Okay, so what you're dealing with, this is a posterior urethral valve. Both these images are very, very important. Okay, MCUG and the antenatal ultrasound. So what is a posterior urethral valve? Posterior urethral valve is a condition where there is a fold of the kind of a mucosa which is extending from the verumontanum till the bladder neck. So basically there are three types of PUV. The most common type is the type 1. Okay, so the most common type is the type 1 where there is a fold of the kind of a verumontanum extending from the verumontanum till the kind of external urethral sphincter. Okay, so that is what you need to understand over here. Okay, so that is what is a posterior urethral valve. Okay, now what is the problem? Okay, so what is a valve? Valve basically allows you to pass any fluid or anything in one direction. So in the posterior urethral valve, what happens? The urine is not able to come out. But if you try to pass in a catheter, you will be able to easily pass in a catheter. So that is the basic problem in the posterior urethral valve. And that is why in the antenatal period, the mother will complain of oligohydramnios. There will be antenatal hydronephrosis. All those particular things is going to be happening in this particular patient. So back pressure changes on the kidney and the oligohydramnios. So that is what is going to be there. And ultimately, because there is going to be the oligohydramnios, the patients might have the Potter's facies and the Potter's sequence. That is what is going to happen. If somebody asked you important MCQ, well, this is a very important topic. I don't know why I put it at the last, but it's a very important topic. Okay, so most common cause of death in the posterior urethral valve is pulmonary hypoplasia. Pulmonary hypoplasia is the most common cause of death in these particular patients, guys. Okay, now for the treatment, you obviously pass in a catheter, and most of these particular patients will have a deranged creatinine. So what is going to happen? The creatinine is going to come down, and once the creatinine comes down, then you basically go in with the endoscope and you fulgurate these particular valves. So that is how you manage the patients of a posterior urethral valve. Forget about this blocks and cystoplasty, at least for tomorrow. Forget about it. Okay, forget about all these particular stuff. Just remember, pass in a catheter, let the creatinine come down. Once the creatinine is down, you basically go in and then you basically fulgurate those particular valves. Okay, I hope you're able to understand this point. This is the basic. Images are very, very important. Clinical history can be given to you. Type 1 is the most common type. And yeah, that is how you kind of manage it. Oligohydramnios, Potter facies, do not forget it. This was the image which was asked to you, like FMG 2-3 years back. What is this? This is a coronal papillae. Just remember this. Okay, this is kind of not a malignant condition. It's a benign condition. Nothing to be done. Conservative management, nothing to be done. Okay, what is this? This is a malignancy. Okay, so this is a penile cancer. Just a couple of points. What is the most common site of a penile cancer? The answer is glans. Okay, so the most common site of the penile cancer is the glans. Then it's the coronal sulcus, and then there is the penile shaft. So most common site is the glans of the penis. Okay. Usually the patients come to you very, very late. Okay, so that is what is kind of there over here. Okay, okay. Now we have the trauma, urological trauma. Do you want me to continue or should I just skip it? Tell me, guys, in the comment box. It will take around 15-20 minutes. 20 minutes के आसपास लग जाएगा. Do you want me to continue? Thank you, Rajesh Shukla. Thank you so much for your kind words. Yeah, I'll definitely try to do it for NEET PG as well. I'm also coming up with my own YouTube channel, so you can search for me and you can kind of subscribe to it if at all you wish. Yeah. Prepuse foreskin, please explain. Okay. Okay, prepuse versus foreskin, one and the same thing. Okay, buzz light year is one and the same thing. So prepuse and they're exactly the same thing. Okay. Right, guys. So what do you guys, do you want me to continue with this particular urological trauma? Okay. I'll just quickly browse through it. Okay. So let's skip this particular renal trauma. So these are the grading of the renal trauma. Okay, I'll just cover this. Okay, this is very, very important. Okay, so okay, let's cover the bladder injury and the urethral injury, and then we will kind of take it a wrap. Okay, so what about the bladder trauma, right? Okay, so bladder is an extraperitoneal or an intraperitoneal organ. So what you need to understand is that you have a urinary bladder, and then you have a fold of a peritoneum, which basically goes over the dome of that particular urinary bladder, right? So once the bladder is ruptured, it can either rupture inside the peritoneum, which is an intraperitoneal kind of bladder rupture, or it can be an extraperitoneal bladder rupture. Okay, now I'll just simplify this particular topic for you guys, and it is very, very important. The clinical based scenarios are usually asked on this, so please kind of understand this. Okay, now okay, so this is what is it. Now what you need to understand is, okay, why do you go and pass urine? Because you feel like passing urine. Why do you feel like passing urine? You feel like passing urine because you have an urge to pass urine, and that happens when your bladder fills up. So when your bladder fills up, it sends signals to the brain, and your brain basically sends signals back to you, and you basically go and pass urine, right? So so please understand, if you want to have the urge to pass urine, for that you have to have a distended bladder. Understood? Everybody understood this point? Now, if at all the bladder has ruptured, will you have an urge to pass urine? Because the bladder will not get distended, right? So if the bladder is not getting distended, there's not going to be any urge to pass urine. So it doesn't matter whether it is an intra kind of peritoneal bladder rupture or an extra peritoneal bladder rupture. Will these patients have urge to pass urine? The answer is no. That is a common thing. Are you understanding my point? I hope you have understood this particular point. So how will be the clinical scenario of these particular patients? The clinical scenario would be that the patient suffered from a road traffic accident. The patient has not passed urine for like last 36 years, and the patient has no urge to pass urine. So that is what is how the clinical scenario is going to start. Okay. Now there are two types of bladder rupture. One is a extraperitoneal bladder rupture. Another one is an intraperitoneal bladder rupture. Okay. Now extraperitoneal bladder rupture is associated with the pelvic fracture. That is something which you need to understand, which you need to remember rather. Okay. So pelvic fracture is associated with most of the cases of the extraperitoneal bladder rupture. Understood? Let's first look at the extraperitoneal bladder rupture. So what is the mechanism of injury? Trauma, pelvic fracture leading to the extraperitoneal bladder rupture. It is also associated with the proximal urethral injury. So what happens is, obviously, if at all there is a kind of a bladder injury, the bladder injury can involve the proximal urethra as well, right? So yeah, that is what is your proximal. So it is going to involve the proximal urethra as well. So sometimes, along with the extraperitoneal bladder rupture, there is a proximal urethral injury also happening. It leads to the deep perineal hematoma. Okay, now let's go back to this particular image, guys. Okay, I'll just draw one image for you. So let's say if at all this is a bladder, and this is the kind of a prosthetic urethra, this is the urogenital diaphragm, this is whatever your kind of penile urethra and all those particular stuff. Okay, so what you need to understand, whatever the area is above this particular urogenital diaphragm, that is what is your deep perineal pouch. Whatever the area is below this urogenital diaphragm, that is what is your superficial perineal pouch. Are you able to understand this particular point? So if at all there is an extraperitoneal bladder rupture, there is going to be the blood in the deep perineal hematoma. Okay, there's going to be a deep perineal hematoma. Are you able to understand this point? So there is a deep perineal hematoma associated with that. Okay, now if at all there is an extraperitoneal bladder rupture, how are you going to manage it? So you just put in a Foley's catheter and you decompress that particular bladder. So once you decompress that particular bladder, what is going to happen? The edges of the bladder are going to come closer to each other, and over a period of time, the healing is going to take place. So you keep the Foley's catheter for 12 to 14 days. After 12 to 14 days, you remove the Foley's catheter. Are you understanding my point? So this is the extraperitoneal bladder rupture. I'll just summarize it. Obviously, the patient is not going to have any urge to pass urine because the bladder is not getting distended. That is common for extra and intra both. In the extraperitoneal bladder rupture, it is associated with the pelvic fracture, and the patient is Yeah, going to have a deep peritoneal hematoma, that is fine. For the management, what you have to do is you have to just put a Foley's catheter and allow the bladder to heal. Now, will the bladder heal always? The answer is no. If at all, let's say there is some bony fragment or the pelvic bone is kind of chipped into it or something, or after 12 to 14 days also the bladder healing has not taken place, then you will have to operate and you have to do the bladder kind of repair. Then you have to do the surgery. But most of the cases will respond to the conservative management. Understood this particular point? Now, coming to the intraperitoneal bladder rupture. Now, what is the mechanism of the intraperitoneal bladder rupture? So what happens? I told you that the bladder is usually extraperitoneal, but let's say if at all there is an over distended bladder. In this scenario, what is going to happen? The peritoneum covering will be to a more extent. Okay. Now, if at all the patient is having an over distended bladder and somebody comes and gives them a very blunt injury, like blunt force into the suprapubic region. So what is going to happen? This particular bladder might rupture up. That is one scenario. Another scenario is if at all there is a penetrating injury. So penetrating injury or a blunt trauma over a over distended bladder. These are the two things which you have to look for in the clinical scenario, which will prompt you towards intraperitoneal bladder rupture. Are you understanding my point? So what is the mechanism? It is either a blunt trauma over the over distended bladder or a penetrating injury. These are the two causes of a intraperitoneal bladder rupture. Obviously, it is not going to be associated with any form of a urethral injury. Urethra is very, very far away from here. It leads to peritonitis. Obviously, ultimately the urine is going into the peritoneal cavity. It is going to irritate the peritoneum and the patient is going to land up into peritonitis. And what is the basic rule? Whenever the patient is having a peritonitis, what you basically do, you have to do something which is called as a exploratory laparotomy. So what is the management of an intraperitoneal bladder rupture? Exploratory laparotomy, and you repair that particular bladder. Everybody have understood this? Extraperitoneal and intraperitoneal bladder rupture, very, very important, guys. Clinical scenarios can be asked to you on this tomorrow. It's very, very important for you. Okay, I hope you have understood this particular point. Okay, if any doubts, please ask. Now, coming to the urethral injury. So I told you that in the bladder rupture, what is going to happen? There's going to be absolutely no urge to pass urine. What about the urethral injury? In the urethral injury, what is there? Bladder is absolutely fine. So bladder is going to get distended and the sensation will be passed to the brain and the brain is again going to pass the sensation back and there is going to be urge to pass urine. There is going to be urge to pass urine, but what is going to happen? The patient will not be able to pass urine. So here the question will start with the patient suffered from a blunt like road traffic accident, let's say 12 hours back or 8 hours back or something like that. Now the patient has brought to the emergency. There is blood at meatus. The patient has a severe desire to pass urine, but the patient is not able to pass urine. Are you understanding my point? So this is how the question, if at all they want you to answer a urethral injury, is going to start. Understood? Now, if at all this is a scenario, they will ask you what is the next best step which you are going to do. Now, there is a bit of a controversy over here. Now, some books say that, a single gentle attempt of catheterization can be tried. Yeah, it can be tried. It's fine. But what is the problem? But if at all you try a single gentle attempt of a catheterization, a partial urethral injury may get converted into a complete urethral injury. Are you understanding my point? So maybe the catheter is not going to go into the bladder and the partial injury can get converted into the complete urethral injury. So if at all that is not given in the option, then what you can do is the next option what you might have is a RGU. So yes, ideally you should perform a retrograde ureterogram. So if you perform a retrograde ureterogram, you will know for sure whether there is any urethral injury present or not. So if at all there is a urethral injury, so yeah, please understand this. Do not try to catheterize this particular patient because you might end up kind of converting the partial into a complete injury. Perform a retrograde ureterogram if at all that is available. That is going to tell you if at all there is no urethral injury. Urethral injury is absent. Forget about it. Just pass a Foley's catheter, keep the Foley's catheter for 3 to 5 days, and then remove it. It's all fine. Why would the patient wouldn't have been able to pass urine? Because of the acute trauma, there would have been some edema, the patient would have been in pain and XYZ reasons. That is why the patient might not have been able to pass urine. But there's no urethral injury, which has been proven by the retrograde ureterogram. That is not important. Important is, if at all the retrograde ureterogram shows that there is a urethral injury, do not try to pass a catheter. Do a what you call as a suprapubic catheter. Place in SPC. Okay. Right, so place an SPC because it can be either an anterior or posterior urethral injury. Forget about it. We will talk about what is the difference between them. But yeah, that is something which you need to understand. So what I'm trying to tell you over here is that how the clinical scenario is very, very important. How the clinical scenario is going to be asked. Patient came with a road traffic accident. 10 years back. Now the patient is having a severe desire to pass urine, but the patient is not able to pass urine and there is a blood atomeatus. What is the next step? RGU, retrograde urothelium. If at all there is a kind of injury, like if at all, let's say there is a injury, urethral injury in the retrograde urothelium, what you do? You place an NSPC. Now the important point comes that how do you kind of distinguish between the anterior urethral injury and the posterior urethral injury? What is an anterior urethra? Penile urethra and the bulbar urethra. What is the posterior urethra? Membranous urethra and the prostatic urethra. Okay, so that is the basic difference. Now let's talk about the posterior urethral injury and the anterior urethral injury. Okay, now posterior urethral injury, as I told you, it is associated with the pelvic fracture. We have already talked about that. Okay, so extraorbital bladder rupture and the posterior urethral injury then can go hand in hand, and they both are associated with the kind of a pelvic fracture. Okay, now if at all there is a posterior urethral injury, let's go back to this particular image. Where will the blood accumulate? The blood is going to accumulate in the deep perineal space, deep perineal pouch only. Okay, so that is what you need to understand over here. It is going to accumulate in the deep perineal space or the deep perineal pouch. Now, if at all there is a posterior urethral injury, very, very important. The prostate can be high riding. Now, what you need to understand is that we have a prostate gland over here. Okay, I'll just take these particular markings out. So what you need to understand over here, that here you have a prostate gland. Okay, what do we have? We have a prostate gland over here. Now, if at all there is a posterior urethral injury, this part of the prostatomembranous junction, from there is an injury and the prostate can be pulled up. So when you do a digital rectal examination, there is a chance that you might not be able to palpate the prostate, or the prostate may be high lying. What is this called? This is referred to as a Vermeulen sign. Okay, what is it called? It is called as a Vermeulen sign. Okay, it is called as a Vermeulen sign. The high riding prostate is referred to as a Vermeulen sign. Are you understanding this particular point? Okay, and associated with the extra. Okay, and yeah, this is associated with the extraperitoneal bladder rupture. We have already talked about it. So pelvic fracture, deep perineal hematoma, high riding prostate, Vermeulen sign. These are the features of the posterior urethral injury. Now coming to the anterior urethral injury. So what is the mechanism of injury in the anterior urethra? It is a straddle injury. So you would have seen the images where there is a pothole injury, where the pothole basically comes and hits the person in the crotch, or let's say there is a kind of a bicycle bar where the patient, person is driving and the person basically kind of accidentally falls over that, and the urethra is basically compressed between the bar and the pubic symphysis. So these are the mechanisms. This is called as a straddle injury, and that is what is the mechanism of your kind of anterior urethral injury. Okay, now here the hematoma is going to be in the superficial perineal pouch. Okay, so here the patient is going to have a hematoma over here. So this is a hematoma in the superficial perineal pouch, which appears outside as a butterfly hematoma. Okay, so here there is going to be a butterfly hematoma. When you do a digital rectal examination, the prostate is going to be normal, so that's not an issue, and it is not associated with bladder rupture. Are you understanding this particular point, guys? So this is all about the anterior and the posterior urethral injury, which you need to understand over here. Now, lastly, what about the management? Okay, so obviously you are going to put an SPC. Let's kind of simplify that. Okay, forget about this. What you do, you basically put an SPC, send the patient home, call the patient after, let's say, 3 months. Okay, so whatever the healing has to be taken place, it would have taken place. Now you can either perform a RGU, MCU again, or you can block the catheter and you can ask the patient to pass urine. If at all, okay, obviously you will perform an RGU, MCU, and if at all in the RGU, MCU, everything is normal, just remove the SPC and it's done. But most of the times, the patient will develop urethral stricture. And now you have to just treat that particular urethral stricture. That's all about it, okay? So how do you do that? That is the urethroplasty and all those stuff. That is a different thing. All you need to understand is, put an SPC, send the patient home. After the patient comes, usually we call the patient after 3 months, 6 months, whatever you want to call. You do an RGMCU. If at all there is a stricture, treat that particular stricture. So that is about the urethral injury. These two are very, very... Okay, what is this particular image? What is this particular image, guys? This is a again, a very, very important image. Okay, this is an extraperitoneal bladder rupture. Okay, so this is what is called as a flame-shaped kind of extravasation of the dye. So this is a cystogram. This is a extraperitoneal bladder rupture. What is this? This is an intraperitoneal bladder rupture. I hope you're able to appreciate that the dye is basically present in between the loops of the bowel. So this is an intraperitoneal bladder rupture. Understood, guys? Yeah. So that is all about this. Okay. So the basic difference between bladder rupture and the urethral injury is bladder rupture, no urge to pass urine. Urethral injury, severe desire to pass urine, not able to pass urine. And other things, I hope you have understood it, right? Okay, guys. So that's, I think, pretty much it. I hope you liked this particular session. I hope you enjoyed this. All the best for your exam. And if you're not an FMG student, I'm glad that you stayed back and you listened to this. Do remember, take whenever you give an exam, maybe tomorrow, later on, whatever, take things one by one, give your 100% to whatever the question you're solving. And yeah, that's pretty much it, guys. See you around. I will be around in one way or the other. You can follow me on my own channel, or I will be in and around over here as well. And yeah, thank you so much. Thank you so much for staying with me, and I hope you like this particular session. I'm here for, let's say, 2, 4, 5 minutes more if you wish to ask me something or something. Yeah. And all the best, guys. Do well. Do let me know. And yeah, do let me know. Yeah. I'm here for a couple of minutes more if you have any doubts, if you wish to ask me something. Yeah. Sutures. What do you want to know about sutures? Sutures, again, it's like I've covered a part of it, but it's a very broad topic. Sutures revision. Very, very broad topic. Any particular thing you want me to revise? We've already covered. Like, I don't know whether you. It's okay. So, Vical basically lasts for around 3 to 4 weeks. PDS basically lasts for around 180 days. So that is what is the, like, that is why it is called as a delayed absorbable suture. Non-absorbable are non-absorbable, that's fine. Catgut basically lasts for around 7 to 10 days. So yeah, that's what you need to understand. Okay, so when do you do a craniotomy versus a burr hole? So what you need to understand is that if at all there is an extradural hematoma, okay, if at all there is an extradural hematoma, in that particular scenario, you can do a burr hole, okay? So because it is a bleed from the meningeal artery. So over a period of time, the meningeal artery, the bleed, it usually stops. If at all there is an acute SDH, in that particular scenario, epidural hematoma. So it also depends on how much of the blood has been accumulated over there or not. So in the chronic subdural hematoma, it is always a burr hole. That is what you basically do over there. In the chronic kind of SDH, in the acute one, it depends on the shift, like whether how big is the subdural hematoma and whether the kind of the things have kind of shifted or not, or something like that. Okay. But the EDH, it is usually a burr hole. That's what you need. And if at all there is a, let's say, cerebral contusion, okay, so in the cerebral contusion, it depends on whether there is any intraparent, like again, like the midline shift, if at all it is very high, then you perform a decompressive craniotomy. That is what you basically do. In the chronic SDH, it is always a burr hole. Rest, you basically depend on how much is the. Okay, guys, I'll just take leave now. And yeah, if you, I will be in and around. So yeah, do let me know how your exam goes and all those particular stuff. Yes, that's pretty much it. Okay. Thank you. Thank you so much. Bye bye. Take care. Do follow me at a couple of places. You can follow me up. And yep, started a YouTube channel. I've just put one video over there. Do show love over there. I'll put my own things over there as well. Yeah, in the EDH, you can do a craniotomy. Okay, so if at all that's a very, very big thing, you can perform a craniotomy as well. So usually it is acute EDH, you usually perform a craniotomy. In the SDH, it varies. In the chronic SDH, you always perform a kind of a burr hole. So in the EDH, if at all you have to choose between the two, you can perform something which is called as a, yeah. Okay. Thank you.